especially for the people who are watching us online. I'm Dr. Gautam Zaveri, the president of the Bombay Orthopaedic Society. I welcome all the delegates seated with me in this auditorium today in Bombay at the Jupiter Hospital. And I take this opportunity to welcome each and every one of the centers at Gwalior, at Ajmer, at Jalandhar, in Delhi and in Lucknow. Welcome to this program, the live or the re-live Pediatric Orthopaedic Symposium. I'm aware that as a specialty, pediatric orthopedics is a relatively smaller specialty and attracts really dedicated people who are there, who love children and want to make a difference to their lives. And it is this, among all of the orthopedic specialties, it is this specialty of orthopedics which requires probably the most dedication and the most sincerity in practice. Today, the Bombay Orthopaedic Society has put together a wonderful program with the top BOS faculty. We've got close to 10 pediatric orthopedic surgeons from all over India or all over Bombay who will be demonstrating a series of surgeries. The morning session will be dedicated to dealing with cold orthopedics. And in the afternoon, we will have pediatric trauma, which is probably more interesting to the average orthopedic surgeon. The session will go as such. Each case, one of the faculty who is there will come and present the case over a period of 5 minutes. What was the history? What was the examination findings? What is the diagnosis? Why? What is his treatment plan? And why is that he's doing the treatment plan? Then over the next 10 to 15 minutes, he will show the surgery live, he or she. And following that, there will be a discussion session. The discussion will be open to not only people from here in Bombay seated with me, but to all the centers over there. I welcome each and every delegate, every moderator in all these 5 centers across India. And I give a special thanks to the organizing team from Intas Pharmaceuticals who have done a wonderful job of organizing this event, not only in Bombay, but as I can see from the preparations everywhere at each and every center across India. Today's Pediatric Orthopaedic Symposium will be convened by Dr. Binoti Sheth. Dr. Binoti Sheth is a professor of orthopedics and a dedicated pediatric orthopedic surgeon at the Lokmanya Tilak Municipal Medical College, also called very commonly as the Sion Hospital. She's been prolific and she has written a number of textbooks on general orthopedics and more specifically on pediatric orthopedics. So we are very proud to have Dr. Binoti with us today to guide us and do this symposium. Along with Dr. Binoti Sheth, there are 2 young pediatric orthopedic surgeons from Bombay who are the co-conveners. Dr. Avi Shah, who practices at the SRCC hospital and a number of other hospitals in the southern part of the city, which primarily caters to the rich people of the city. And I'm told Avi, his father met me yesterday and he told me that Avi now is only specializing in pediatric hip. So maybe it is pediatric hip. And then we have Chintan Doshi, who comes from my part of town, the northern part of town, where all the patients are relatively poor. And Chintan, of course, spends a lot of time at the Municipal College in Bombay, called as the Rajawadi Municipal Medical College and Hospital, where he does a fantastic job of treating pediatric trauma, and he actually runs a lovely CTEV clinic over there also. So welcome all. And now, without much ado, I'm going to hand over the mic to Dr. Binoti to carry it forward.
Thank you, Dr. Gautam Zaveri. And I welcome everyone here in Mumbai as well as all across the country. And we hope that the numbers will increase as Sunday morning starts and we start with this terrific, wonderful academic feast today. So Dr. Gautam Zaveri has already introduced you all to the format. And we have 14 surgeries which are going to be demonstrated, real-life surgery, which we've recorded and will be discussed by the respective faculty. We start with initially the developmental and congenital conditions, and then followed by that, we will have the deformity corrections, which all of you see even as general orthopedic surgeons in your OPD, patients presenting with elbow deformities and other problems. And post-lunch, we will have some interesting trauma session. So we have a team of eminent pediatric orthopedic surgeons from Mumbai, and we have our delegates from all across the country who are also attending with us a 7-day Bombay Orthopedic Society basic pediatric orthopedic course. So they all are welcome from the various parts of the country. So without wasting time, we start with the first case, which is SCFE, which is slipped capital femoral epiphysis, which is a special condition which we see mainly in adolescent children. And this surgery done by Dr. Mandar Agashe and his colleague, Dr. Avi Shah, and Dr. Avi Shah will present on behalf of Dr. Mandar. So welcome, Avi.
Thank you. Good morning, everyone, and thank you so much. So Mandar couldn't be here today, so I'm going to be presenting a video for him. So this is the in situ fixation for mild slip capital femoral epiphysis. It is one of the gold standard techniques and is standard of care all over the world. So it's a very important technique of not only most pediatric orthopedic surgeons, but even our regular general orthopedic colleagues should know, because this condition does present to most people, and it is always treated sometimes akin to fracture neck femur type 1 at times by our adult colleagues. So this condition is a little bit different and needs a little bit more nuance as compared to treating other fractures. So we'll see this. So the patient. So this is a 14-year-old male child. This is the standard type of patients that we see. They're usually 10 plus, 12 to 16 years in range, adolescents. Majority of them are big build. Some have obesity. They usually present sometimes with a mild pain in the groin. A lot of them present with just pain in the knee, but the hip is missed. So make sure if an adolescent is presenting to you with a knee pain, don't just start thinking of sports injuries and other things of the knee. Always check the hip in these children as well, because a lot of the times this condition is missed as just knee pain, and the patient is sent home. So these patients present with a slight out-toe gait, and in a mild variety may just have mild groin pain and a small limp. But other than that, they may not be very symptomatic. And this condition is has not started since one day. It's a gradual onset, and if you go back in history, a lot of them have groin pain since couple of months, which gradually increases over the time. If it's a stable variety, a lot of these patients will come to your clinic in a walking and just complaining of groin pain. But if it is unstable and in a severe variety, these present to you in a wheelchair majority of the times. So in this child, you can see on the left side, we have the AP and frog lateral. Always make sure to take two views. A lot of the times we see patients who have just had a AP view, and then this diagnosis has been missed, especially when it's a mild variety. So knowing SCFE, we know that the neck shifts anteriorly. It's not the epiphysis. The epiphysis stays in position, but it is relatively posterior inferior to the neck. So here you can see there is widening at the physis. And if you draw what is known as the Klein's line, that is a line along the superior border of the neck, in the normal hip, you see it cuts across the capital epiphysis, but here it does not cut. So this shows that there is a mild slip capital femoral epiphysis. If the deformity is more severe, you can see the capital epiphysis shifts more lower. So now, as I said, the in situ pinning is the gold standard. The conventional method can be of a single screw, which is perpendicular to the physis. And the oblique screw method or the universal entry method. This oblique screw or universal entry method has been recently published and also been published by one of our colleagues, Dr. Prasad Gurneni, who said it is a much easier way. So now again, positioning. Positioning can be done either on a fracture table or supine on a radiolucent table. If at all you're using a fracture table, be very, very careful. It is a tendency of our team members to treat this as a fracture neck, femur, and IT. And as soon as you put this on the table, our technician tends to internally rotate the foot because that is what he is used to. Please do not ever do that in this condition. That increases the risk of avascular necrosis. So here, if you see, the foot is kept in the position of what the leg wants to be in. Either it is a neutral in a mild slip or in the external rotated position it is. Do not ever internal rotate, and no attempt at reduction should be made. So there are a lot of papers who talk about serendipitous reduction. That means when the patient is taken under anesthesia, a mild reduction does happen because of the anesthesia, but no forceful attempted reduction that you would do in fractures should be ever done in this condition. So fracture table is good for people who are doing it initially because it's easier to take X-ray views of the hip in both planes. A radiolucent table sometimes can be difficult for people who are not used to doing it regularly. Then the hip is painted and draped and you get a good C-arm image, AP and lateral view to see the position of your hip joint. So here you can see, because it's a mild variety, you can see the AP view and you can see in lateral view. If you see the difference between the pre-op X-ray and the C-arm image, you can see there's a mild serendipitous reduction, which does always happen. It happens on its own. So then once we get these images, we mark with the guide wire. So here Mandar has planned to put 2 screws. So there is a debate in literature. You can use 1 screw or 2 screws. Some of our colleagues prefer to use 2 screws in much heavier children who are more obese and bigger. They feel it gives much more stability. Otherwise, 1 single screw, if perfectly placed, is good enough. Biomechanically, yes, 2 screws is better. But overall, in literature, there is no difference in results with single versus 2 screws as long as the position is perfect. So here we mark the guide wire in the AP view. You can also mark it in the lateral view, but sometimes it is difficult to mark in the lateral view. So normally, if you mark in the AP and lateral view, here, as with adult trauma, your entry is not perfectly lateral. It is slightly more anterior because, as we know, the slip is posterior inferior directed. So your entry point is slightly more anterior on the neck, but it does not cross the intertrochanteric line on the C-arm image. So once you have confirmed your position in the anterior view, so here you can see it is slightly anterior on the neck, not perfectly lateral. You put the guide wire inside and make sure it is perfectly centered through the physis. So like we discussed, one way is the entry point should be more anterior and should be perpendicular to the growth plate. But majority of the times it is very difficult to get this entry point because it's very, very anterior. It is very difficult to get that trajectory in a lot of patients. So that is why a lot of us now use the universal entry point. So the whole point is you can enter in an oblique manner, but it should enter perfectly center in the capital epiphysis when the screw inside. So here one screw the guide wire has been placed inside and the sizing of the screw is done. And similarly, the second guide wire has been placed inside, which will be parallel to the original, the first wire to get a good hold. You can see here again, entry point is AP. So make sure your entry point does not cross beyond the intertrochanteric line because we know the capsule attaches till the intertrochanteric line. We don't want our screw head to be intracapsular. We want it to be extracapsular. And secondly, if you go too anterior, the screw head can also cause impingement in flexion, internal rotation. So we need to take care of that as well. So what screws can we use? So here Mandar has used a cannulated cancellous screw 6.5, 16 threaded. You can use 32 threaded as well, or fully threaded screws as well. So literature, there is again debate of which screws would be ideal. So here no washers are needed. We are not looking for compression at the growth plate. We are just looking for fixation. Most literature says fully threaded screws are easier to remove later, but you can use 16 or 32 threads. We need to make sure at least 3 to 4 threads are across the growth plate. Otherwise, you will not have enough fixation, and your screw should be short of 5 to 10 from the chondral junction. So once the screws are tightened and placed inside and confirmed on both the views, you can see here, now both the screws have been tightened and confirmed. You remove the guide wires. Then we do something which is known as a live fluoro check, because we need to make sure the screw is not out in any direction. So we remove the boot from the fracture table. We flex, internal and external rotate the hip, and in no view the screw should be intra-articular. Piercing the screw or the guide pin, if it goes intra-articular, increases the high risk of chondrolysis. So be very careful. Your guide pin also does not pierce through the chondral articular surface as well as the screw threads. And a wash and an absorbable suture stitch is given, minimal closure and dressing. So the child post-operatively usually is kept non-weight bearing for, or partial touch to weight bearing for 6 weeks. Hip range of movement is started from day 1. We don't allow the child to do any sports activities until we see the healing of the slip capital femoral epiphysis, and majority of the times these screws are kept inside for lifetime. Very rarely they are removed unless we find there is some screw irritation or impingement. So this is this child doing well, and at 6 months follow-up, you can see the SCFE has almost healed. The neck almost partial remodeling has already started. You can see on the frog lateral view, there is a mild cam bump which is still there. So in some individuals in mild variety, this cam can still remodel. So normally our algorithm now is, once we do the pinning, we flex and internal rotate the hip. If on flexion and internal rotation at the time of pinning, if internal rotation is less, means less than 10 to 15 degrees, we may add an osteoplasty at the same sitting, be it mini open or arthroscopic based on your surgical skills, or you can come back after a month or 2 and then do it in a second stage. In younger individuals, at times in mild slips, in literature and in our experience, we have seen there is some amount of remodeling. So we may not be very aggressive in doing those procedures in these individuals.
Thank you, Avi.
Yeah. So just the last slide. So these are the key points. No close reduction. It's incidental or positional. It can be either 1 or 2 screws, 6.5 fully cannulated or fully or 32 oblique or universal entry point is preferred because it's easier. Perfect perpendicular is difficult, and just be careful to pick up these conditions and treat them well. Thank you so much.
Thank you, Avi. So this thing is open to the house. Can we see to the house? Anybody has any questions regarding this procedure, the technique? So let me just start off. Avi, you've been putting these screws through the physis.
Yes.
So are you worried at all about obviously you want that physis to close.
Yes.
But what are the resultant deformities? Do you get shortening? Do you get any?
So in older individuals, we do not get any deformity. Majority of the times, these children present at age 12 to 16. Most of the capital epiphysis growth is gone. So we just want the growth plate to close. So we don't get any deformities. But if this condition presents in children younger than 10, that is where we see a lot of deformities. Even though we do in situ pinning, we want to stop the growth plate. But in younger children, we do see coxa breva, we do see mild coxa vara, we do see a greater trochanteric overgrowth. So these are still issues which we are trying to solve. So in younger individuals, we do have different implants. We do have growing screws which are now available in the market, which elongate as the child grows. But as with innovation, it is still not completely there in literature as to the results. But in younger children, if at all you see an SCFE, always please do a metabolic workup. Majority of the time are associated with endocrine issues, because very rarely a young child will get an SCFE. Older children as well, even though they are getting it, the SCFE is not big secondary to a trauma. Majority of them have thyroid profile which is deranged or low vitamin D which is associated. So we always get these blood tests before doing any surgery on these children.
Lovely. Thank you. Any questions? Ajmer, Jalandhar, Delhi. Any questions for Dr. Avi?
Yeah, from Jalandhar. Sir, do we do any prophylactic pinning on the opposite side once we understand it's a hormonal problem?
Yeah, so the criteria for prophylactic pinning again depends on the age and skeletal maturity. In younger children with endocrine issues, we know there is a high risk of the other side also slipping. So there we will do a prophylactic pinning. If we feel the child is older adolescent but has thyroid or vitamin D, we may or may not do a prophylactic pinning based on the skeletal maturity. If I know growth remaining is less than 2 years and the Oxford hip score is high, we may not do a prophylactic pinning. We will observe these children, but we will tell the family as soon as your child may complain of mild groin pain on the other side, you need to urgently come back. Again, with prophylactic pinning, literature says, oh, it is very easy to just put one screw. There are 20% risk of having AVN and chondrolysis in the normal prophylactic pinning hip as well. So it is not a completely innocuous procedure. So you need to have a conversation with the family, because a lot of the times they will ask, why do you want to put a screw in the normal hip when the problem is in the other side? So endocrine issues, younger child, skeletal maturity is less, lot of hip growth remaining, consider prophylactic pinning if needed.
Any other questions anywhere else?
Just for the benefit of the house, if you can just tell them which conditions of SCFE this is not to be done and you go for the safe surgery.
Yes. So SCFE, we have different varieties. So simple way is putting, we have a stable, we have an unstable variety. We have a mild, moderate, and severe based on the Southwick's angle. Anything less than 30 is mild, 30 to 50 is moderate, anything more than 50 is considered severe. So in most literature and in most hands, the mild and moderate varieties, the standard of care all over the world for most general orthopedic surgeons is in situ pinning. Severe variety, in situ pinning, is extremely difficult because the head is toppled almost more than 50-60 degrees. You really have to go very anterior. It is not easy at all to do in situ pinning in a severe variety. That is where we have different methods, such as the Parsh method in an acute setting, or a safe surgical dislocation method, capital realignment technique. In those techniques, again, in situ pinning for everyone. First, if you're not trained in those other techniques, better is always do a in situ pinning and transfer them to a person who will be able to do those procedures, then trying those other procedures and causing complications in this hip, because avascular necrosis and chondrolysis risks are extremely high.
So Avi, for the benefit of the delegates, can you just elaborate what are the routine preoperative investigations you do, and which are the conditions in which you would consider prior referral to an endocrinologist?
Yeah. So the routine which I do, one is your routine blood work, which you do your CBC, triple L, whatever you do for your surgical. I always get a thyroid profile done and a vitamin D, alkaline phosphatase, and calcium done. So we have seen majority of the times vitamin D is low. Just for low vitamin D, normally we don't refer to the endocrinologist, but we do start them on medication. But if a thyroid profile is deranged, we definitely, we have seen a lot of these children having deranged thyroid profile. So then we get an endocrine opinion. So, and especially other endocrine opinion is if we are seeing an SCFE in a child younger than 10, then definitely they need an endocrinologist or a nephrologist, depending on why it has happened, to opine as to what is happening with the child.
One more question regarding the implant. Preference for SS screw versus titanium screw. What do you think is
So
better?
preferably SS. Titanium has bony ingrowth. So if at all you want to do another surgery, like pinning was done and it is still not perfect and the child has come with impingement, you want to treat impingement, the titanium screws are extremely difficult to remove. So preferably it is SS. In SS, again, it can be partially threaded or fully threaded. Again, between them, fully threaded are said to be easier to remove as compared to partially threaded, but no using washers at all.
Other very technical question while placing the guide wire. Everyone would like to know
Yeah.
where you want to be, center of the neck, center of the head, center of the physis. Like which is the
So-
if one single.
Yeah, so
Right.
you can be oblique in the neck. That does not matter. As I said, we have different ways of entering. But if you see the physis, so one is if you get it ideal, your ideal trajectory should be that your screw is coming perpendicular to the physis. That is the ideal position. But majority of the times that may not be possible. So you can be slightly oblique in your trajectory for your screw or guide wire, but you should be perfectly center in the while crossing the epiphysis into the capital epiphysis in both AP and lateral plane. So as long as you're entering in the, if you see a ball, your aim is to be in perfect center of that ball. You can come in slightly oblique or straight. That is absolutely fine. But you need to be perfectly center. If you're too superior or inferior, we have seen these heads spinning off, and even with the screw in follow-up, we have seen these heads continue to slip. So you need to be very careful with that. It is a simple, small procedure, but if you don't do it right, it does have high complication rates as well.
Sir,
Do we have any other question from here?
so is there any guideline as to after what duration the screw can be removed?
So as I said, normally we do not remove any of these screws because we want them to be there till the entire growth plate is fused. And most of the times these screws don't cause any issues. So like a mild variety and all these screws will never cause any issues. So we usually tell them to forget about it. But in conditions where it is moderate and severe, it is a severe deformity, your entry point is more anterior. In the long run, these screws as well can cause impingement and problem, and can cause if you want to do any secondary procedure, it can come in your way. So those are the times we may think about removing, or you can remove it once the maturity is completely gone. If you want to make it easier for your arthroplasty colleague, if at all ever in the future this has to be done, but to be honest, it does not come in their way that much. It can be easily removed.
Sir, and last query, sir. In case of valgus slips,
Yes.
is there any specific tips or guidelines?
So valgus slip is rare. The one feature in valgus slips, lot of these children are thin. So like when we talk about SCFE, we say, oh, all are obese and big, high BMI. Valgus slips are seen in a lot of children or young adolescents who are extremely thin. So valgus slip, the treatment is the same. Again, it is not easy to pin, but again, in situ pinning is still the standard of care. But in severe valgus slips is where we start shifting to other modalities.
So do we have any other question from the live relay centers, Gwalior, Ajmer, Jalandhar, Lucknow or Delhi?
Jalandhar.
Okay.
All right. Thank you.
How much traction you give? Normally say there is no need of reduction, but you give some traction on the fracture table.
No traction at all. So the fracture table is just to maintain the position so that it's easy for you to get a good C-arm view. You're not giving any traction, any position, nothing at all.
Thank you.
Hello, it's from Ajmer. Can we use small threads like 16 or less and just cross the smooth part of the screw from the epiphysis and just put threads in the capital head?
So using 16 mm is not a problem. The issue is you may not get enough threads. If you do not have threads across the physis and your threads are just in the epiphysis, you will not get much hold if your smooth barrel of your screw is over there. So the threads have to be on both the sides for it to hold the capital epiphysis. So you need 3 to 4 threads across and a couple of threads on the other side.
So actually we need
Also,
to,
if you do that, it's the weakest part of the
Part.
screw. And
Risk
these
of breaking.
children are obese and they have a lot of forces which act on that hip. And there are chances that it will break exactly at that point where it is crossing at the physis. So it is better to have threads on both the sides.
So I understand your question because in orthopedics, you're thinking of compression, that you want all the threads on the other side and you want it to compress over there. So here, that's not what we are using the screw for. We are using it for just fixation. So you want threads on both sides with 3 to 4 at least on the other side.
Okay, so if there are no other questions, from one hip condition, we move to the another hip condition.
Thank you.
We have Dr. Sandeep Vaidya, senior pediatric orthopedic surgeon from Mumbai, and he'll tell us about how we perform a DDH surgery, complete, open reduction and femoral osteotomy and other things. So over to you, Dr. Vaidya.
Okay, so I'm going to show you a 15-minute video which demonstrates operative treatment for developmental dysplasia of hip in a 17-month-old child. Now, unfortunately, walking age DDH is something we still see quite commonly. And I work in a tertiary care hospital, that is Vaidya Hospital. And over here, we do see this condition quite commonly. And the primary reason why we are still seeing walking age is because we still don't have a formal screening program in place. The Pediatric Orthopaedic Society of India, in association with the Indian Academy of Pediatrics, is trying to put up a formal screening program for DDH. But till that time, that awareness regarding this becomes widespread throughout the country, we are going to see these cases, and we are going to need to treat this surgically in most of the cases. So my case description and X-ray findings are all within the video, so I won't waste time talking about it, and I will jump straight away to the video with the audio as well. Yeah.
18 months old female child presented with a history of left lower limb limp noted by the parents since walking age. There is no positive risk factor for DDH. There is no history suggestive of infection in the neonatal period. On clinical examination, there is a leg length discrepancy with the left lower limb being shorter than the right. The telescopy test is positive. There is an adductor tightness on the left with the left hip abduction being restricted as compared to the right. The ortolani and Barlow tests are normal. X-ray pelvis with both hips AP, proglateral and abduction internal rotation views shows left developmental dysplasia of the hip with complete dislocation of the hip joint. By the IHDI classification system, this is a grade 4 TDH. The acetabular index was 40 degrees, which is abnormally high. Other positive radiological findings include smaller femoral head ossific nucleus on the affected side and early formation of false acetabulum. The child was taken up under anesthesia and close reduction was attempted. However, close reduction failed. In view of this, decision was taken to perform surgical intervention in the form of soft tissue release, open reduction of the hip by anterior approach, and capsulorrhaphy. The need for additional procedures would be dependent on intraoperative test of stability. So if the hip is stable at the end of open reduction and capsulorrhaphy, no further procedure would be performed. If the hip is stable in abduction and internal rotation, we would perform a femoral osteotomy. If the hip is stable in abduction and flexion, we would perform a pelvic osteotomy. And if the hip is stable in flexion, abduction, and internal rotation, then we would perform a combination of pelvic and femoral osteotomy. The patient is positioned supine with a small bump under the ipsilateral buttock. The entire lower limb, extending from the iliac crest down to the toes, is prepared and draped. The drapes are sutured to the skin and use of towel clips is avoided in order to minimize hindrance of visualization under the image intensifier. The incision for the adductor longus tenotomy is marked about 2 finger breadths below its origin from the pubic tubercle along its lateral border. The adductor longus tenotomy is performed by inserting a 15-number blade. The blade is initially inserted parallel to the tendon. Once deep to the tendon, the blade is rotated through 90 degrees and the tendon is cut from inside out. On completion of tenotomy, a gap is palpable within the tendon. The bikini incision for the anterior approach, which is marked about 2 finger breadths below the iliac crest centered on the anterior superior iliac spine, is next infiltrated with an infiltration solution which is prepared by mixing 0.5 ml adrenaline in 100 cc of normal saline. The maximum permissible dosage of this infiltration fluid is 1 ml per kg body weight. Skin incision is taken and is deepened through the subcutaneous tissue till you reach the deep fascia. Once you reach the deep fascia, through the translucent fascia, you will see a clear line of demarcation between the pinkish muscle fibers of the sartorius and the white fibers of the tensor fascia lata. The fascia overlying the sartorius is then incised to expose the underlying muscle fibers of the sartorius muscle. In the superior part of this incision, you have to be extremely careful to protect and isolate the lateral cutaneous nerve of the thigh. This nerve has to be carefully isolated and retracted from harm's way before the further procedure is carried out. The lateral cutaneous nerve of the thigh is now carefully retracted and the sartorius muscle is looped with a mixture forceps. The sartorius is then tagged with a number 1 vicryl suture, following which it is detached of its origin from the anterior superior iliac spine. In the deep plane, fascia overlying the iliacus muscle fibers is incised to expose the plane of dissection between the iliacus muscle fibers medially and the rectus tendon laterally. The rectus tendon is looped with a mixture forceps and tagged with a number 1 vicryl suture close to its origin from the anterior inferior iliac spine. The iliac crest apophysis is then exposed superiorly and split down the middle with a number 15 knife. The outer half of the split apophysis is then stripped along with the muscles attached to the outer table of the ilium. The straight head of the rectus femoris tendon is then detached of its origin from the anterior inferior iliac spine. The psoas tendon, which lies along the posteromedial border of the iliacus muscle, is dissected and identified. Once identified, the psoas tendon is looped with a mixture forceps and then tenotomized. The capsule of the hip joint is then exposed by erasing the remaining muscle fibers of the capsule with a combination of blunt and sharp dissection with an electrocautery. The entire anterolateral aspect of the hip joint capsule is now exposed. Omen spikes are placed along its superior and inferior margins. A T-shaped capsulotomy is then marked on the capsule with the horizontal limb of the T being parallel to the anterior margin of the acetabulum and the vertical limb being along the femoral neck. Stay sutures are then placed in the capsule to aid in later capsulorrhaphy. In total, 4 stay sutures are placed, one superomedial, one infiromedial, one superolateral, and one inferolateral. Capsulotomy is then performed along the previously marked T-shaped incision to expose the femoral head with its attached ligamentum teres. The ligamentum teres attachment on the femoral head is then looped with a mixture forceps and cut. The stump of the cut ligamentum teres is then held with a Cocker's forceps and is pressed to its attachment in the floor of the true acetabulum. The ligamentum teres attachment to the floor of the acetabulum is then cut with a stout scissors and excised. Next, the transverse acetabular ligament, which bridges the inferior margin of the acetabulum, is cut with a scissor. The fibrofatty pulvinar tissue, which covers the floor of the acetabulum, is then excised with a bone nibbler. Once the pulvinar is completely excised, the floor of the acetabulum is clearly visualized. This completes the soft tissue clearance and the hip is now ready for reduction. The femoral head is then gently reduced into the acetabulum. Once the reduction is achieved, stability of the hip joint and adequate coverage of the femoral head is confirmed. A CM image is obtained at this point. Concentric reduction of the femoral head is confirmed under the image intensifier. Additionally, a probe placed along the lateral margin of the acetabulum shows that the non-ossified cartilaginous roof extends lateral beyond the bony roof and offers excellent coverage to the femoral head. The young age of the child, the intraoperative test of stability, combined with the CM image, help us to determine that no further bony pelvic or femoral procedure is needed in this particular case. A transarticular K-wire is then inserted percutaneously from the lateral aspect of the thigh across the hip joint. The lateral end of the K-wire is bent, cut, and buried beneath the skin. We then proceed to perform the capsulorrhaphy. As you would recollect, in an earlier step, we had taken 4 stay sutures in the capsule. So during capsulorrhaphy, the infiromedial stay suture is tied to the superolateral stay suture. Similarly, the superomedial stay suture is tied to the inferolateral stay suture. This step helps us to take up any redundancy in the hip joint capsule and helps us to obtain a stable capsulorrhaphy. The cut rectus femoris tendon is then reattached to the anterior inferior iliac spine. The iliac crest apophysis, which was split, is now resutured. Finally, the sartorius is reattached to the anterior superior iliac spine. Following subcutaneous tissue and skin closure, we proceed for hip spica application. For application of the hip spica, the child is first placed on a hip spica frame as shown. The first layer of inner padding is with a stockinette, following which we apply a cotton roll for applying the 1.5 hip spica. First layer of POP roll is then applied. Around the hip joints, The POP roll is applied in a figure of 8 fashion. The anterior aspect of both hips and the operated knee are reinforced with POP slabs. The POP roll is then reinforced with fiberglass cast. The child is then taken off the hip spica frame. Special care is taken to see that the sharp edges of the plaster do not impinge on the skin and create skin problems. Diapers are applied to prevent soiling of the cast. Parents are instructed in care of the hip spica cast. Post-operative X-ray is obtained. At 4 weeks post-operatively, the transarticular K-wire is removed and a new hip spica is applied under anesthesia in the operating room. At 8 weeks post-operative, the spica cast is removed, gentle physiotherapy is commenced. A hip abduction brace, which is to be worn sleep time, is fabricated and gradual weight-bearing mobilization is started. This is the latest 5 months follow-up X-ray of the same child showing concentric reduction of the hip joint. The acetabular index at this point is 33 degrees. Long-term follow-up is essential in every case of DDH to look for the potential complications of residual acetabular dysplasia, instability, avascular necrosis, growth disturbance, stiffness, and secondary arthritis. Thank you for your kind attention.
That was the recording.
Hi,
And
everyone.
I would be.
This is a surgical demonstration of developmental dysplasia.
Excellent. Yeah, excellent.
Simple, but it's not as simple as it looked. But yeah, any questions from the house here or anyone from our centers? Any question?
Yeah.
In the last part of the surgery, when we know that the head we have properly fixed, the fixation is we have ensured everything. Do you think we could remove the K-wire and maybe let the spica and everything keep in place and remove the K-wire as it is?
So, we have been following this protocol of keeping the K-wire in for 4 weeks since quite a few years. We have not had any complications with it. We have also seen some cases where, we don't keep the K-wire and, within the spica cast, despite applying the spica cast well, the hip has either, subluxated or dislocated. So we are more comfortable keeping the K-wire and we have not observed any complication pertaining to the K-wire per se. And so I don't think it is a problem. Anyways, at 4 weeks, we have to take up the child for a spica change. So at that time, the K-wire can be easily removed. So this is a protocol which we have been following. We have had good success with that, and we don't intend to change that.
Thank you, sir.
Just to enumerate, if you can just explain, like the K-wire is just to hold it, not actually reducing the hip, because a lot of
absolutely. It's the K-wire is just a supplementary thing. The stability is mainly achieved at the end of your soft tissue capsulorrhaphy. Concentric reduction has to be achieved, plus if needed bony procedure. So the K-wire is just a supplementary thing. It's not that you are relying on the K-wire to maintain reduction, but I feel later lateralization or subluxation incidence is reduced with the K-wire in place.
So it's an additional, safety, because sometimes if the patients, you can sit, the relatives don't follow up, the plaster breaks, everything, whatever you have achieved, you want to retain till the capsulorrhaphy takes care and stabilizes. So this is an additional safety just for it. It is not mandatory. But for our scenario, patient compliance, we always put it.
So can you just tell what is your algorithm of when you would add a femoral based on the steps? When a femoral and when an acetabular procedure will be added based on what you see in broad?
So I am much more, aggressive in terms of doing a pelvic osteotomy as compared to a femoral osteotomy. Pelvic osteotomy, almost any child who comes with an acetabular index more than 30 after the age of 2 years, I would do a pelvic osteotomy. Before that age, between 18 months to 2 years, I would do a pelvic osteotomy if the hip is unstable with adduction and extension. So in those cases, I would add a pelvic osteotomy. Femoral osteotomy, I used to do very routinely till a few years ago, but then I realized that in most of these cases, unless the anteversion angle is very high, more than 40 degree, it is usually not needed. You do get the stability even without doing the femoral osteotomy. But one indication where femoral osteotomy is must is where at the end of your soft tissue release, you are not getting a reduction and you need to do a femoral shortening. So I more often do a femoral osteotomy for the purpose of shortening rather than doing for a derotation. Varus almost never is needed in a DDH.
Hello,
Yeah.
from Ajmer. Just one question.
Yeah, so contrary to what people think, there is no valgus. It is the problem is anteversion.
So I think fair ask the question.
So just one question. The question is that if after the soft tissue procedure, a reduction is not concentric, would you like to reconsider some other soft tissue procedure, or will go for some osteotomy or something like that?
No. So at the end of your soft tissue procedure, your reduction has to be concentric. If it is not concentric, it means there is some interposing structure, either the pulvinar or you have not cut the transverse acetabular ligament. If you have done all this release, all this clearance, it has to be concentric. There is no other reason why it won't be concentric. So you have to again recheck all your steps, go back. Have you done your psoas tenotomy properly? Have you, released your TAL? Is your capsulotomy good? Is your pulvinar completely excised? So if at the end of all this, your reduction is not concentric, means there is some step which you have missed out or some step where your, clearance has been incomplete. Only that could explain a non-concentric reduction at the end of your.
A lot of it was people have thought they have tenotomized but never reached there, and even the acetabular cleaning has not been done properly. Any other questions from any of the other centers? And from
more than a question, I think I would be happy if Sandeep can tell how easy is the psoas tenotomy, what all structures to take care of, because I think many a slip happens over there.
Yeah. So the psoas, you will find it along the posteromedial border of the iliacus. That's where you have to search for it. And it is hidden within the muscle fibers of the iliacus. So the thing is that you have to retract the superficial fibers of the iliacus and go deep and search for it. The main structures that you have to, be careful about is, your femoral nerve and vessels which are further, medial to that. So always, when you isolate your psoas, make sure that it is a tendon that you can do by, flexing and extending the hip and checking that the movement of the tendon along with it. And the initial cut in the psoas tendon, if you are not confident, it's better to do it with a cautery, because if it's nerve, you know that you are on the nerve. So that's there. But having said that, the nerve is, on the anteromedial aspect of the muscle. The tendon is on the posteromedial. If you are, you're used to releasing the psoas, I don't think there is any reason why you will, confuse between the two structures.
Other thing of the spica, what is the position of the hip you give in the spica?
So in a K-wire, typically we fix with the K-wire in 30 degree of abduction and slight about 20 degree of flexion and neutral rotation. So that is the position in which we will apply the spica as well, the position in which it has been fixed with the wire. However, if, in cases of close reduction or in cases where we are applying the spica at the time of spica change. So here the spica has to be applied in what we call the human position. And the human position is around, 80 degrees of flexion and around 30 to 40 degrees of abduction and neutral rotation or maybe slight internal rotation in order to further stabilize. In close reduction, in fact, you may even do a bit of hyperflexion, 100 degrees, so that your head is really, goes into the depth of the acetabulum. So that is the human position. Having said that, never ever give a forced abduction. Okay, if your hip is only stable in more than 50 degrees of abduction or so, and you have to force the abduction in order to stabilize the hip, it means your soft tissues are tight and you will need to release them, because that increases your risk of avian.
How long do you keep each spica, and then your bracing do you do in?
So as I mentioned, it is an open reduction. It is a surgical reduction. It is 4 weeks of the first spica. At 4 weeks, you change the spica under anesthesia. At the same time, you take out the wire, and after that, continue for another 4 weeks. So total 8 weeks in spica. However, when it is a closed reduction, arthrogram and closed reduction, it is 6 weeks of the first spica, 6 weeks of the second spica. So total 12 weeks of spica.
So any other question from Delhi, Gwalior, Ajmer, Jalandhar, Lucknow?
Okay.
Okay.
Thank you, Sandeep. That was really great. I think they've made it very clear, all the steps, and explained very well. So now from the hip, we move to a different area, and I'm happy to invite my dear friend, Dr. Rujuta Mehta. I think she needs no introduction in India. She is the pioneer and the leader of women orthopedic surgeons, and also an excellent upper limb pediatric orthopedic surgeon. And she's going to show us 2 videos, one after the other. One shoulder muscle transfer for obstetric brachial plexus palsy, and then radial clubman. Over to you, Rujuta.
Well, thank you, Binoti, for a lot of kind words. And I think it's more important that we kind of learn to address things which very often get neglected in our country. And if hip is missed, then I think shoulder OBPP is even less, brought to the orthopedic surgeon for any procedure, because the tendency tends to be from the pediatrician to the physiotherapist to keep on just hoping against hope for a full recovery. A lot of them definitely get that full recovery, but it's when they plateau, it's when they are in the mixed phase, it is when that they have achieved some function but are not going further, that equally occur. And since we pay a lot of attention to hip, I think it's about time we start looking at the shoulder also with equal aggressiveness, because this is a joint where the kind of deformation that occurs in the shoulder girdle is not addressed fully yet, even in literature. So as soon as the slides come up, we'll go through a few PPT slides, not too much in theory, just to orient you all with the procedure that's going to be done. And feel free to ask me any questions either in between or as we go along or at the end of it. क्या चाहिए आपको? Screen. Are we on? Not yet. So how many of you all even know that a lot can be done in OBPP by the pediatric orthopedic surgeon, the one sitting out here? Yeah, all the ones trained by me are not allowed to answer. All right, so that just goes to see that, this is still a unaddressed need. So let's quickly look why this happens. When you have a recovery going on in something which we in textbooks imagine to be in a linear fashion like this, like the palm, in reality, it's always a bunch of nerves sitting over there. And therefore, mixing up of growing axons, like cross connections, like which used to be there on the phone calls, and co-contractions is a very, very common phenomenon, especially when you're dealing with the upper plexus, that is C5-6. What happens as a result of that? There are strong adductors and internal rotators, which are pulling the shoulder inwards, which are the pect major, latissimus dorsi, subscapularis, and the teres major. So 4 large bipinnate muscles, which are being opposed by weak little abductors and external rotators, that is the infraspinators and teres minor. So this tug of war is obviously going to be won by the 4 large muscles. When this is happening, initially this is what it starts as, that there's a restriction of range. Parents get very excited that now she's going up to 90 degrees. She's able to take everything in the front line. And then that's where all the time pass, literally, I would put it as, with the physiotherapist starts. And when that is not treated surgically in time, this is what happens. The same child at the end of 3.5, 4 years with a fully established, tight internal rotation contracture and a posteriorly dislocated humerus. So again, some more examples. Some of them may manifest as a trumpet sign. You can see even how badly in the first video, going above 90, going to 110, but the internal rotation is completely more than 90 degrees. So it's like a totally posteriorly subluxed humerus, and this could have been easily prevented. When the biceps and the deltoid contract together, this is what is known as the trumpet sign. So every time the child wants to do a hand to mouth, instead of doing it like the normal way like you and I do, they will involuntarily abduct the shoulder, and that again pushes the thing back. There's a very simple functional evaluation score which is known as the Mallet score, which you could read up. I will not go into details, but it is just devised on 3 or 4 very simple movements you can do in the clinic. You could just read up this paper, or for want of time, we won't go too much into detail, and that's how you can measure each. The grades are from difficult to little simple to near normal. That is 2, 3, and 4. Very, very easy to follow. You can just paste a chart in your clinic and evaluate the child. Khel mein. You can just show them, do this, do this, do this, and it's done. So OBPI, now remember this for life, that has a combination of muscle imbalance plus soft tissue contracture, which leads to a progressive glenohumeral dysplasia. And this has been very beautifully studied by Peter Waters and popularized. A normal looking shoulder joint then gets slowly deformed and dysplastic like this over a period of time. We have many papers now telling us how early it happens. So ideal screening time for looking for shoulder dislocation in OBPI is 4 to 6 months. This is how you measure it, either on a CT or an MRI. Again, we won't go into too much details. You could read this up. But suffice to say that if you draw a line along the long axis of the scapula, it should ideally bisect the humerus globe into half. And then you draw a line across joining the 2 borders of the glenoid, and that would tell you the amount of retroversion, which is shown by the alpha angle. But what happens here is, because the humerus globe is subluxating, only 35% remains anterior to the long axis. And at times you even see it completely posterior. So very similar to the hip. If you remember the IHDI stations that Sandeep showed you, this is how the quadrants will tell you where the humerus is subluxed. You can have these kind of deformations. You can see how badly the glenoid is deformed here and the humerus is completely posterior. Or you could have it flattened, or you could have it bicompartmentalized with the globe again posterior. So don't underestimate the power of a physiotherapist, and you see how much the shoulder girdle can really deform with a forced abduction and a forced external rotation, which happens there. These are the classical water grades. Again, we are not going to go into detail because our focus is the technique today. And there is a paradox. Upper plexus lesions have a better neurological prognosis, that the C5-6 will recover fast, but they have a worse prognosis for humeral head deformation. And C5T1, or the global palsy, where the hand just keeps lying like that, again has a bad prognosis for nerve recovery, but has a great prognosis for the shoulder deformation, because there's hardly any tether anteriorly which is pushing the humerus posteriorly. So this is just to keep in mind the paradox of both these things. Again, we won't go into details today. This is too large. So the treatment strategy from our perspective should focus firstly on either preventing, which you could do by relaxing the muscle, which is similar to what the Backloff does for the entire body. You could inject chemodenervation in the deforming forces, that is the pect and the subscapularis, and center the humerus in a closed reduction, and then followed up with a shoulder spica. Or when you need, more often than not, you need to open, that is detether, and anteriorly release all the contracted ligaments, exactly how you go in a DDH. Then do your musculotendinous lengthenings and release to maintain it there. In some cases, when the humerus is totally bad, you have to even do an anterior capsulotomy and a subscapularis release, which shouldn't be complete. It should be only 25% so that the child doesn't lose the hand to back function, which is very important for hygiene. And at times it has been so bad that we even had to nibble the coracoid anteriorly, because otherwise the coracoid abuts and does not allow the humerus to come forward. We'll show you each of these. The difference between a DDH and a OBPI is that you need to add a tendon transfer here, which is your main motor, which is going to now prevent internal rotation all over again. And this is done by doing the latissimus dorsi and teres major to the rotator cuff, because it augments the missing function, enhances your abduction external rotation. And it's a strong motor which is transferred coaxially. So it's a phasic transfer, therefore it works very, very well. And then you follow it up with a dedicated rehab, as I will show you. So the goal would be to convert somebody who's a Malay 2 in every action to convert to a Malay 4 and be able to do all the actions. So what are the two muscles that we're looking here? The teres major, which is attached onto the lateral border of the scapula, and the infraspinatus, teres major and the latissimus dorsi, which are to the infraspinatus, which is your rotator cuff tendon. So that's the pivot that you want to take it to. That's the position. The child is in the lateral decubitus position on the table. That's your incision line, which needs to dip into the axillary fossa and then go on to the humerus. Remember the lady between two majors, your teres major and your pect major. So this is your latissimus dorsi, which is opened out. This is going to be axillary dissection. So again, like the psoas, where the femoral vessels are there, you have to be extremely careful when you're going into the axillary fold there. That's your conjoint tendon identified. Teres major and lat dorsi together. Make sure you retain the pedicular attachment. Even when you're detaching the entire muscle all the way down to the lateral border of the scapula, make sure the pedicle is live, otherwise it just becomes a dead muscle transfer. Then you open posteriorly, identify the deltoid, take it away, go on to the humerus, identify your infraspinatus, then create a subcutaneous tunnel which is wide enough for both the muscles to fit in comfortably. Bring it out through that subcutaneous tunnel, close all your other incisions, and then attach it here, and then go into either a pre-fashioned splint, that is what we used to use in the olden days, but now we replace that with a shoulder spica. Maintain it for 6 weeks and followed by physiotherapy. Now the same steps that I told you are being shown as a video. Always do this under infiltration. That's your incision and on the spine of the scapula and the posterior axillary fold. With the infiltration, it becomes a virtually bloodless surgery, as you can see over there. Be generous in these incisions. There are a lot of people who use a Mercedes-Benz or a circular incision in the axillary fossa. But I think when you're really dissecting large muscles and you want to identify your neuromuscular structures well, it's very, very imperative that you have a very clear visual field, and your areolar planes will just fall apart if you have good infiltration over there. There you can see both your muscles being, slowly isolated, securing hemostasis. That's a lat, which you will encounter first, and that your teres major is a more internal muscle. And you can just wield the cautery like a knife or a pen. Yeah, that's the identification of both your tendons, then digging deep into the axilla. Now you come into the area with very gradual, gentle dissection. That's your axillary nerve and vessel. I like to look at it and then get your best assistant to retract it away so that it's always protected away from you. And anyway, you need to go in deeper to get to the tendon, as I'm showing you. That's me sounding the humerus. So when you can actually put your closed instrument against it, that's when you know you've reached the end point and the insertion. Ask your assistant to keep on externally rotating. You get the whole tendon into view, the conjoint tendon, and with a sharp, steely, kissing the humerus, rip it off the humerus there very, very gently. Again, while going into the axilla, be careful. Once you have that blow for freedom, you have both the tendons in your hand. Remember, there are few fibers which are going to be attaching of the lat, especially into the skin. So it's important to identify that. Separate it from there. Be careful not to injure the triceps and the radial nerve there. And then gradually separate it out from the humeral inferior surface. When you're doing that, remember there are going to be circumflex humeral vessels over there as is being shown by the hemostat. And then you just lift it off like exactly you do the capsulotomy in DDH. So I think it was good to have both the things in parallel so that you can see how you're lifting the rectus off the DDH, same way you're lifting off the conjoint tendon from the inferior surface of the humerus. Then you proceed to the posterior dissection there. Again, do a lot of infiltration. That's the marking of your humerus and the spine of the scapula. Incision comes exactly on the spine of the scapula. That's your superficial dissection. Keeping the fibers of the deltoid away. And identifying the rotator cuff. And you could take a pre-stitch on this infraspinatus tendon, so that you know when you are bringing your tendon from the tunnel, it's easier for you to identify it and just tie it there. I always prefer tagging it like we tag the capsulorrhaphy. Then that's the subcutaneous tunnel, which you will either use a large hemostat to form, or you could use cautery, or you could use 2 fingers like they do in the prostate. But it's important to really have this as a generous wide tunnel. I like to say 2 fat fingers. So if my fat fingers can fit in it, then the muscle will never get strangulated in that. And then you bring it out. Very simple. Finish off your closure. We'll stop this here. And those are some of the results that you can see. A child 1.3 years old. Not a very bad subluxation, but a significant retroversion there. Conjoint transfer done, and those are the immediate kind of results you can see within 3 months doing all the actions. Same child when she grows up. Mild FFD at the elbow, but done very well. Again, similar results. We won't spend too much time on the rehab here because the younger you do them, the more time it takes for them. So, just using play therapy, we won't go into any details, but a lot of constraint therapy and against without gravity or gravity eliminated therapy, you can really get there. And this is an example where you needed a coracoid nibbling also, and that's how they do post-op. So remember, there's not going to be one key that fits all the cases, but remember the neurological type in your decision making. Remember to do your Malay score, and remember to document the degree of shoulder dysplasia. When will you do just a single tendon? Sometimes even lat dorsi suffices. You have only one range deficit, say just an abduction deficit. You have minimal glenohumeral changes, and you have a better Malay score pre-op. That time you can afford to use just one muscle for the transfer. If you have a very severe internal rotation contracture, especially if you have a very bad external rotation, you have a high glenohumeral Waters grade and a poor Malay pre-op, that's when you're going to use a conjoint tendon. So this is the algorithm that I'll leave you with. Look at the poor abduction, good ER or a congruent glenohumeral joint. Then you will check for how much passive external rotation is there and do just an isolated latissimus dorsi transfer. But if your passive external rotation is less than 30 or 30 to 45, then you have to add a fractional lengthening and a latissimus dorsi transfer. If you have a poor ER but a congruent glenohumeral joint, again you will follow the previous algorithm. But if you have a non-congruent joint, then you have to really do a radical anterior release plus a conjoint tendon transfer. We'll show you the anterior release just very quickly over here. Let's take a few questions while this PowerPoint closes because there's a huge video in it, so sometimes it gives trouble.
Yeah, so thank you, Rujuta. That was a wonderful demonstration of a very complex problem. So we invite any questions, and I think Dr. Tushar wants to ask some question.
Yeah, madam, you are the complete boss of this surgery. But I want to ask, we've started doing it through the transaxillary approach and it is delivered through the same incision.
Yeah.
I'm sure you're also doing that. So
We've done that with Peter Waters.
Vis-a-vis the two, what difference do you find in the struggle intraoperatively versus the outcome?
So outcomes, I don't think there's any change as long as you're very, very confident with your axillary dissection. It is the same difference that you have in a Cincinnati incision versus a PMR. In the transaxillary incision, it is very tough to really get adequate space to kind of dissect your conjoint tendon free.
Means to make it very mobile. You
Yes.
mean to say?
Yes. Otherwise, there is no real, it's what you are, more familiar with.
Another question I have is that after the end of this surgery, do you have a specific position of the shoulder spica?
90 degrees abduction and full external rotation in 90 degrees. The humerus should be swinging
And
easily.
how much forward flexion? Like
No forward flexion.
it should
I
be
like to keep it absolutely at 90 degrees abduction.
And that would be there for like 4 weeks.
4 to 6 weeks, like I said. This is the, I think, anterior release. Let's complete that part if it is projecting.
Just to ask, like with the axillary incision, sometimes you have seen a hypertrophic scarring coming in some of these, and then that gives a little slight contracture. So in your experience, any changes that you do now or anything to
No,
prevent?
I just forewarn them because having a hypertrophic scar is something which is a child's tendency. So you have to tell them that we will do things like, giving Contractubex, or you'll put a silicone sheet and make sure that the scar is a little less. Yeah, we are ready with the anterior release video also.
Can I ask
whenever
one more
you,
question?
yeah, till you can.
So
Maybe dikhana.
sometimes you see the superomedial border of the scapula becoming very prominent as they adduct and internally rotate. So how do we overcome that?
So the putty sign, if it is already there, that is a sign of deltoid weakness. So you can't really overcome that. And sure enough, initially the parents will be bothered about it's not going overhead, and now they'll come and say, oh, it's showing. The superomedial border is showing. So then you have to counsel them saying that this is the hypermobility of the scapula, which is allowing the whole girdle to rotate forward and backward.
We can resect that portion, the superomedial.
Why do you want to go around doing, normal tissue unnecessarily? Unless it's a sprangle, which is a true high riding scapula, then I suppose you're justified. Okay, we're ready with the anterior release. So let's go ahead and show that. That's your pectoralis major marking. That is the acromion process. That's your clavicle, which you need to palpate a little bit deep, and the coracoid right below it. This is going to be your deltopectoral approach, the line of the incision. Just remember, this is just like the DDH. Again, after infiltration, you go in. You could do the pec like a percutaneous adductor tenotomy as well, but I think it's better to, in anything around the axillary region, better to have a look at it yourself and do it. That's your pect identified. Make sure that there is no nerve structure below there. And you do a fractional. So you don't really want to release it fully unless it's a very, very tight, complete posterior dislocation, which is long standing for many years. So you get a very nice, significant lengthening there, and that itself brings the humerus a little anteriorly. Then you continue further in the deltopectoral region. Again, use your quadri to get your planes better. Take the cephalic vein out of your way, and that's your coracoid lying really deep there. You see the white glistening structure, which my hemostat is sounding. That's the coracoid, and there are coracohumeral ligaments attached there and the capsule. This I've shown you diagrammatically there. So if the humerus was there, it would have not, allowed the coracoid, would not have allowed it to come up front. That's your long shot to show you that now I'm able to anteriorly reduce it and get good external rotation. So which means that my anterior release has been sufficient. I then close up the pect and then complete my conjoint tendon transfer. Actually, that's how I prefer to do it in very long standing cases. Okay. And that's the shoulder spica. We have not made a lengthy video of the shoulder spica because we've already seen a hip spica. And that's not very much different from it.
Right. So any delegates has any question on any of these procedure? Or anyone from the other centers in India? Anyone from Gwalior, Jalandhar, Ajmer, Delhi?
Madam, ये glenoid osteotomy पीछे से open reduction, all these things.
No, we don't do a piche se open reduction ever when the problem, the entire head is piche. So you have to do an anterior open reduction. Glenoid osteotomy is like your Salters or your Degas. You can always add it on, but that child has to be above 7 to 8 years. You have to have a definite glenoid dysplasia. So means a deficient posterior wall of the glenoid. And only then you can use, that time is when you excise that superomedial portion which is jutting out and use it as a graft.
Acha, there into the glenoid.
Yes.
Okay. And this humeral derotation osteotomy?
That's a salvage procedure for a very old child where you have absolutely no muscles to transfer, you have no motors. And remember that that will only change the arc of rotation. So if the child was stuck like this, he'll be stuck in a more neutral position. And he'll go outwards, but then he will lose a little midline function. So there are limits to how much you can derotate in a derotation of
You
humeral
would use
osteotomy.
it for children more than 10 years of.
Where there is no deltoid, where it is completely atrophic, where have even the lat and teres is not really good for it. If I cannot reconstruct, that is when I choose a salvage.
Any other questions in any of the other centers? So ma'am, just to ask for, we have a lot of young graduates who are just new into pediatric orthopedics. What is the ideal indication of doing this reconstruction? What is the maximum age limit? And what is the criteria you would say now this child does not fit in for this kind of a procedure? And you would be talking about salvage like you were discussing previously. Minimum age limit?
So minimum age limit 11 months. Upper plexus almost finishes its entire recovery at 9 to 10 months. So I have done it as young as 9 months as well, but I think that's in select exceptional cases where you know that the parents are completely cued in with what you're saying. So around 1 to 1.5 is what I would put as a better age for a good surgical field, for ease of the structure identification and things like that. The criteria is restriction of abduction, overhead abduction, and external rotation. More than abduction, I think abduction anyway improves by default when you take away an internal rotator and an adductor. When you have passive external rotation not going more than 30 degrees, that means you really have an external rotation deficit, and that is what this tendon transfer was described for. Then your anterior releases are to be added in depending on how bad your posterior subluxation is. And upper limit, I've done it as old as 13, 14, 15, but not beyond that. Basically, if there is no muscle power to transfer, that is what I just discussed with Tushar. Yeah, you have to have so it's an algorithm. You put all three things together, your root value, your functional Mallet score, and your shoulder dysplasia grade.
Right. So any other centers have any experience or anything different being done, or any queries to ask to Dr. Rujuta from Delhi, Jalandhar? Yeah, someone from here.
Not related to the tendon transfer, but what is the age limit and criteria for suggesting a nerve-related surgery like nerve grafting and nerve transfer?
So those are at 3 to 6 months of age. When you have zero recovery, your biceps has not even started flickering at 3 to 4 months of age, then it means that your entire plexus is avulsed from the spinal roots, and no matter how much you wait, no matter how much you stimulate, no matter how much the therapist works on it, it is not going to get a re-innervation. So it's like pura wire खींच दिया है from the plug point, तो लगाना जरूरी है. You have to connect into the power supply of the brain, and that is done by the plastic reconstructive surgeons. They actually take a nerve graft and plug it into the opposite side plexus, because that's like using a Bofors gun there. So you get a lot of neurons which are connected with cable sural grafts, and that works really well, especially when you have a median territory which is completely gone. So that's why the C5T1, it has a bad prognosis for nerve recovery, But it has a good prognosis for the shoulder joint because there's nothing to tether it anteriorly. Whereas a C5-6 will invariably recover. The upper plexus will invariably recover. But to what extent? That depends on how bad the lesion is.
Ma'am, just there are a lot of delegates who are just new. They have not been exposed to brachial plexus. So just in a small nutshell, if they get a baby in their clinic who is suspect or is supposed to having obstetric brachial plexus, what would be the algorithm that they should just keep in mind and timeline to progress to all of these things?
So if the baby is referred to you at birth, if you're lucky, first just reassure the parents in detail that there could be a spectrum. Most of them will recover, but however, if it doesn't, then there are surgeries at every stage which can be done. So first 6 weeks, you will just do reassurance, give some nerve tonics, and teach the mother gentle mobilization of all the joints, the shoulder, internal external rotation, the elbow, biceps flexion extension, and the wrist pronosupination and again dorsiflexion, palmar flexion. They just need to maintain the biomass of the muscles. After Valerian degeneration is completed, the first signs of recovery will start at around 1.5 to 2 months of age. In the next 2 months, if that is steadily progressing, things are improving and the biceps has started reaching a hand to mouth, you will do a cover test. When the child you're examining and if the child is not in a mood, just cover the eyes of the child and if the hand is normal, they'll vehemently struggle to try and get your hand off. If that is not happening, but you're getting a slight contraction or the biceps, triceps are co-contracting together, then it means that some recovery is coming, but this is going to need Botox. So do a early Botox between 6 to 9 months to the triceps, subscap and the pect. When you've given Botox to the antagonists, and if the agonists keep catching up over the next 6 to 9 months, then great, you're going to not need anybody for any surgery. But if you're not getting co-contractions, the hand is just flail at 3 to 4 months, then please do not wait. You have to refer to a brachial plexus surgeon. Like I said, plug lagana zaruri hai into the wire point. Assuming that all that has not been needed and things are going well by 9 months, everything is recovering, your Botox has started wearing off, but the co-contraction has started returning. Then you know that now if I don't intervene in time, it is going to go into an established contracture. That is when you do the surgeries which I showed you. And if like child has come late to you, 9, 10 years, then you look at how much deformation is there in root value and just go ahead with the salvage.
Great. So I think we can move to the next area, which is radial club hand.
Okay, since we are plugged in into the laptop, we will do that. No
So
problem.
this is another difficult problem, radial club hand, where you have complete dysplasia, aplasia of the radial side of the forearm development. And it's not just a short or a deficient bone or an absent bone, but there are a couple of other associated soft tissue abnormalities over there. So how do you deal with it? That Dr. Rujuta is going to tell us about the corrective surgery.
Okay, you want the corrective surgery straight, or again, there's some Ponseti-like thing which we can do here as well. Yeah, so radial club hand and club foot are not similar. Radial club hand is an entire hemimelia of a segment with a lot of carpus deficient, with some fingers anomalous. So this is the algorithm which I want all of you all to take home, that between 1.5 to 3 months of age, you apply splints and stretch the skin and soft tissue, which should be followed by either a soft tissue distraction with fixators 3 to 4 months in higher grades, or a plastering technique, which I'll show you similar to the Ponseti. Then a centralization at 6 months, which we will show you a video of. And just remember this, but we won't go into too much details here because we are concerned with one procedure that helps us. So this is what all of us can indulge in, how to do plasters and stretch the skin and soft tissue. In lesser degrees of radial club hand, it's just a mild tendon transfer that you need a FCR to the FCU, which is done from the wrist there. FCR is moved subcutaneously to the FCU, and ECR is moved to ECU, and you can get a good correction. But that's not the subject of our deliberation today. This tendon transfer part we will cover in the open surgery. So everybody, the whole world knows about how to plaster a club foot with Ponseti, and which Chasanal will be showing you very elegantly. but there was no technique really described for a radial club hand plastering. In a radial club hand, the challenges are more because sometimes you don't have the thumb. So it's very easy for a plaster to slip off a shortened and bowed forearm. And the working space is really small. You barely have 3 to 4 inches in a baby. Remember that, against your own palm, which is probably twice the size of that bachu's forearm that you're going to be plastering. So we kind of, over the years thought, and we came up with this technique, which now I've subsequently published also. What we use is thin strips of POP and Vaseline gauze multiple layers. So what you do is first you layer the child's skin with multiple layers of Vaseline gauze and put a dry cotton bandage over it. Then you use the 2 thin strips to create a crisscross lattice. I will show you subsequently the maneuvers also for manipulating this, so that this forms a very strong sort of a reinforcement there and does not allow the carpus to slip volarly. And on top of that, you complete again with a dry cotton and half semicircular layers of these strips. So let me show you how this is done. It's been inspired by the Ponseti casting and the steps of the Pirani score and everything. So what are our maneuvers? We do a neutralization and abduction, because it's not just a simple adduction contracture. There's a carpal override also over there, which you need to bring the carpus out from below the ulna. There's an entire row missing. So this is the first step, the neutralization maneuver, where you hold the fingers, give pressure on the ulna styloid, as you can see over there, and bring the whole palm up to make it collinear with the wrist joint. Then you do an uncoverage. You gradually start abducting like you do in Ponseti. At that time, maintain your pressure on the ulna styloid so that you're pushing the ulna down, pulling the wrist and carpus up, and then you are starting to abduct slowly. Once you have achieved that, again, I'm showing the same first 2 maneuvers, and you have seen that it has started to come out. Then you use pressure on the pisiform, that is the 5th metacarpal base, and on the base of the 2nd metacarpal from below. Both my fingers here, you can see this is on the 2nd metacarpal base and the little finger is on the pisiform, and that is pulling the wrist, pulling the hand out of the forearm and wrist space. And then you proceed with your these Vaseline gauze layers, dry gauze, crisscross lattice, and complete the plastering. So this really works very well over a period of time. We've seen that we're getting as much translation as we get in the atypical clubfoot. And you can use the same 2 points, the pisiform and the base of the 2nd metatarsal, to mold it exactly like you mold an atypical CTEV, where you are addressing the plantaris. So this apex is what is your ulna styloid there, and you are increasing the space here in this triangle and getting the plastering done. Some of our results, which we won't go into detail, but we used to get quite good corrections there, and the only thing that remained to do was the centralization. And sometimes we've just added a ulnar osteotomy as well, but we're not going to discuss that in detail at all here. And there's a post-surgery that we kind of results that we get. So for those of you who are interested, this has been published in the latest issue, October issue of JOIO, which is a women ortho special issue. And you can read it up from there much more in detail. But we are orthopedic surgeons. We don't like it unless there is some surgery involved. And can every club hand be sorted by plastering? Not always. You get a lot of neglected cases. You get a lot of tight syndromic cases where plasters may not succeed all along. So that's when you use JES. You could use a unilateral or a bilateral frame. You use 2 mm K wires in the ulna, 1.5 mm metacarpals with pins, which are half pins, as I will show you here. 2 from the ulna side, 2 from the radial side. And this is your ulna pins. And you connect them to distractors. Half mm per day you use this turn button. And you gradually stretch it out. If the child tolerates, you could go up to 1 mm per day. Retain the frame for 4 weeks. Wash for infection and loosening, as is the case with any other fixator. That's the kind of correction you can get. And then you proceed with your open procedure, which is what the video is all about, in which you will execute the FCR to the ECR, which is converting your deforming forces into corrective forces as described by Bagram-Co. That has also been published initially. Some modifications to the frame where it is difficult to apply a linear frame there. You can use drop Ls and put distractors on the lower part. This is the apex of your deformity, and this is your triangle. And then you distract along the isosceles triangle margin. And those are some of the complications also which may happen. So again, we're not going into this in detail. Now comes the main centralization technique video which you wanted. So we have been kind of brought up to be, doing the skin approach by this technique, but there are many, many other. Some people use a lazy Z, some people use a curvilinear S. We prefer this because we feel that the skin which is anomalous here, you have a lot of redundant skin on the ulnar aspect that is very effectively utilized by the bilobe flap of Evans. So what happens here is this is where the radial defect will be. Then your flap A will move into this radial defect and your flap B will move into the space created by the flap A, and these two edges will close by primary intention as I will show you. So now let's run the video here. How will you measure these flaps? You will place your gauze piece on the radial defect and both the limbs of the flap A and B should be equal. Again, before fashioning this flap, make sure you have equalized both. Mark out these flaps on table. Flap A on the dorsum, flap B on the ulnar excess skin. That was a grade 3 radial club hand. Yeah, then you proceed with the incision which defines your radial defect. Two structures that you have to be careful here is the median nerve and the FCR if present. In higher grades of radial club hand 4 and 5, you may not find the FCR always, but you will always find the radial enlarge. So that is carefully dissecting and going down, identifying your median nerve which may be tented over the defect, releasing all the structures around it. Visible well? Yeah. And whenever you've used a fixator, remember your tendons would be adherent. So make sure that when you're opening now, go around both. That's the tendon identified. Confirming that. And then release its excursion above into the forearm and below. Then you go ahead and flash in your flap on the dorsum. Make sure it is glabrous there. Let's play the video and show you. Yeah. And maintain the adipovenous plane as was always taught to me. That is, the veins here have to be maintained. Otherwise, the flap will get engorged and even necrose. So we use a lot of skin hooks and very gentle, delicate dissection there. We'll see the long extensor tendons over there. Those have to be preserved. You have to make sure that you connect the radial defect and flap A so that this will swing freely into the radial defect then. Again, using steelies, we identify that. And when you are coming to the edge of the flap A, that is when you will try to look for the ECU, which is usually tented over the ulnar defect. To the next slide. Yeah. As you can see over there, it is usually thickened. Identify it nicely, release it, and keep it out of harm's way. The beauty of the dissection with this bilobe flap method is that you get the entire ulna there in front of you. So doing your reduction then is very easy, and that's the carpus which falls down over there, and you can actually release all the structures around it, take away the ECU, and then bring the carpus on that. So that is the flap B that we are doing, and that's in fact my mouse is pointing to the ECU there on the ulna head. This method also retains all the growing cartilage of the ulna and the carpus. In other methods, you will see that they create a notch in the carpus, which is absolutely not needed here. So whatever that hypoplastic bone's growth potential is there, is beautifully maintained, and you can pass a nice retrograde wire since the ulna is right there in front of you, and then thread the carpus over it. And that's how beautifully this closes. That's the radial correction and the K-wire over there. So it's a minimally invasive sort of a thing for the growing cartilage, but it's a maximally invasive for the exposure. And those are some of our results. As you can see there, we don't want to go into too many details, but over a period of time, you can see that the ulna actually becomes as broad as the radius. always a moment of truth. There's a bit of a growing curve in this learning curve in the flaps. So if you're not watched your venous planes, then you can get this kind of a necrosis. And with fixators, you can get even as bad complications, especially if you've made multiple attempts to drill the holes, then you can get fractures at times or a physeal distraction. And therefore, it's not an easy endeavor and you must do that with care. And some long-term results, after which you'll move to policization. We won't go into details. I think let the Elizaro guys do the lengthening after this. But in short, you can really successfully treat radial club hand right from being a toddler to a full-blown adult with multiple procedures at the orthopedic surgeon level.
Thank you so much, ma'am. One question is, one is at what age do you add the ulna osteotomy? We know it, the ulna bowing is there. In young children, sometimes it's very difficult to do both the procedures at the same sitting.
Yeah, especially if it's done in the same tunicate.
Yeah.
So earlier the thinking and the classical teaching has always been that do it after 5 years of age. But over a period of time, I've grown to learn that if you have a more than a 30 degrees ulna bow, it is a multi-apical deformity like your OGI bones. So when you are doing the plastering, you can just do percutaneous osteotomies. It is much easier and lesser, and you can thread your wire over it, provided you've got the carpus out onto the ulna. But if your wrist is still not reduced, then no matter what osteotomy you do, you will not get a good correction.
Ma'am, percentage of recurrence and how often you need to do a centralization again? Or would you consider arthrodesis at any time?
Okay, so we'll start from the other way. Arthrodesis word we should drop because we don't want to go around fusing wrists in children unless we have no other go, very poor muscle power like we have in cerebral palsy adults. Ideal time for centralization or this thing is 6 months. I think we forgot to mention that in Avi's question. And yes, just like club foot is known for recurrence, radial club hand is even more known for recurrence because you have an entire ray of bone missing over there. Over 5 years follow-up, we've had around 13% kind of a recurrence rate which we've seen. But it is easier and more amenable to repeat procedures, but which are usually a fixator and not a reopening centralization. Only the ones where we've been, you've just had no entire first ray, you've had no thumb. That's when we've sometimes had to reopen, and that's when we've used a fascial autograft to recreate the missing FCR.
Sandeep Patwardhan talks about retaining a K-wire for a very
6
long
to 8 months, which is, if we were blessed with a country where there was no infection, it would have been very easy. In an ideal world, what he says can hold true, but maybe in my hands, within 3 months, I've seen a lot of them getting infected and then you're pulling out the K-wires and putting plasters. So plasters and fixators, I think, are easier to repeat rather than a full open procedure and then having to deal with osteomyelitis.
Ma'am, the other is, what is your upper limit? We have a lot of patients who come very, very late. They are nicely accommodated and they do a lot of that. So what is the limit till you would think of reconstruction?
2 years, 3 years, max 5 years is what I would say. Once they've crossed the 5 years, their brain will just not adapt and their wrist joint is then functioning like an elbow because the forearm is so short that the taller the child grows, the hand doesn't reach up to the groin. But it's a serious problem for them for toileting if it's a bilateral case. However, you do find that they are reasonably adapted.
So I had an occasion where we did a good centralization and following which the patient never did policization. So then the relapse starts coming in because...
Yeah, again, very good question because the long flexors then act like a bowstring and they keep pulling the arm in. But if they've not agreed for policization at 1.5 to 2 years, max 3 years, then again, better not to touch them because the brain just does not adapt to the function. And it looks like a good thumb, but it doesn't use it like a good thumb. They still use the chopstick action, which starts setting in at 8 to 9 months actually.
So you feel policization latest should be by 3 years?
1.5 years, 2 years ideal.
Stretching.
Yeah. from birth to 1.5 to 2 months, perhaps you could do that. I mean, I find if you can plaster a clubfoot baby at 5 days, you can plaster a radial club hand baby also at 5 days. Provided they have such a lot of those systemic things going on with them, like if they don't have heart issues, tracheoesophageal issues, then you can start off with your plastering. And that's the other reason I'm preferring plastering, because these babies are very syndromic.
Okay, so if any other question, we would ask other centers, Gwalior, Ajmer, Jalandhar, Delhi or Lucknow. If you have any questions, you can ask for these two conditions now. So we have Jaideep who wants to ask something.
Lot of children develop the recurrence, ma'am. So same line of protocol we follow once we did the centralization, everything.
Yeah, so you would start plastering again, like you can plaster in a Ponseti. If it's not kind of responding, then fixator still.
After doing centralization.
Centralization also.
Again.
We'll still start the simpler methods first, because it will be very stiff if you open up directly.
Okay. Thank you.
Even post correction, post correction, we know recurrence is a risk. So do you give talk about bracing, some sort of bracing forever, or
that's an important point we left out. So we definitely continue plastic or fit splints on the radial aspect. In younger children who are toddlers, above elbow. If they are cooperative children, then you could go below elbow, but ideally brace them till 18 if they are really going to listen to that.
Okay, so if there are no other questions, we go from the clubs of the upper limb to the clubs of the lower limb. So thank you, Rujuta ma'am. And to start with the clubs of the lower limb, we have Dr. Chasanal Rathod to tell us about clubfoot or CTEV, Ponseti casting and Tenotomy techniques by her video presentation.
Okay. नहीं ऑडियो नहीं चाहिए ऑफ कर दो मैं ही बोलूंगी. So good morning everyone, and now we see a very common and most treated pediatric problem, that is a CTEV or a clubfoot, and I'll take you through the Ponseti casting technique and the tenotomy technique. So initially I had a video, but I think talking here makes more sense because then it feels little connected rather than the voiceover playing. So CTEV is one of the most commonest problem, as common as 1 in 1,000 live births. And we see the key deformities, that is the cavus, the adductus, the varus, and the equinus. And they are corrected in the same order as well. So Ponseti remains the gold standard of treatment, and it is applicable for children from birth till as high as adolescence. There are papers which talk about using Ponseti technique as high till 12 years of age. It is widely accepted and followed all over the world. It's the most minimal and conservative technique which helps the child get a near normal looking painless feet, with which he can do as good activities as possible. So the word is near normal. So the further video would consist of the casting technique, how to manipulate, the tenotomy and the do's and don'ts. The suggested reading is what I have not covered is the pathoanatomy, the grading, which is the mild, moderate, severe, the various classification systems, and the modifications in terms of atypical casts and others. So a strict protocol is followed, that is, it's a standard protocol. We don't need to deviate from it. And the earliest cast begins at 2 to 3 weeks of age because the child's skin is very delicate. And that's a good time to hold the weight of the cast as well. Based on severity, at least 5 to 7 casts would be needed, followed by, when the adequate corrections are reached, which we'll see ahead. The tenotomy of the tendo Achilles is performed, and that is the only cast which stays on for 3 weeks. Rest all other casts are weekly casts and can be slightly manipulated if the patient is from a far off city or different city, then can be extended up to 10 days, because with the weight gain the plaster gets tight. So we need to keep that in mind, that these babies gain grams every day and every week. So 150 grams a week is also enough to make the plaster tight and make the child cranky. And when you open the cast, you'll see that even the soft roll has made like indurations and markings on the delicate feet. So we are going to see this 20-year-old kid, and yeah, the video was like taking weekly videos every week to record the correction. So let's just see what is happening. So the first thing is the thumb is always placed on the talar head, and the fulcrum is the talar neck. What I showed before was the medial crease and how the foot is turned laterally. So, and that's the equinus here, that's the medial crease. And based on the classification system, we can classify this clubfoot as well. And that is how the manipulation is done. So always the manipulation is at the first metatarsal head. It is only to be supinated and supinated, never pronated. So the most important take home from this slide should be that it has to be always supinated. The moment we pronate it, we will create a rocker bottom feet or some iatrogenic other deformities, maybe a skew feet, which is not needed. So the finger is placed on thumb, or the finger is placed on the metatarsal head, and just the foot is supinated. The other thumb is at the talar head, and that's how the manipulation is done. So before every cast, this manipulation has to be done for some seconds to minutes, followed by the cast application. The child needs to be positioned comfortably. Some centers prefer giving a syrup like a pedicloryl so that it's calm. Best thing is to put the child on mother's lap and ask them to breastfeed or maybe get some feed. That works wonderfully. Now, preparation of the cast is very important. We can't use the regular cast rolls which we are using. They need to be divided into half, and the 6-inch needs to be made into 3, or the 4 needs to be made into 2, so as the soft roll. If we don't do this, we'll end up with bulky cast, challenging to correct the deformities which we want to do. And cast, once they become bulky and not nicely applied, they might just slip off. So after doing all of these preparations, and once everyone is ready, the water should be slightly warm so that the cast sets in quickly. A cold water will make just life difficult. So after the manipulation, after lifting the foot in the supination, I'll apply the soft roll starting from the toe till the proximal thigh. And we usually give some time for the mother to do a tender loving care, apply some oil and just feel good with the feet, and they don't get a lot of dry skin. Once the end of the soft roll should always be secured with a micropore or a tape, because the kid is constantly moving. Otherwise, the soft roll will just pull off, especially if we are doing a bilateral casting. So it should be fixed with a micropore here. 2 assistants or 1 assistant is enough while plastering. Everyone should be positioned in such a way that the one who's applying the cast should be in front of the baby. I've picked the plaster roll, and the initial part I've just done 3 folds like a slab, because then it gives more support on the plantar side and less plaster on the dorsal side where all the manipulation is happening. So if we apply too much plaster throughout the feet, it will become difficult. This cast has to be completed till below knee. So 1 roll should go up to below knee, while one of the assistant you see is stabilizing this. Sometimes the kids' feet are very small, and another assistant to hold on the toes might be difficult, and essentially who practice every time, it's easier for them to do. Now the same maneuver, I have lifted the metatarsal head with this thumb, and I'll just not much of manipulation here. We are just holding in the corrected position. The toes should all be visible, And the plantar surface of the plaster should always cover the toes. The toes should not be clawing or hanging out of the plaster. That later causes clawing while walking, because along with the other medial structures, the FHL and FDL are also short and they need to be stretched, and this plaster helps there. So once this is done, now I'm holding it in the position which we had done the manipulation. No excessive corrections, just gentle kind of contouring. Certain contouring should be done like at the heel and both malleoli so that the plaster doesn't slip off directly, and it should not cause any pressure points. Once 2 rolls here are complete, then we need to fix the knee. The knee has to fixed in 90 degrees of flexion. And as we advance the cast, slight tibial extorsion can be done to correct one of the other abnormalities which we don't talk about is the tibial intorsion. Again, here same things, the plaster should not be too much in the popliteal fossa or around the crease, and more of the plaster should be above the knee on the anterior aspect of the thigh and the knee joint. Once this third roll is complete, then the soft roll edges should be everted on the plaster, because these edges have a capacity to kind of cause big sores for the children if inadvertently it gets soiled with urine or other things. So these key points about the plaster will continue for every plaster, and I'll not repeat this, hence I have explained them here in detail. Last is the fourth roll, which is applied again to reinforce and fix the knee, and that's it. So too many plasters should be totally avoided. We don't want to give a kg full of plaster to the child. Once the plaster is applied, we see the foot side is flat, the foot looks supinated, and it is in 80 to 90 degree flexion and extends very well up to the thigh. If it is short, it will just fall off. Okay, and the same things with what we spoke about the toes. So now this was about the first cast application. Always the parents will feel that after the first cast, the foot looks more bad because we have applied it in supination. But when we remove the cast, we see that it has corrected. The initial photo, I'll show it again later. And then subsequently, we continue to do the same supination more and more to get little more abduction always at each cast. So this is the position at the second cast. And we'll go to the next slide because the same thing is going to continue. So after the second cast is now removed, the feet which look like a J or the golf club kind of thing now looks much better, almost coming to neutral. Again, the same thing, elevating the metatarsal head, manipulating. And at the third cast, we want the feet to be neutral, or if it's a mild club feet, then probably go into some degrees of abduction. So we'll just keep a watch here. So same after the cast is completed, this is how the cast looks. So till the third cast, we are supinating and trying to correct more of coronal plane problems. We have not gone to correct the equinus yet because the talar head is still not locked in, the talus is not locked in the ankle joint. Any point of time during this castings, if we try to do a dorsiflexion, we might cause a midfoot break and a permanent like a rocker bottom feet, which is an iatrogenic thing. Okay, so now comes the fourth cast. So now when the third cast is removed, which was neutral, if I look at it here now, the position looks way better. Now the lateral border is very good. And now it's time to see Arcavus has corrected the forefoot and midfoot look really nice. And now is the time we start correcting the dorsiflexion here and accordingly get a little bit dorsiflexion. You saw from the first cast to now, the talar head is almost not visible. And this cast will continue. Okay, I'm going to skip this. Let's go to the quick slide. So this is how the feet looked before the first cast when we saw the child first. Post first cast, which is excessively supinated. Second time from the excessive J, it has covered to a very nice, like a lazy J kind of thing. And the cast gives more of correction. By the third cast, we have got a lateral border good. And you see by the fourth cast, I was able to get a little bit of small ankle dorsiflexion here, which was not seen here. It's evident here. Now coming to the fifth cast, and this is like preparation for the TA tenotomy or the procedure, which might be needed in almost 80 to 85% of the children. And many a times, like some people who are not used to applying lot of tenotomy, lot of CTEV casts, they kind of feel shy away or they don't want to do a tenotomy, which is often observed. And I think if needed, it should always be done, because then equinus is the first deformity to come back as recurrence. So we need to address that, and certain things which will have to be seen is there equinus? How is the heel? Is the heel empty or is it down like the opposite foot if it's normal unilateral? And what amount of abduction has been achieved? So at the fifth cast, if we are able to get a midfoot Pirani score of 0, that is the lateral border straight, the talar head is covered, and there is a presence of the medial crease has gone, that means the cavus is corrected, then it's time to do a tenotomy. And at this point, after this cast, we can prepare the patient for tenotomy. So tenotomy, again, the rules vary from center to center, surgeon to surgeon. It can be done under local anesthesia. It can be done under short sedation or short GA as well, in the OT, in the OPD, based on your comfort zone, how anxious the parents are, how easy or the age of the child is to handle. And the tenotomy is a simple procedure where the tendoachilles tendon is cut percutaneously to maintain the paratenon just 1 centimeter above the heel crease. And it can be done with an 11 number blade or a 16 number needle like I have used here. So it's very simple, just get in the needle or the blade in the center of the tendon, go medially and go towards the lateral. So both the sides, medial and lateral, there are vital structures like the tibialis posterior artery on the medial side as well as the nerve. And on the lateral side, we have peroneae and certain branches. And at times, it's rare to injure them if we don't have lot of movement. So the movement has to be really very fine to get the adequate dorsiflexion on the table. And the final cast would be usually 40 to 60 degrees of abduction based on if it's an idiopathic club feet, that's possible, but in an atypical, it won't be. And 15 to 20 degrees of dorsiflexion, and again, no pronation. After removing of the cast, the child goes into bracing. So the last cast remains for 3 weeks. So usually at 15 days, I open the cast so that the child can grow into it, like slit it a bit, not reapply, because we don't change that cast as the tendoachilles is healing. And there have been various ultrasound guided study which prove that within 3 weeks, the new tendon in the gap has been regenerated, and we don't need to worry about weakness or what is happening with the tendoachilles. The bracing is very simple, and again, a standard bracing. This is a Steenbeek brace, not the dynamic brace, but a young infant or neonate is okay to have this brace. So the characteristics of the brace are, it should be convex towards the patient 10 to 15 degrees so that it holds the feet into dorsiflexion. And the abduction, if it's a bilateral involvement, then 30 to 40 degrees of abduction or even more than that. And in case of unilateral, there'll be different angles that the normal will have less abduction and the unilateral will have more abduction. Post cast removal, if all the technique is followed well, casts are done wonderfully, tenotomy is done well, we are able to give almost nice, near normal looking good feet to the children by the end of 3 months of age. So these are some of the do's and don'ts, and thank you for this video. And lastly, once Sir has already extended a hearty welcome, but even I would like to invite all of you to YROC 2025. Thank you. Oh, you finished? No? You've not invited? Okay. So ma'am, let me invite. So we have the organizing chairman as Gautam Zaveri, sir, myself and Dr. Parag Lad. We are going to present this year the 60th, that is the Diamond Jubilee YROC. And we promise you a never before YROC with lot of activities which are aimed for residents, fellows, and of course for every other delegate. The social program is amazing to look forward to, and we are all waiting to welcome you. Outside, there is the registration counter. Please register for that, and also the barcode is available for the same. Where? Yeah, and all other cities, we are looking forward for you to come in large numbers and join us for this wonderful meeting. Thank you.
So, Chasanal, that was very good. And you really showed right from the first cast till the child was fully corrected. So, any of the delegates have any questions? Yeah. There.
Ma'am, what do you do if you develop a small pressure sore after, after removing one cast, you see a small pressure sore? What do you do?
So if any of these complications like swelling or sores happen, then we are supposed to break the cast or take a cast vacation, what we call it as. And particularly they are seen with atypical feet. So that's why it has to be very gentle. All the manipulation has to happen before, not after the cast application. So once you do it before, then it remains in that elastic mode to get fixed into that cast easily.
Also, as you saw when Madam was applying the cast, she was not just putting continuous pressure at one point.
Constantly.
It's always you keep moving. So hand to thumb, thumb to hand. You keep molding and moving. So then there is no actual too much pressure at one point, and that avoids.
Not a point pressure maneuver where you're pushing one side. So that is when sores come. So it's a constant movement of the hands and modeling and using both your hands to reshape the plaster.
Yeah. Till it heals 1 week, 2 weeks, that's fine. Then we have to start from the beginning. Then we can't go back where we were. Suppose it has come to the position of cast 3 and now it's slipping constantly, and or there is a sore and there's a swelling. Then if we leave it open for a week, the cavus might come back, the adduction might. So we restart. So there is no such thing as third cast then. You go back to 2 or 1, whatever the feet looks like. So it's not to chase the number of cast or what, it is always to see what deformity is present. If suppose cavus is not corrected in first cast, we need to redo till the medial crease goes away. So it's not necessary that we start the abduction quickly. So it's like a general random, like a range number. We don't need to follow it. It is very specific with the child again. Somebody might just need 3 or 4 plasters. That is also fine. Or somebody might need 7, 8 as well. The atypical one.
One question. We have someone from Gwalior who has raised hands. I want to ask a question, I guess. Yeah, you can ask a question from there.
Question from Gwalior.
Gwalior.
Gwalior, anyone? Yes, yeah. I think somebody is raising hand. I think you can tell. I think it's so. Speaker.
So we can't hear you, sir. From we are unable to hear you.
From Gwalior, can you hear me?
No, he's asking, but I think audio is not getting.
Hello.
So your audio is not heard here. It's not transmitted. Message kara.
We can ask.
Are you hearing me? Hello. Yes. We are able to hear you. Okay. Hello. Am I audible now?
Hear you now. Yeah.
Hello. Can I ask?
Yes.
Hello, Dr. Rathod. My question, how many times you can do the tenotomy while the Ponseti? Because I have seen many cases, after we have tried for the 2 times, even after correcting all the deformities, when the patient comes to the final cast removal, still there is a resistant equinus. So is there any your view on this, please?
So ideally, we should be able to get full equinus on the table after tenotomy. If we have not been able to achieve, there could be certain reasons, like maybe the talar head has not got locked into the joint, 1. Second is the tenotomy could be incomplete. And in those cases, we can always go in for a mini open tenotomy. If somebody is not well versed doing a percute, then a small incision can be taken, the tendo-Achilles pulled out, and a tenotomy can be done. I haven't experienced this because usually we get the full correction. So we shouldn't hurry doing the tenotomy until 30 to 40 degrees of abduction has been achieved before the pre-tenotomy cast. So if we try to do a tenotomy at neutral, then yes, these problems might be there. And sometimes similar problems can happen in AMC feet, that is the secondary club feet, syndromic feet, AMC feet. They might need recast after the tenotomy. Even that is a kind of rare possibility.
Only thing want to add to his question is, it's as Chasanal said, we always get it on table. Yes, there are certain feet who have had tenotomy before and are scarred. That is where the only indication is that to maybe check with an X-ray with flat top talus, because then whatever you do with your TA, you're not going to get the equinus correction. And that is where you may need something more if the feet is little more scarred because of previous procedures.
So I would add just two things. First is your
Yeah, please.
While I have operated 2 or 3 cases, this kind of resistant equinus after attempting of the 2 or 3 tenotomy, what I found that on the scarring, there is a lot of scarring and on the just above the calcaneus, the insertion part, most of the people used to do the tenotomy near to the calcaneus. So I can put my side that the tenotomy should be done little above the calcaneus
to be-
the adhesions.
Yeah.
area.
So it has to be a centimeter above the posterior crease, never at the incision. It has to be above the crease, almost a centimeter.
And then if at all you're doing revision, it has to be at a different site. You don't go at the same site again.
Right. So what I was saying is that first of all, in addition to what Chasanal said, your indication has to be perfect. So objectively, we all know that we score them by Pirani score. So before you attempt and go for tenotomy, your midfoot Pirani score should be less than 1. The lateral head of talus should be 0. So the talar head should be completely reduced. And then when you have hindfoot contracture score more than 1, so persistent equinus, that is when you do. If you have these parameters not perfect, then it's too premature, and that is one more reason where you do not get the adequate correction. So your indication has to be right. In addition to what she said, doing a complete tenotomy, especially when you're doing under local anesthesia, not taking under general, then the child is quite, sometimes kicking and you are not able to do it. So you end up doing incomplete, and that is where you will not get a good dorsiflexion. Secondly, just to add a little point, many times when you have done a tenotomy, there is a lot of bleeding. So always put some pressure for about 5 minutes, control the bleeding, and then give the cast. Don't be in a hurry to give the cast, because otherwise, post-operatively, there is soakage and the parents really get worried that there's too much of soakage and there is bleeding and all that. So achieve hemostasis, because when you're cutting, there will be some bleeding. So achieve hemostasis by just putting little pressure and then give the cast. So that will reduce apprehension from the parent side. Any other center has any other question or any other delegates? Yeah, Ankita.
Ma'am, do we always?
Yes.
Yeah, sorry.
So, ma'am, we use a blade for the tenotomy. I just wanted to ask you, how do you ensure the adequacy of tenotomy using the needle? So,
same as the blade. So the bevel of the needle works like the cutting edge of the blade. So it's same. It's just personal preference. Yeah, so the bevel is very long. Yeah, okay. So we have a question from Jalandhar.
If the patient presents late, maybe around the baby is 9 months or a 1-year-old, we still start with the Ponseti technique. And in these children, when their feet have grown up, do we give a below knee cast or do we still go above knee cast? But is it mandatory to go above knee for correction, or it is just given above knee to prevent the plaster coming out?
So the initial cast, that is the cavus correction cast, can be below knee, but subsequently, as we want to dorsiflex and the tendo-Achilles, which is crossing the knee joint, we also need to relax that. So the primary thing is to relax the tendo-Achilles. Second is to prevent the slippage. So ideally above knee joint, above knee casts are the recommended ones. But yeah, the first cast, there are some kind of modifications or suggested papers which talk about this. But if we follow the standard Ponseti, all casts have to be above knee. But yeah, certain walking children, we can kind of get away with the first cast being below knee. That bit.
Just wanted to add, so when you start abducting, lot of the times some abduction can come from the knee joint. So one is you want to prevent that as well. So in walking children, we go above knee, but we don't give as much flexion as we give in babies. Baby only 30-40 degrees of flexion at the knee.
Just
yeah.
Just wanted to add on a couple of points when someone asked about the bleeding. So make sure that you keep pressing till the bleeding time, clotting time. So at least that is over and the clotting time has just started. I mean, even the above knee thing is there are a lot of papers on walking and all. Then you use synthetic casts and then they will end up breaking the cast faster. So I think more practical is to really follow what is best from the science point of view. And yeah, about the hemostat also to adequacy of tenotomy, which Ankita asked, you can just put a small hemostat inside your tenotomy incision and make sure, just twirl it around and make sure that there's no tight band left. Be careful, you might be end up feeling the saphenous vein also as the tight band. So that's going to come up with a little bit experience. The feel of a tendon and that grating as against a tight cord-like structure.
So you can feel the palpable gap. Once you have done it, you get the snap and you get the dorsiflexion. These are the three on-table indication that you have done it adequate. Secondly, about the age which someone asked, I think as of
कॉम्प्लीट कर देते हैं मुंबई वाले साला छोटी सी चीज विराट सर बिल्कुल 2 स्टेप में से क्लियर कर देते हैं वो इनसे सीखेगा भाई वो तो फंस जाएगा
So about the age limit, somebody was asking. Now the consensus is to start with Ponseti technique, whatever age the child comes. You may not achieve complete correction like you see in a younger child, but at least the amount of deformity will get reduced and then you may end up doing only limited surgery for the final correction. So start with Ponseti and then judge serially how the correction is happening. Any other questions from anybody else or any other center?
They don't want to learn more.
So I think those who want can grab some coffee or something. We'll continue with the course. And so thank you, Chasanal, for that wonderful video. Grab your coffee and come back and then, yeah. So now we've had some couple of developmental conditions and we wait for some time, or I think. Yeah, okay. So in 5 minutes, we restart.
Good morning. We are doing this orthopedic surgery course. So we will just go for a formal felicitation program. I invite Dr. Vaidya sir to please come over here.
Good morning, everyone. I would like to welcome all of you for this Friday meeting. I hope you are enjoying the live surgery sessions. So I welcome our dean, Dr. Agashe. Please come forward. He is with us to encourage the young orthopedic surgeons of the city.
Sir, please. We'll start off. Yeah.
Cameraman यार back आएगा सर में चक्कर
नहीं माइक नहीं
सर साइड सर प्लीज
हाँ म्हणजे ते ऑन कर ना नेक्स्ट वीडियो चा
अरे साइड फेस करिए सर
कौन से
पूछ लो उनसे
बाकी सब लोग ऑन
So I was just saying we had a couple of interesting developmental and congenital conditions in the morning, covering the hip common conditions, the foot, upper limb. And now we move on to some more common practice and presentations, which even adult orthopedic surgeons see in their day-to-day office. And one of this very, very common is a cubitus varus deformity happening post malunited supracondylar fractures. We all see many supracondylar fractures, and if they're not treated perfectly, then many of these children present with cubitus varus. And how do we correct that? For that corrective osteotomy technique. So now in this module, we have 3 deformities: cubitus varus post malunited supracondylar fracture, cubitus valgus following non-union lateral condyle, and then we have the
I invite
genu-valgum.
Anupam Gupta, sir, please.
So first,
Anupam, sir.
I invite Dr. Avi Shah for demonstrating the supracondylar osteotomy for cubitus varus.
Thank you so much. After that avid discussion on congenital, let's move to malunited, which we hope not to see much, even though we treat a lot of pediatric trauma and my colleagues as well. We see supracondylar fracture, which is extremely common. We still see a lot of malunited supracondylar fractures in our day-to-day practice. So one is we should be treating these fractures much better to reduce the burden of cubitus varus, but still it is common practice for us to see these. So as with cubitus varus, there are a lot of techniques in literature, and people may argue one technique is better than the other technique based on their experience. I'm going to be talking about a simple technique which I feel is easily reproducible by anyone, anywhere. It's a biplane oblique lateral closing wedge osteotomy with an intact hinge. So I feel this technique is very simple. It is very quick and easily reproducible as compared to some of the more complicated techniques which are out there. But to each surgeon his own and his own experience. So let's move ahead. So this is the case. This was a 3-year-old child. He had multiple elbow injuries, displaced supracondylar fracture, humerus at age 1 year. Was just treated with back slaps. Unfortunately, I have not. I have the X-rays, but I didn't add it in this video. Sorry about that. The initial treatment, the fracture was displaced in slight varus and extension. So he was treated elsewhere with this fracture united, and then the child was told to go home. Now he presents with a deformity 2 years post his injury. So you can see on the right side, if you compare to the opposite side, he has a cubitus varus deformity, and he has some amount of limited flexion because of the deformity. So we need to know supracondylar is not just a uniplanar deformity. It's actually a multiplanar deformity. So there is a varus, there is an extension, and majority of the times internal rotation as well, which is a component a lot of us neglect. So in basic examination, when these children will come, you will see an decreased carrying angle compared to the other side, limitation in range of motion at times. A lot of the times they will come with hyperextension at the elbow, and there will be an increased internal rotation when you compare to the opposite sides. So try to take good x-rays. So one is a good lateral view. So in a lateral view, you want to make sure how much of hyperextension or extension is present in the distal humerus. So here, if you draw the anterior humeral line, there is very minimal hyperextension noted. So the line just about touches the capitulum. So you may or may not do anything about it, because we know the child is young and deformity in the plane of the movement always remodels. Other deformities which are not in the plane of the movement of the joint will not remodel. So our internal rotation and varus do not remodel. Hence, this needs treatment. So you can wait up to a year of remodeling post injury, but you don't need to wait more than that to do the surgery if at all you need to go ahead. So get good x-rays of both the upper limbs to do your planning of the amount of correction. A lot of the times initially, we used to do these surgeries with just eyeballing and compare it with the other elbow on table. So always the patients would not be very happy, because they would still find it undercorrected as compared. So as with innovation and precision, as we talk with Vairog, things advance. So we go more for planning even with these kind of osteotomies. So for planning, what do we do? So one is you measure the carrying angle. So the carrying angle is measured by the axis of the humerus and the forearm. So here, when we measure, the carrying angle is -16 on the affected side and 8 degrees on the normal side. So we need these measurements to plan our deformity correction. Then in the forearm, there are two angles that we use. So initially, we used to use the humero-ulnar angle. The problem with that angle is the forearm is not on the axis; it's on the axis of the ulna, and we don't want to base our correction based on the axis of the ulna, but should be based on the a mechanical axis of the forearm, as we do with lower limbs. So nowadays, we use what is known as the humero-elbow-wrist angle. So it is the anatomical axis of the humerus, and the center point. You take two lines, one at the level of the ulna and the bicipital groove, and the other at the level of the wrist, and mark the midpoints of these lines and draw a straight line. So the angle formed by this line and the humerus line is the humero-elbow-wrist angle, and this is the angle which we use to plan our deformity correction. So here it is -16 and 8 degrees. At times it may match to your other angles. At times it may show a different degree compared with the other angles that you would have drawn previously. So in our planning, so the normal angle plus the affected angle. So it is -16 plus 8 degrees. So that is the amount of correction I want to match it till the other side. So that is 24 degrees. So now the technique which I'm going to be showing is known as a lateral oblique closing wedge. In this, we have a triangle with a base. In this triangle, both the lengths of the triangle can be either equal, or the length of the superior part of the triangle or the more proximal part of the triangle can be of a longer length as compared to the distal part. So on your planning, just draw a triangle with the angle that you have measured, that is 24 degrees. So just make a triangle, place it on your X-ray. The hinge is at the medial epicondyle. The lower base is just above the olecranon fossa, and the other line is proximal. So you draw this triangle. So then the lines, as I said about the distal cut and the proximal cut, the length of the proximal cut can be a little bit longer as compared to the distal cut. And then you measure the base of the triangle. So this is extremely important because the base is what you're going to be using on table to make sure you're getting the same angle on table. Yes, people say they can use triangular stencils and other markers as well. You can use those as well. Sometimes they're difficult to get, especially we operate in a lot of centers where there are limited resources. So this way it makes your job very, very easy. Make sure these X-rays are 100% view. Otherwise, whatever measurement you do will be wrong. So the positioning is quite standard. In the theater with a sidearm board, tourniquet, the X-ray comes from the lower end. Make sure the screen is in front of you so that you can easily see the screen. So a tourniquet. So I always mark the incision of where I'm going to be doing. So I mark the upper border of the olecranon fossa with a mosquito or a hemostat, because if you'll see, this is a very small and cosmetic incision. We don't do big incisions at all. So usually our incision is hardly more than 2 centimeters ever in this, because you can correct up to 30 degrees of angle of deformity with just within 2 centimeters of your incision. So once I do this, I raise the tourniquet. So then the dissection is quite standard to a lateral approach to the distal elbow, the interval between your brachialis and the triceps. So you open the interval and you're straight at the humerus. You make a nick over the periosteum and gently with a periosteal elevator, elevate the periosteum only in the area of where we are doing the osteotomy. And the periosteum is elevated more distally towards the medial epicondyle, because that's where our hinge is going to be. So you want to elevate the periosteum on both sides. So initially I put metal homens till I know I have elevated it nicely, and then I will exchange them later with radiolucent ones. Having these radiolucent homins is really good because it makes it very easy to use them while doing your osteotomy, and they don't come in the way. So now I'm switching it to the radiolucent homins. Yeah. So now the next step will be the marking of the osteotomy. So you take two small marking K wires and you mark the osteotomy as we planned on the X-ray before. So this K wire is going to be going in an oblique manner just above the olecranon fossa towards the medial epicondyle as we planned in our X-ray preoperatively. So it stops half to 1 centimeter before the epicondyle. And then this is the base. We measured it preoperatively as 1.4 centimeters. So you mark it on the humerus, and that is where your proximal guide wire will enter, and you direct it towards your distal wire to make them somewhere meet just near the medial epicondyle. So once the marking wire is done, pre-fixation wires are inserted. In pre-fixation wires, you need to be careful. You're going to be a closing osteotomy. So the wire should be exactly parallel to the lateral column. Because if you're towards the medial column, it will not give you enough hold when you close the osteotomy. So I put two parallel wires parallel to the lateral column just till the osteotomy site, and then you stop there. So now we are ready with everything to go ahead. You check in your lateral view, you're perfectly in the center and have good hold for your wires, because once this is done, you don't want to be changing anything and going back in any of these steps. Next, with the saw, you complete the osteotomy. So with the saw, with a small blade, you go and you stop just before your K wires meet. You don't want your saw to go more ahead and break the hinge that you have kept intact. So you do your distal and proximal cuts with a oscillating saw. So there you can see your blade just stops before where the K wires meet. You don't want the osteotomy to propagate more medially. And similarly, after the distal cut, you do the proximal cut. Then once you have done your cuts, use a small osteotome and make sure your cuts are completed and they are meeting at the triangle where you want them as you planned with your K wires. So you finish off your osteotomy with a small osteotome, and then you can see the entire piece just nicely comes off in a nice triangular manner. There is no force or nibblers needed. And once this is done, the osteotomy is closed. If at all you want to correct any hyperextension, you can just nibble off the anterior cortex on the proximal segment of the humerus, and that gives you correction even of the hyperextension. So here you see, using the K wires, we just close the osteotomy, keeping our medial hinge intact. So everything is completely stable. You can see the deformity is now corrected. You have good bone-to-bone contact. And once you have made sure your deformity is correct, you recheck your arm and check your carrying angle, and then you just have to pass the wires till the opposite cortex and fix your osteotomy. So everything is stable, it is quick, because all your pre-planning and your wires were already ready. So once you cross it, you just confirm the deformity correction and assess your fixation in both the AP and lateral planes. The one question is, can you correct? So here I have not corrected the hyperextension because I know it's in the plane. It is very minor, so I have left it. Internal rotation can be corrected. People say, oh, if there is an intact hinge, how can you correct internal rotation? This technique does allow you to correct internal rotation. So if you want to correct internal rotation, you just give slight translation of the distal fragment when you're closing it. It can give you up to 20 to 30 degrees of internal rotation correction. But if your patient has a very severe degree of internal rotation, then I may not choose this technique of cubitus virus correction. So that preoperatively we need to check as well. So now here you can see once you have closed, everything is extremely stable. You can recheck, you can see there is extremely good contact because there is a long surface area. It is very good healing is there. It heals as soon as like a normal supracondylar fracture in 4 weeks in younger and up to 6 weeks in an older child sometimes. The K wires are bent, cut, kept outside of the skin so that they can be easily removed in clinic once the osteotomy heals. So you can see here good contact of the osteotomy that we have done. I close the periosteum and you close the muscle layers, the subcutaneous layers and the skin after that. Oh, sorry about that. So you close the skin. And a nice dressing, foam and good padding is given. You don't want any of these wires irritating the child. And after the dressing, a nice well padded back slab is given. Majority of the times in young children, I don't need to change it into a plaster at all because I know in 3 to 4 weeks it is going to heal. So a good, nice, well padded back slab is good enough for the entire treatment. If at all we feel this child is going to break your slab, usually at 4 or 5 days when they come in clinic, we just wrap a plaster roll above the back slab. We do not change or remove or do anything in the clinic at all. So you can use either a soft cast, which is easily available, or any fiber plaster, just a single layer above the cast so that it does not break. So as you see here, we give a nice well padded above elbow back slab. So in children, be very careful. Your back slabs, a lot of the times it irritates in the thenar crease and it causes itching. So we give a nice lining of a stockinette inside, then a soft roll, good padding, and then a nice above elbow back slab with good molding. So this is our final. So once the back slab is set, we just recheck the final image. So you can see everything is in place. A good above, a nice arm pouch is given. So as I said, most of these patients get discharged either in the evening or the next day. Very rarely they have lot of pain because there is usually very minimal bleeding if everything goes well. K wires are removed in 4 to 6 weeks. Elbow active range of motion, no passive range or physiotherapy is recommended for this. The arm pouch is then weaned off gradually and they can resume most sports and all activities by 3 months. We try to go slowly with children and not allow them to go sooner, even though they may be able to. So, yeah. So this is the follow-up of this child. This is 1.5 years. So you can see the correction is good. You can still see there is slight limitation in flexion compared to the other side, but better than what it was preoperatively. So I know this is remodeling with time. So I usually counsel the parents that give this couple of years, that remaining flexion will also come back. But usually it is functional and it does not have any bearing with any of their activities. It is just sometimes cosmetic. So thank you so much. And I'd like to even thank my fellow who helped me during this case. Otherwise, it's difficult to do these. But I feel this is quite easily reproducible in any setting because it's very simple. It's just 10 minutes of planning before the surgery and then everything goes smoothly. Usually our tourniquet time is hardly 20-25 minutes doing the procedure.
So thank you, Avi, for the wonderful demonstration of a very common procedure seen in all. Yeah, Tushar, you wanted to ask.
So you mentioned internal rotation.
Yes.
So there are articles which say that the patient came to you with varus. He is not really aware of the internal rotation.
Yes.
So we can sort of very well not focus so much on the internal rotation. However, for a lot many cases, I was not focusing on the internal rotation, and I found that in spite of correcting the varus to valgus,
They
you
still
would
keep it.
rotate a little. So I started focusing more on internal rotation. Then we did 3D planning software. We took the bicipital groove to the epicondylar edge. And surprisingly, even for a patient who's working like this, the internal rotation deformity is not very high.
Yeah.
It's always 7 degrees, 9 degrees. It's never more than that.
Yeah.
So it's predominantly always the varus.
Varus, yes.
So I think for the purpose of this talk, we should, though it is a three-dimensional problem, but if you feel that it's very tough to correct everything, focus mainly on varus.
Varus, yes.
Secondly, in your case also, no, you noticed a little lateral prominence. So that is always a slight, it creates a little pseudo-varus kind of a feeling, which is going to remodel.
Yes.
In the osteotomy which you do, there is automatic translation.
Yes.
There is no requirement for
Yes.
translation. But if somebody is doing an osteotomy which is not the double
So
oblique
then they need
osteotomy,
to translate.
they will have to intentionally
Yeah.
translate. So I was not translating it before, and I found that it is very,
Yeah.
very important to translate it.
So that is why we switched to this technique, because one is you don't need to translate. Everything is inherently stable. So there is an article known as lateral prominence index. So when they compared all of the other techniques, this had the most minimal lateral prominence that we could achieve.
At the end of your correction, the long axis of the humerus, the diaphyseal axis, should be in the middle part of the distal.
Yes.
If it's not, then it is
Yes,
still lateral.
that means it is still lateralized. So again about the rotation, you write.
One more thing.
Yeah.
If it is really more than 30 degrees, then this technique will not work because you will have to go very high.
Yes. So as I said, your
take
30 degrees is your limit, because otherwise your proximal cut is very high, then your radial nerve comes in your way. So up to 30 degrees, this is, as I said, there are different techniques. You choose your technique based on what you need. So by and large, majority of the times what we see, I would say 90% to 95%, this fits into everything.
This should be now promoted as the go-to technique for sure.
Ajmer, good morning. Any question that you see in clinic, Malunited, so very elegantly shown by Avi? Any questions from Jalandhar, Gwalior?
Yeah, or do they do this technique differently? Because there are many different, so many osteotomies described for this
there-
particular. If you go through literature, there are
More than 100 plus ways of doing it.
So anyone else has been doing it in some different ways or has any opinion about this technique?
Yeah. Jalandhar. So, Avi, at your, what I noticed was that if you look at your post-op X-ray, there was still the arm was slightly internally rotated over there.
Yeah.
Now, is this the pseudo varus which was Tushar was talking about, or was the even the X-ray did not show the typical alignment? It did show as though there was a rotation of the distal fragment.
So in this child did have, so I have correct to a certain amount. So usually what happens is a lot of these children, because they have compensated for many years and have been using their arm like that. So a lot of the times, even if you have corrected the rotation, as soon as you tell them to put, that is the lie they put in. And that pseudovirus, though mild, may make it look even worse when the opposite person is seeing. So the photo might not have been great, but if you actually tell them to properly supinate and hold the arm out, it is matching to the other side. But that compensatory mechanism takes a long time to go.
Does the technique change depending on the amount of rotational correction that you want? Suppose your primary job is varus correction, you might want to choose this technique.
Yes.
But suppose you want to do more of a rotational correction, would you choose an alternative technique, or would it still be the same technique?
So if the rotation is within less than 30 degrees of rotation, the same technique easily works. But if it's a very big rotational correction that you need to do, then with an intact hinge, you cannot do that. Then we would change the technique of how we would do. So as Dr. Tushar was saying, there is, if our rotation component is high, then a lot of the times we do higher planning with CT scans, and nowadays 3D and jigs are there.
Hello.
So you can.
Without that also the classical modified French osteotomy,
osteotomy.
which was described to correct the way you place the osteotomy and translate and rotate. You can correct 3 dimension by just doing a simple transverse rather than oblique.
Oblique.
Yeah, Delhi, please go on.
Any insight for the translational osteotomy? That deals with
so
the.
can
any pointers for the translational osteotomy?
So if you're doing the normal osteotomy, like if you're like the most standard way is you do your distal cut just above the olecranon fossa, parallel to the joint, and then you take the cut above, you close it. If you're doing that method, that is absolutely fine. But in that method, like we were discussing, you have to translate. A lot of people don't do that translation. So you have to translate the distal fragment.
Because at our center at MAMC, usually what we get that child or some adolescent kid reaches to us with the deformity of like 25 to 30 degree with the rotational component also. So in
Yes.
those scenario, we prefer to do step cut translational with the fixation with the
No,
white.
so as I said, step cut is also very good. I also do it. But what I'm trying to say is there are a lot of ways of doing the same thing. Some are complex, some are easy. So by and large, this is a very simple way of doing majority of the times. But there are certain times where we need to change our plan. So in older children where our deformity is more than 30, more rotational component, we can use the step cut, we can use the dome. There are a lot of different ways of doing it. It's not that this is the only way, but 90 to 94% of the times, this fits into majority of the patient we see and is easily reproducible by most people. Step cuts require a lot of different cuts in different planes. If it doesn't go right, things don't fit in. Your approach is much more extensile. You have to sometimes go through the posterior approach to do all of these things. They're much more bigger surgeries as compared to.
So, Avi, let's
agree
bring
to
it
that,
down
but,
to a- let's bring it down to a boil and say which osteotomy for how much correction. So the considerations are the amount of deformity that you have.
Yes.
Whether the deformity is primarily varus valgus or is it internal rotation. So this standard osteotomy, which you said, which Tushar said has become the standard of care these days, most accepted, is primarily for a varus deformity, which is where the correction required is less than 25 degrees, where there isn't a significant internal rotation. Now, if there is a significant internal rotation, what would be if there is a deformity which is more than 30 degrees and multiple, like the people in Safda facing what choice? Give us.
It is more than 30 and a severe rotational component. So one option is the step cut osteotomy, or you do your old method like the French method and you do a good amount of translation once you correct your deformity. Other is some of my colleagues are doing a dome osteotomy as well. So dome also allows you to do both of these correction. So unfortunately in our pediatric literature, we don't have direct comparison with each of these techniques. A lot of these techniques are as per what has been taught and what the entire group thinks is now standard of care. But that does not mean even in this you cannot do a step cut. Again, sometimes it is surgeon dependent. We don't have an exact algorithm up to 30, this much rotation. Strictly, it is this osteotomy, but it is simple. So all over the world now, people are doing this because it is reproducible and easily matchable to all of the results.
Yeah, Delhi, does that answer your question?
Yes, it rightly pointed out all the things. But just to add on that, I feel, in my opinion, that for the rotational component, if we do the lateral closing wedge osteotomy with the lateral approach, when we do some rotational component, the medial hinge gets broken down and it becomes very unstable. And we feel that it is.
So that's why about medial hinge, your rotational component within 30 degrees, the hinge will not break. It just green sticks. But if you try to do a severe rotational deformity, then yes, the hinge will break. It becomes like your old French osteotomy. And in that, you can correct the rotation. If your hinge is broken, translate the segment. It becomes like your old French osteotomy, but just in an oblique manner. So it can happen if your hinge breaks. Like your HTO.
1 minute. So the boss there is saying that there is more than 30 degrees internal rotation. It is never there.
Yeah.
If you
It is rarely there.
do a 3D planning with a CT with the bicipital groove and your epicondylar axis, it is illusional internal rotation.
Yes.
You are feeling that there is so much of internal rotation. It's always predominantly varus only.
Yeah.
With CT planning.
So the varus also makes the internal rotation seem to be exaggerated than what it exactly is. So a lot of the time we do clinical examination and we feel, oh, internal is more because the varus exciting. So when we straighten it, then but the patient is still keeping his arm turned inside. So oh, we have not corrected the internal rotation. So it is not exactly that. So the varus is the main component. But if you have clinically proven with CT or something that yes, it is the internal rotation really which is the thing, then it's a different matter. But very rarely internal rotation is that big a component in this deformity.
Another point for your point about stability, what you said. So this oblique osteotomy has advantage that your wires are going perpendicular to the osteotomy. As against if you're doing a transverse, then two lateral again you have to put divergent and you otherwise you have to put medial. Here because it's an oblique osteotomy and both your wires going from lateral, they are perpendicular to the osteotomy, it makes it more stable. So this question, because we have small bones, you can't put plate, otherwise you have to go high. So this K-wires is a sufficient amount of fixation and oblique osteotomy makes the fixation more stable. So it heals beautifully.
So I've treated up even 10, 12-year-olds with this technique and it is extremely stable. Very rarely we've ever had to do a plating in any of these children, even in the older ones who come to us.
So lovely. Thank you for this presentation. Let's move to the next one.
Yeah, so next now, Anand, you have some question? Yeah.
Along with the varus, if there is an extension component of the deformity, can we add?
Yes. So as I said, so this is a biplanar. So normally it is very difficult to do your saw cut and this thing. Some people can do it in precision. So what I do is, if at all you want to correct your extension, you just nibble a little bit of the anterior cortex of the proximal humerus segment. Just a little bit. It's soft bone. So when you correct it, it compresses that and it even corrects your hyperextension. So if you, and in this, it inbuilds, if you feel you're under, you can always nibble more and get it. So it still gives you play to add and subtract things.
And up to 30 degree of deformity, you don't need any translation.
No, so in this, there is no translation. It doesn't need to, because of the way the osteotomy design is, it auto translates the mechanical axis. You don't need to do it separately.
If your child is less than 10 years of age, don't focus too much on the hyperextension. If the child is more than 10 years of age, focus on the sagittal plane deformity.
Yeah, so yeah, next
And
now
invite Dr. Binoti Sheth or the another osteotomy that we are going to see for deformity correction.
Yeah, so now we have a reverse deformity, that is a cubitus valgus. And the most common cause for this is a non-union lateral condyle. So like you can see in this child, he had a lateral, he's a 14-year-old boy who had a lateral condyle fracture, which was not united. And now he has got a cubitus valgus. You can start the audio. I think you go back because the audio. So now we just showed us the wonderful planning about how to calculate the HEWA. So I'm going to take you straight to the OT where I have performed with my audio and I'm doing the planning on table, but this you can do pre-operatively to save your operative time. So this was non-union lateral condyle. The main concern was cubitus valgus. The child with both upper limbs, with elbow in full extension and foramen supination. You can see on the right side there is excessive cubitus valgus with the elbow in full extension and foramen supination. Now we have to calculate the angle of cubitus valgus. So you calculate clinically the carrying angle and also radiologically you have to check the HEWA angle, which is the humerus elbow wrist angle, which represents to the maximum extent with the clinical carrying angle. So I will show you how do you do it. So the humerus axis is drawn by joining 2 points, 2 midpoints at 2 levels of the humerus shaft. So this from cortex to cortex is about 1.8. So I will put 1 point at 0.9. And the other point, this is 2.2. So at 1.1. So I will join these 2 points. That will give me the humerus axis. So that is the humerus axis. Now, how do you draw the forearm axis? So you take the midpoint at the level of the radial tuberosity. So at this level, this is about 2.8. So I will take 1.4, 1 point. And the next point is at the maximal radial bow. So there the bow is maximum. At that point, I will take the midpoint. So this is 4. So I will take at 2. And again, I join these two. So this line is representing the axis of the forearm. So this I'm going to extend right till where it cuts the humerus. Okay. So this is the line. So now what this will give me, one is that when I calculate this angle, that will give me the actual angle of cubitus valgus, which in this patient is 28 degrees. The other side we had calculated was about 14 degrees. And now this will give me the level of the osteotomy. So where it is cutting the medial humeral cortex, that level we draw a line perpendicular to the humerus shaft. So this is the axis. Here we draw, we take ideally with a goniometer if you have, you take one line. So that's going to be the level of the osteotomy. So intraoperatively, you can see how much is the distance because this is going to be our incision. We will be able to see this area and then that will give an idea where is going to be our cut. So this is a true size X-ray. If you do not have true size, you can make corresponding cut. So this was coming out to be 0.8, which we will project in our surgery. Now what we do, so the planning will be first, I will fix the lateral condyle in situ. I will clear the fibrous tissue at the non-union area and I will fix in situ. So my this distal fragment becomes 1. And then I will do the osteotomy at this level. Now this osteotomy is going to be, it's called the Milch open wedge angulation translation osteotomy. So that's what you can do a pre-operative planning. So you draw on your trace paper so you can see how much angle we are going to correct and how much opening is required to go back to that angle corresponding to the opposite side. And you translate it so that the axis is corrected and your abnormal prominence, which we have been talking about in cubitus varus, is not there. So that is the purpose of doing, because if you do a pure angulation there, there'll be an abnormal prominence and bump on the medial side. So you have a pseudo correction will not appear well clinically. So that is why you angulate and also translate in addition, in order to get a good cosmetic correction in addition to the radiological correction. So then this planning you can do pre-operatively. This just for the purpose of demonstration. So the child's right upper limb is on a bolster. We've applied the tourniquet. As you can see, this is, so again, you can do this in a supine position or in a lateral position. I'm more comfortable. It's the position is not any issue. Right side elbow, we are seeing it from posterior side. There is cubitus valgus. That is the lateral condyle fragment, which has gone proximal. It is non-union. We are taking a posterolateral approach and we will be reflecting the triceps on the medial side. So the standard skin, subcute and deep fascia, and you can easily retract the triceps on the other side and you go straight to the bone. You incise the periosteum and then you are on the bone. So the purpose here is to do in situ fixation for lateral condyle to give some stability to that area and then obviously correct the deformity. I am on the lateral surface of the humerus and this is the lateral condyle fragment, which is non-united. I'm at the non-union site. So clear all the fibrous tissue from there, whatever is hampering in the non-union site. Yeah, you can see the fibrous tissue in the non-union site. Just trying to clear the fibrous tissue from the fracture end. Now, since we have the fracture surface well visualized, so once you have cleared the tissue, you see good bleeding bone, then you put wire, you need to fix it. Okay, so one wire was put which was not in the right plane. So this was just then revised or cleared of the soft tissues on both the sides. We are just wanting to compress it by putting the screw. Yeah, I can see it coming out. I can direct it on this now. So this wire is going till almost, we did not pierce the second cortex. We just have to have a hole. So we will take this as the length. It's coming as 30. So we want a 30, 4 mm cancellous. You can see that gap is become on the mid. Distally, it is quite compressed. Proximally also, compared to earlier, the gap is reduced. It's okay. It is gone in the proximal. It is just to control. So this wire, which was for, once you fix the lateral condyle in situ, then you're going for the osteotomy. Before that, just as we had also shown, to control the distal fragment, you can put a provisional wire just in the distal fragment that will allow after the osteotomy to control the distal fragment. So that is just a provisional wire to control the subperiosteal, because now I'm going to do the osteotomy. I have to make the area clear to protect the anterior neurovascular and the medial ulnar nerve. From our pre-op evaluation, the site of osteotomy where the distal forearm axis meets the humerus is at about 0.8 centimeter above the most prominent point. So that's the most prominent point, about 0.8 centimeter. That's the prominent bump, just above the site of non-union, and 0.8 centimeter above that. So roughly at this level. Okay. So if you can see, that is well above the level of our olecranon fossa, and it will, that this cut will be perpendicular to the humerus shaft. So I will show this with a K-wire on the C-arm. Yeah, so that is okay. That's the area where we're going to. So I just mark it, I put a wire. Where I mark it, I put a wire on the humerus only, and then just check it on the C-arm. So if it's okay, then I need not pass additionally just a wire. Just you can do both ways. You can pass a wire just as a control, or you can just mark with a marker pen. That I've confirmed. So this is not passed through the bone. It is just at the level of marker. I've put it on the posterior surface of the humerus. So, and again, osteotomy, either you can use a saw. I'm more comfortable with multiple drills because you have all your neurovascular around. So I'm more safer with the multiple drill holes and then joining with osteotomy. So that is above my area of the screw. Try and join the holes. This cortex fire sound. Some part of the anterior cortex is still left. So this is, if you just, now it was in valgus, whole cortex is corrected, and but now this will lead to abnormal. So if you just leave it like that, just like an open wedge, the angle is corrected, but you will have a very prominent bump on the other side, the prominence. So that is why you need to now translate it to some extent in order to have a good cosmetic correction also. Normal translation. So we will now translate it. I have the control over this. The entire osteotomy is opened up. Now this step is important. So I've translated it and I have centralized. So the spike of the medial cortex proximal end sits in the center. Okay. So this is angulation translation osteotomy. And this is my eventual valgus angle. That is what is the angulation translation. You see my distal fragment has not only angulated, but also translated laterally. So actually the spike of the medial cortex of the distal fragment has come at the center of the proximal fragment. Made a little notch in the proximal fragment where my distal fragment can move. Yeah. Okay, so this fragment is sitting in the notch. So now we will try and pass it this way, and then one more from the lateral side. So the first wire is going intramedullary. So that little notch which is created in the proximal fragment allows that spike to sit there, and that makes it very stable. Otherwise, it becomes very unstable. So that notch really helps in improving the stability. That we will change. We will remove this one. Show the lateral view. You can see on this area also, we are pretty stable because of the inherent notching and putting the distal fragment in the proximal notch. Even while doing flexion extension, it is not moving much. And right now we are just on 2 wire. Clinically, normal cubitus valgus. So that is the humerus axis, it is the forearm axis, and we have the normal valgus angle. So we will put one medial wire, and then we will revise this. So we'll take a small stab. So we've taken a small incision on the medial side. To see how the osteotomy is, we have done the angulation. So from the lateral, we have angulated it, and we have translated such that the spike of the distal fragment is sitting well in the notch. So this is a very stable osteotomy, does not require any plating, and the child will remain in plaster till the osteotomy unites. You will see after a while the entire area gets filled with bone because of the raw surface here. We will do little shingling on this side so that this cortex also unites. And because of this alignment, eventually the lateral condyle also unites. So the aim is just to stabilize it. Many times because of this, there is union at the lateral condyle also. But the osteotomy unites well, and once it unites, you can have a good normal shape of the distal. Right now it is looking tilted, but eventually you will have the nice shape of the distal fragment. So we are happy with the fixation. Now what is left is just cutting the wires, and we will make some drill holes to make little draw area on the cortex, and we will take final shoots, and then we will close. It should be enough. There is some cortical groove bout in, because possibly that is the way it will be. It will be difficult. And we have a screw with a washer compressing the lateral condyle non-union. Yeah. So all the wires are inside, and the alignment is good. The anterior humeral line, the teardrop, everything looks good. Okay. So the patient had full range in preoperatively, and post-operative also the patient has. So what I mean is intraoperative actually, we assess the range. Full range of motion. Okay. And he has got a normal valgus. You can see from posterior. We'll just close over drain. So that was at 6 weeks. You can see initially we had some raw area or some gap there, but it nicely fills up and gets corrected well. So that's the X-ray at 3 months. you see that completely there is bone formation and you have a normal cubitus valgus now from what you had excess cubitus valgus. And clinical correction also. The non-union site is also uniting. So from what you had, an additional cubitus valgus excessive is corrected well. This is just 3 months. This child did not have any tardy ulnar nerve palsy. If that would have been there in addition, then you do additional procedure of anterior transposition of the ulnar nerve. And he is just, because he was 6 weeks in plaster, now he started doing range of motion. There is terminal range is still restricted, but we with time, I think it will improve. So that is a 3 months follow-up. And from what you had, a non-united lateral condyle with significant cubitus valgus, you have a normal carrying angle, normal valgus, and the surprisingly not doing anything, just freshening and compressing that area. The lateral condyle also seems to be uniting. So that's the final result. And he's undergoing further remodeling will happen. This is just 3 months post surgery. Thank you.
So thank you, Binoti. That was a fantastic demonstration. A few questions. Number one is the need to put an intercondylar screw, considering that it's a lateral condylar fracture. You've just fixed it up into the pillar.
There's no need for intercondylar. Here, we are not doing anything to the we are not recreating and going and, getting the normal anatomy, because if you do that, go intra-articular, then the chances of stiffness are very high. So we just want to have the lateral column more stable so that they can do heavy work. So the more problems in lateral condyle non-union are 3. Either they have instability and difficulty in doing heavy activities because non-united fragment, you have the deformity cosmetic thing, and a tardy ulnar nerve palsy. So the aim is not to create and have a normal articular congruity. And then that is where you go inside, go in the joint, and you can put correct screws. But here, this screw is enough. Even for acute lateral condyle, we never put a intercondylar.
Since you went by a posterolateral approach, the risk of avascular necrosis.
I'm more in the metaphysis. I have not got anywhere there, and it's quite lateral. Now, even for acute lateral condyle, sometimes we do a posterior approach. So there's no risk of AVN as such. We are not going too much in the condylar area and not disturbing.
So the crux of this surgery is we want metaphyseal union. We don't want to explore that intra-articular fragment, don't want to dissect it. And that will cause further problems in the long run, AVN, stiffness, and all the other things. So it is achieving metaphyseal union and correcting the deformity. So
yes.
So I just wanted to, for the benefit of the audience, there are a lot of surgeons who use a medial approach and a medial plating. So just some tips on how that can be done, and what is the advantages as well as what are the risks of going into that.
So you can use a plate, as I said, in children, and this was a little bigger boy, you can use a plate. But again, once you put a plate, sometimes you have to remove the plate, and at least you should have 2 screws. So sometimes, your osteotomy level may have to go a little higher for you to have 2 screws. If you just go medially, then again, for doing in situ fixation of lateral condyle, you have to go again laterally. So as I said, the principles matter, what approach you take, what osteotomy you do. Some people do dome osteotomy. There's one article by Thane who has actually again described how much angulation, how much rotation you should do, how much angle correction. So various osteotomy, the principles are more important. Is what is the indication for you to correct cubitus valgus, whether it is for the deformity that the patient has come, whether it is the tardy ulnar nerve palsy, or does he need strength and the stability. So how you do is up to you.
So, I mean, I just wanted to add on
everything. A lot of people do plating, and the only advantage is you can
it's a bigger
immobilize little early. Here we had to immobilize for almost up to 6 weeks, but otherwise you can mobilize early. But yeah,
that's when we just do a percutaneous fixation of the lateral condyle, because that's just in situ that you want. What Gautam is talking about is when you're doing an acute late presenting lateral condyle and you're trying to mobilize the fragment. Here we're not trying to mobilize the fragment at all. So you don't want to go then erase the posterior periosteum and then stop the blood supply. Here it's just completely stick to the bone. That's all that we want it to do.
Yeah, Taral.
Just so principles we agree on. The approaches can be different. I use a medial approach. The reasons for that is that it allows you to do everything what you need to do in that procedure. So medial approach, you can dissect the ulnar nerve. You can free it from the notch. You don't have to transpose it actually. The second is that the osteotomy is medial closed wedge. So a medial closed wedge is easier to do from medial side than a lateral side. The third thing is the way you are translating. You beautifully showed you translate, and with that translated fragment, if you are going to plate, it is easier to do medially
Yeah,
than
because
to
you
put
have,
a plate laterally, because laterally you will have a bump. And it's very difficult to put a plate laterally unless you nibble out. And lastly, you want to preserve as much as blood supply possible to the non-union fragment. Even if you're going to fix it in situ, you can put a screw percutaneously. You really don't need to make a lateral incision. But as I say that as many heads are there, the approaches will change, and the whole idea is to provide our audience with different approaches, and they can select what they want depending on the situation. Brilliant video. I really want to congratulate.
Thank you.
Any questions from?
Hello.
Seeing any? No.
Hello.
Yeah, Ajmer, please go. Let's have Ajmer asking us a question.
Hello.
Sir, पूछिए.
A nice presentation. Dr. Jamaria from Ajmer. If you have tardy ulnar palsy.
Yes.
Sir, आपका दिखाई दे रहा है जरा ऑडियो वहां से चालू कर लिए.
Hello. If tardy ulnar palsy, you will tackle at the same sitting or later on.
Sir, can you repeat the last
If
question?
you have tardy ulnar palsy, you will do a transposition at the same sitting or later on.
Same sitting, sir, because you are there and you can do it over there. So some people say if it is not too much, though, because you are correcting the deformity anyway, you are reducing the valgus. But since you are subjecting the child to anesthesia, it's better that you do it. So as I said, the type of surgery decision depends on what the child has.
Does the type of surgery depend upon also the need for transposition? So suppose if you're going to transpose the ulnar nerve, would you go through a medial approach? Would that be your plan then, surgical plan? Or would you still stick to the same lateral approach?
You can do medial approach also. So, or otherwise, even if you're doing this
So you
approach,
do a bilateral approach. Yes.
additional.
You are going quite high.
Yes, someone.
Yes, madam. Yes, sir. Please go on.
You are going quite high. Do you spare the radial now? How you identify, isolate radial now? Because you are
No, radial now is much higher, about 6 to 8 centimeter higher. This is just as the exact planning as the how forearm axis meets the humerus. That is the level. That is the exact level which what is classically described by Milch osteotomy. It's not that high. I mean, so there's no danger of radial now because you're just taking one cut. You are not taking any wedge or double cut as we were discussing earlier. If you're taking one more cut higher and doing a wedge, then you have to go further high. This is just one cut. We are not taking a wedge. So that's not a problem. Yeah, someone has a question. Yeah, so that one point was missed out very nicely. So how we had planned how much opening up it happens. So that for 14 degrees, how much opening up eventually that also you measure once you have angulated that much opening is the correction. Plus clinically you can see.
Yeah, one question.
Yeah, Safdarjang, is this the correction? Do you use a technique? No? All right, we move on.
Yeah. So thank you very much. And I invite next Dr. Tushar Agrawal. Now he's going to tell us about some lower limb deformities. Again, very common, Jenu valgum, Jenu varam are common OPD presentations. So yes.
Yes, madam. From Gwalior. Can I ask?
Yes, please ask.
Hello. Madam, I have a question. In case of the non-union of the lateral condyle or the supracondylar, what are the indications, your indications for the bone grafting? And if it is bone grafting indicated, which side or your preference for the bone grafting?
Okay. So supracondylar non-unions are very, very uncommon. Usually they malunite. They don't go into non-union. For lateral condyle non-union also, usually we don't put any additional graft. So there are some techniques described where they do the correction at the non-union site. So they open up at the non-union site and put then a big graft there. Here the idea is just to clear off the fibrous tissue and have the raw bony surfaces. So you don't, classical osteotomy does not require any putting additional graft. But as I said, yes, there are techniques where you correct the deformity at the non-union site, then there is a big gap which is created there. Then you have to put a graft and you can take from the iliac crest, which we many times do in many other pediatric procedures.
I hope that answers your question, Gwalior. Yeah. So we move to the next deformity case, something which very commonly correction of a jelly. Post-rachitic, sometimes congenital, many other causes. And we've got Tushar there taking you through it.
So the previous two speakers in deformity correction went as per the fancy, right? Drawing lines, making triangles, calculating angles. And somehow I feel in an audience of 100, if you draw too many lines, if you do too much of planning, you start feeling I don't want to do this. So the way I am going to show you genuvalgum correction is that tomorrow you wake up at 6 o'clock in the morning and it's the first case you are going to do and you will be able to do it perfectly. Okay, very basic, very simple, no line, no angle, no triangle, no geometry, no mathematics. Definitely, if I was good in maths, I would have definitely been in US right now, been in some IT sector, working from home, making millions and having a startup. So I don't have that and I'm just a humble genuvalgum corrector. Okay. So वीडियो मैं देखो दिया था ना. Unfortunately, the organizers sort of felt that maths was required. So they didn't want to upload my video at all. So I'll try and tell you what happens. I think the primary problem with genuvalgum is that they sort of come to you at an age and stage after 10, 11, 12, where they start noticing significant genuvalgum. You start calculating the intermalleolar distance and you start telling the parents ke, you know, मुझे लगता है अपन 8 plate डालेंगे, pet screw डालेंगे. And by the time they sort of get used to the idea, they go around to 15 surgeons. उतना second opinion लेते लेते उनको 2-3 साल निकल जाते हैं. So then what happens? Then there is no pet screw, there is no growth modulation. So then they come for the osteotomy correction. I think this is our experience by and large. Okay, because it is very tough for parents to suddenly decide, you know, when you tell them I'm going to do a very small procedure called growth modulation, the next question is, wo to surgery hai na? So then the word just unnerves them completely, you know. So this is perfect now. Kya dabaun bhai? So today, so this is, we'll start from the beginning of the case. Now this is how you do the case. You are called into the OT and you are shown the X-ray. No line, no planning. Just start. Today is 2nd October 2025. With the dates, we are talking about this lady who's 13-year-old female. Her date of birth being 14 September 2012. She is weighing currently at 41 kgs and she is measuring 148.5 centimeters in height. She has rough. The reason I am mentioning the height and weight is because I'm using a Philos plate here. So that's a 3.5 profile plate. Very high body mass index patients, you want a 4.5 profile device. So if you're using this technique, the child has to be a little regular body mass index. She attained her expected adult height. She is now with us for bilateral genuvalgum marginally asymmetrical on clinical examination. Her current intermalleolar distance in supine position is 18 centimeters. She first noticed this deformity in roughly 2023 and was initially managed conservatively with all forms of metabolic support. She never had pain or much of functional limitations. She was probably advised growth modulation at and around that time, but probably she and her parents could not bring themselves to get growth modulation done. So as you can currently see from her sequential scanograms, this one is done on 28 December 23, where the growth plates are open and she would have responded to a PET screw growth modulation. Now, roughly 1.5 years later, she is a fully skeletally mature lady with a more pronounced genu valgum. So now, currently, the possibility of growth modulation is not there. And for this particular patient, because she is of slender build and very low body mass index, we have chosen to do a dome osteotomy with a contoured, with a pre-contoured lateral philos plate. So that is the surgery which we are going to be demonstrating. Perspective of deciding on skeletal maturity, as you can see, all the phalangeal growth plates are now closed. Only the distal radius and distal ulna growth plates are open. All elbow growth plates are closed. So this really tells us that no form of growth modulation is going to be useful. So if the middle phalangeal growth plate is open and you have very, very minimal genu valgum, you can still offer PET screw to that patient, and you can do both femur and tibial PET screw. Very rarely any patient of genu valgum will have a pure femoral deformity, though on flexion you feel that it's a purely distal femur, but illusionally and otherwise also I feel 3 degrees to 5 degrees of upper tibial valgus is also there. But you're not going to do a separate procedure for that, so you're going to incorporate that into your femoral osteotomy. So now we'll go ahead and show you the surgery. So since we were doing a bilateral procedure, we passed a epidural catheter. So right at the beginning, I'm choosing a 3-hole SS philos and I'm just straightening it. There is no measuring, there is no angle. I'm not using my brain. I'm just straightening it. Very straightforward. It is an internal fixation tool. All screws are locked. I used to, when I started doing, I used to just fix the philos and then I found that I was probably pulling it back into valgus. So the moment I just straightened the philos, my philosophy was right. So you can see it compared to the regular philos. Now it's become straight. So you keep the philos plate on the lateral aspect of the thigh. Roughly 20 to 25% more than the length of the philos is the size of your incision. This distal femur lateral exposure, I think, is a very chilled exposure. Nobody has ever had any problem doing this. So it's not that I do not do distal medial femoral osteotomies. I'll show you that as well. But it always makes you feel a little more anxious, marginally more anxious when you're on the medial side. For the purpose of this philos plate, a 3-hole philos plate, there will be generally 2 perforators which you will have. You can identify them very easily on the tourniquet. And I always feel at the top end of your philos will be that second perforator. So if you burn that well, then there is no problem at all. Post-operative, after release of tourniquet as well. So the osteotomy is planned in such a way that it's at the supracondylar level, neither too distal, neither too proximal. It has to be at the metaphysio-diaphyseal area, and distally I should have 3 to 4 screws available through the philos. So at this time, the CM is sort of wheeled in and I marked my osteotomy. I'll show you the CM images together for the sake of convenience of editing. At this stage, I found that now I'm inserting the wires. So this is the important thing. I think this whole surgery is done at this level. Your wires have to be perfectly placed because this is all your planning. Here you take time. And I pass 2 wires. Initially, I used to pass 1 wire. Now I pass 2 wires parallel to each other because I require some force in the distal fragment to translate it laterally. I found if I was holding it on 1 wire, I was not having adequate force to translate the distal fragment laterally. So you see now these are in line with the deformity. Now I place the plate and through the most proximal hole, I pass the wire as a marker wire which is going perpendicular to the shaft femur. So if you see the wires from the top, you can actually see the magnitude of the deformity. Now you just leave the plate there itself and mark out your dome. The more number of perforations you make with the dome, the faster and easier and more cleaner your osteotomy looks. So spend some time on creating your dome. Because it's a dome, I don't use a saw. I'm using an osteotome. It works well. The most medial part of your cut in the osteotomy you need to complete well. So now the osteotomy is complete and the leg is straight. But I require to translate the distal fragment a bit. So with the help of my osteotome, I'm levering the distal fragment laterally. Now you stabilize with in the wire hole, and the rest is just fixing everything with the lock screws. I'm not passing a single lock through a sleeve. They are all free-handed lock screws. I've done many cases. Almost all the time, implant removal is not difficult, even if you sort of cross-thread the lock screw. Because distally, you can't pass it through the sleeve all the time. So you have about 4 screws distally, 3 screws proximally. The distal screws go fairly long, from 50 to 65 millimeters in length. So reasonable long length, but remember this is a 3.5 profile plate. So you can't be doing it for very obese human beings and not for skeletally mature, very adult sort of patients. So this surgery from start to closure takes 30 minutes with 0 time spent on any planning. Means in your sleep, you just wake up and do the genu-valgum correction. I hate drawing lines, angles, mechanical axis, anatomical axis, apex. I attend millions of meetings and I come back and I do it in the same way. Because it just makes me feel very anxious when I start drawing lines. Because ultimately a straight limb is a straight limb, right? You got to make it straight. You got to, I think all the lines have been created by drawer Pele just to sound very smart and intelligent and to make the others feel that you can't do all this. So मतलब basic है boss, काय के लिए line बनाने का? So you measure with the cautery wire and see basically just to confirm and show off that now your mechanical axis has become okay. It's very rarely that anything can go wrong in this technique. Quickly, we'll repeat this technique on the other side, and then you can see that both the limbs are straight. And then I have a rehab of a patient done previously, so you can see how well they recover. So I must tell you how this started, because I was traveling a lot for pediatric orthopedic work, and I was not finding that distal femur plate available everywhere. And he was charging too much money for it. And I was going to small cities. So I thought this philos is available with everybody in every nursing home. Bend the philos, only special equipment you require is the plate bender. If the hospital where you are operating doesn't have a plate bender, then it's a problem. I carry my plate bender. That is the only planning I do, that I have to carry my autoclaved plate bender. Huh? This is the other side, right? So you can notice the other side, the valgus was a little more prominent. So the opening of the wedge is a little higher. So this in effect works like a partial open, partial close osteotomy with translation. Do not attempt to translate too much. If you attempt to translate too much, you can create a sagittal plane instability. This is not a stable, hinged sort of an osteotomy, and you don't want to create a flexion deformity. Okay. So these are the C-arm images. You can see the amount of angle at which the wires were. From time to time, we took the images and see, you can see how well it has corrected. The left one was much higher, as you can see. So this is the correction X-ray, and that's the clinical result. I don't think with any form of better deformity correction planning, at least the limb from outside would look any different. So simple thing. So this is another lady, roughly. See, again, you see the body mass index. So this is the body mass index for which you can use this technique. And fortunately, my therapist had the common sense of that time. Means 2-3 years back, she recorded this. So we have the whole rehab. So they do find it difficult initially for range building, strength building. So what's about core exercise? Not so much on anything else. If your core is strong, you walk better. You can see she's been constantly focusing on her core. So a slimmer patient is able to work better on the core, you know. Now this is another patient with very severe genu valgum, and you can see because of the obesity and because of the big thigh mass, it was so much worse. And I've done a medial corrective osteotomy because she requires a 4.5 profile. So it's not that I can't do deformity correction planning, but just for entertainment purpose, I'm trying to tell you that it is easier when you do simpler osteotomies in a simpler way. You know, so much of dissection we do for simple procedures. I agree, if it's a multiplanar complex deformity with limb length discrepancy, you can do planning. But simple genu valgum is all about passing wires at angle, making them correct, and then stabilizing them with an internal fixation tool, and focus on rehab. Do not forget the patient after doing wound closure. There is no plaster involved, simple knee braces till suture removal, following which the rehab I have already shown.
To the 1970s, when surgeries were done this way. But you used a plate, which is a very rigid plate construct. When you're doing an opening wedge osteotomy and you're creating a gap, are you worried that this type of a rigid plate can result in a non-union?
It has not happened. It's metaphysical. It's a surgically created osteotomy. So even the thought never occurred to me, fortunately, and it has never actually happened.
So just to add, anyways, most of our osteotomy plates are locking constructs, so they are by and large rigid for whatever osteotomies we do nowadays. So non-unions are quite rare in the conditions that we do, especially genu.
We are overthinking in orthopedics. We are overthinking. We are having too many conferences, too many articles are being written, and everybody is just overthinking.
So, hello.
हाँ बॉस बोलो. नहीं है ना इधर बॉम्बे
speak. Go on. Bombay.
Can you hear, please? Hello? 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 Question from Vaidya. Are you hearing?
Yes.
Yes. Yes. Sir, you have not done any pre-operative planning and you have not calculated any angle of correction. So just I want to know but how you have done this. That's a query.
So I placed wires in line of the deformity and I make the wires parallel to each other. Right at the beginning, I am saying you may not follow my procedure. If you are trained in deformity correction planning and you like to draw mechanical axis and calculate CORA, you can use that. But I'm just showing a simple technique and I showed the outcome. You pass wires parallel to your deformity lines and do your osteotomy and make it straight.
So, Doctor, I think Dr. Agarwal showed us very clearly and elegantly that the distal K wire parallel to the joint. He passed another K wire in the direction of the deformity and he just made a cut and then made the two K direction he got. It is simple. Doing things may not necessarily be the best way, the right way, or the calculated way, which all of us do these days, but certainly very effective. Yeah, doctor, somebody wanted a question over here.
Yes, sir. So in the osteotomy which you performed, you did not do any translation. So
I did, but not too much.
So
I have attempted to translate the distal fragment, and in fact, you should always do it. I have deliberated this many times. Now, a genu valgum can have the CORA at various places. Many a times, your CORA may be exactly where you are actually doing your dome. So, you need not translate. Also, I feel in some of my cases, in my attempt to translate, I have actually over-translated the whole thing. So, I think very minimal translation so that it doesn't look like an umbrella, so like a hockey stick.
Yes.
But that is more than enough. Honestly, I am trying to tell you, I do not know about other deformities. Do not overthink in genu valgum. This is my humble request. Mehta, if you want to practice overthinking and practice deformity correction, keep thinking. Mehta, it is not required.
So my question was that if there is a so-called hockey stick deformity,
Though there is nothing, you translate it a little, no? You translate the distal fragment. Okay, so let me put it this way. Now, if you are very worried and you want to use, if you do too much of force, see, translating is not a problem. If you make the osteotomy excessively unstable, I have had one occasion on which I created a 5 to 7 degree sagittal plane deformity, which I was unable to overcome. So do not translate excessively. Few millimeters of translation is all you require. And do not overcorrect. See, very important point is, do not push the patient into varus. Normal valgus is there, no? 1 to 3 degrees valgus. So retain. I think the one problem with my technique is that your desire to correct the valgus can be overwhelming and you may push the patient into a little. So you can't have even 1 degree of varus. That doesn't look good. So not even 1 degree of varus. It has to be neutral or 1 to 3 degrees of valgus. So you undercorrect. So the proximal wire which I am placing, if it's exactly perpendicular to the shaft, I'm not going to make the distal wire totally parallel. It's a little off. So there is some amount of eyeballing involved. But honestly, ultimately it was eyeballing only, no, that you picked up genu valgum.
So,
which side of
how
plate
much
you have to use for the philos?
Yeah, it's always the 3-hole. I have always used the 3-hole philos.
Which side? Like if you are correcting the right side of genu valgum, which side philos we have to use? Right
To the
side
best
philos
of
or left?
I think philos is a universal plate. So again, I didn't think much. I chose an implant which does not have any variation. It is a universal plate. So same plate, same company, same thickness I am using.
Sir, how much opening do you accept without bone grafting?
No, I have never bone graft. Believe me, it does not require. It's always a partial open, partial close. Even if it's a very, very bad deformity, you will not require. You will be amazed to know that when I have done a medial closing wedge osteotomy, there's hardly any graft which comes out. So it's a completely overrated thing. This bone gap, too much of bone removal, it's not happening. Means when you do 25 cases, you will realize we are overthinking. Believe me, if anybody is thinking too much on genu valgum, it is very sad.
Sir, can I just ask one question? Sir, wouldn't it be a little easier if we would just put in a K-wire from medial and a lateral side so that we don't need an implant removal surgery later on?
Okay, so we were doing that before, but I think when you use K-wire, problems, you have to support with slab cast. In 6 weeks, they become very, very stiff. There was an era where we were doing with Jess fixator, the whole thing. And then we used to take the patient at 3 weeks and do a manipulation under GA to prevent stiffness. But we found that the weakness was much higher and the rehab was longer. So using the philos, I think the rehab is much shorter, much better. I agree there is an implant removal and it is not very easy to convince them to come for it. But I would still feel that this is the best way to do currently.
So when do we start the weight bearing?
Yes, so because it's a 3.5 profile implant, maybe at 3 weeks, even for a bilateral with walker, you can start 2 to 3 weeks. Yes, the 4.5 medial closing wedge osteotomy, you can start immediate weight bearing, irrespective of the weight of the patient. And now there are few good implants. The distal medial femoral tomofix implant is there, which is very good.
So as we discussed, there are a lot of different techniques to do the same thing.
I have a feeling, like I'm philosophical now. I'm practicing for 30 years. So I feel when we are treating a common human problem, think of common human solutions. God will not create a common problem which has a difficult surgery. Unnecessarily, we are complicated. Fibular hemimelia, tibial hemimelia, 1 in 1 lakh incidence, PFFD, drawer pele is great. But why use drawer pele for genu valgum? It's a common human problem. It's happening every day. Everybody is seeing millions of genu valgum in their practice, right?
So absolutely point taken, but now a lot of colleagues are moving even for the replacements later. Everything is on mechanical access correction.
Yes.
And
So we have done 3D planning. I have created jigs.
Yes.
So I agree, when you do 3D planning and when you create jigs, it's very cheap now. It's just 20,000 bucks. But you need to do a CT scan of the whole limb and you need to submit that. You need to break your heads before. In a busy practice, sometimes breaking your heads before is very difficult. Now, once you have the jig, Taral has won a BOS award for even printing plates.
Yes.
So you can get more and more accurate if you feel your patient, you need to do that. But I feel I wanted to show a simple technique, right? कल बोला किसी ने जेनु वाल्गम करना है, एक फिलोस बेंड किया, वायर डाला, तोड़ा,
the reproducible
very well.
anywhere.
No. So the 3.5 is within regular BMI. 25 26, anything going about 26, 27 BMIs, moderately obese, bulky patients use the femoral medial corrective procedures. Closing wedge osteotomy would be better. You know, they have a bulkier thigh also, so illusionally, in spite of you getting good correction, they still look in valgus a lot of times, the people with bulky thigh. And like I said, their cores are very weak, so they take a much longer time to rehabilitate.
So I think absolutely taken. I think standard, most probably everyone, even if our adult colleagues do the medial approach and the medial closing, I think, and that too now majority of our colleagues are doing the biplanar. So it is more stable. You don't get any the flexion extension deformity which you were
But
talking
again,
about.
see, those osteotomies
They're
are
complex.
slightly more difficult to understand.
Yeah.
And one last comment, with the Philos, now we are having multi-axial, those multi-lock screws. So, you know, now you don't even have to worry that I'm cross-threading the screws.
Right. So going in from deformity corrections, we'll start with the everyone's favorite and trauma. So the first case in trauma symposium is by Dr. Binoti Sheth again. We are doing a supracondylar fracture fixation with K-wires. So we'll continue with the symposium and everyone can contribute in asking questions. It's me.
So again, I think supracondylar fracture humerus in children is one of the most common fracture, which I think everyone encounters in day-to-day practice. And all of you all know that except for modified Gartland type 1 or type 2A, one which are completely undisplaced and 2A where they are just hinged and no rotational component, majority require closed reduction and K-wire fixation. So here we have a case of type 2B where you have a hinge fracture with little rotational components. So where we are going to do a closed reduction and K-wire fixation. Audio. So we'll have to again stop because there is audio inside. So all of you agree for this indication that how many of you treat the patients just conservatively on which types? Anyone? Audio. Yeah, so we'll see the X-ray first. So we have an 8-year-old child who had a history of fall yesterday, and he has this type 2B because you have a significant rotational component here, and you can see there's soft tissue swelling. So it's an extension type 2B fracture, and hence it's an indication for K-wire fixation. So always when the patient comes, the neurovascular is very important. You have to check the vessels, peripheral pulses, and all the nerve examination. And you have to document it also. And after reduction also, we are going to confirm whether post-reduction, when you flex the elbow, then pulses are getting maintained or no. Okay, so now we come to the operative view. So the child is on the arm, on the side arm. So the child is again at the edge of the table because we need the arm to be on a table where we can put the C-arm. So you take the child quite at the edge of the table. And now you first, the steps in reduction and fixation, basically first you have to give traction. Then you have to correct the mediolateral translation. So correct the coronal plane malalignment. Then you're going to reduce and correct the sagittal plane malalignment. And finally, rotate and stabilize it and then fix it. So we start first with the reduction. So my assistant, Dr. Akhil, is going to give counter traction. And I'll be giving traction. Again, now traction, it is always better to give in about, say, 20-30 degrees of flexion and not too much of extension. Because as you know, in these fractures, you have significant swelling and you have all your anterior neurovascular structures which can get tented if you give too much of extension. So preferable position is little bit of flexion, about 20 to 30 degrees. So I'm giving traction here. Depending upon the amount of overriding, you may require to give it for a little longer if it's a significantly displaced and shortened fracture. So in this case, luckily the fracture is not too much shortened. So I'm just giving gentle traction for some time. Fracture, AP view, C-arm shoot. Okay, so now since this is a little milder variety, I don't have luckily much of mediolateral translation, but otherwise in a classical posteromedial type, what I would have done is I would have corrected the translation by giving a varus valgus force. So I would give a, if this was a posteromedial variety, I would just gently displace it and get my coronal alignment first correct. And once, and again, I'll see that C-arm shoot with that. And once I'm happy with that, now the next step is to correct the posterior angulation by giving a pressure at the olecranon and then reducing it and then putting it in pronation. So now my AP is good. This is the Jones view. The lateral view. Now lateral view. Okay. Again put on the AP view. Take the AP view shoot. Okay, so now as I talked on my view, I will tell my assistant, or I will now, here it is very perfect, but otherwise somebody can actually draw the Bowman's angle here. When you see the line on the humerus shaft and the lateral physis and calculate the angle. On the lateral view, I will shoot again on the lateral. Okay. On the lateral view, again, I will see my anterior humeral line, which is here passing middle third of the capitulum. I will draw my lateral capitulo-humeral angle and see that it is correct. And as I mentioned, don't forget to see the oblique views. So when I'm doing my internal rotation, shoot. See, I'm seeing the lateral column.
Yes.
Okay.
Yes.
And I'm doing the external rotation, a medial column. Again, shoot. So all my columns are perfect. They are well aligned. So I'm convinced about my reduction. So once I've achieved the reduction, I'm going to check my pulse, whether it is obliterated or it is maintained. My pulse is good and I'm convinced about the reduction. Okay. So now I'm going to fix this by 2 lateral pins because my medial column is good. There's no comminution, but you may not get a very perfect reduction sometimes. And then you want to see, whether the alignment is good or no. So once, you have reduced, you can confirm whether all the acceptability criteria are met with or no. As I said, here there is no indication for medial pin. The crux is to avoid medial pin as far as possible because the chances of iatrogenic ulnar nerve injury are very high. So except where you have a medial comminution on where you have a medial oblique fracture, I will try and avoid medial pins. So here I am convinced that I can just pass lateral pins, 2 divergent lateral pins. Should try and put at least 1.5 mm, but depends again on the age of the child. If the child is very small, then you can put a thinner wire. But if the child is little older, you may have to put a bigger, but usually 1.5 mm K wire. I would like to pass 2 lateral divergent wires. So one wire will be supporting the lateral column, okay? And the other wire I will try and pass transolecranon or at least divergent from the first wire. Okay, so I'm palpating, that is the olecranon. I'm able to palpate the lateral condyle. And because you know that the capitulum is little anteriorly placed, your entry should be little anterior and then from anterior to posterior because that is the position of the capitulum. So I would just see on C-arm whether my direction seems okay. About 30 to 40 degrees angulation usually we target. And it should cross above the fracture site. Okay. I would also check on the lateral view. Okay. Okay. Shoot. Shoot. Yeah, I will draw a little bit. Yeah.
It's fine. The point is just lateral.
So one wire goes from the olecranon. So you have both cortex. Lateral condyle. Yeah. So I've tried to pass the other wire. One is a column wire going through the lateral column, and the other one is going through the olecranon fossa. So it is having 4 cortices purchased, and they are separated almost about say 7 to 8 millimeters. So this is a lateral divergent fixation, and it's quite stable. On the lateral view, I've tried to go from anterior to posterior. Can you shoot? Because the capitulum is anterior and your humerus capitulum is usually tilted anteriorly. So always better to get at least one of the wire from anterior to posterior. Let me see the column. Okay, so column is restored well. Okay, so take one AP view. So this is quite stable. On movement, I can take a fluoro and I can see whether there is any mobility. But looking at the configuration, I'm sure that there is no movement. The columns are well aligned. Fixation is good. So the purpose is to give, now I will give my post-op slab not in so much of flexion, but just in 60 to 70 degrees of flexion. Okay, because many times especially in type 3 supracondylar, you have a lot of swelling anteriorly and you don't want to give it in now. This is a very stable fixation. If this would have been unstable, I would have probably added a third lateral wire. Or in types where it is indicated to give medial wire, I would have put, if I have to do a medial, you should first always fix the lateral wire lateral column first, then extend your elbow to some extent because your ulnar now goes posterior once you extend the elbow. And then you take a mini incision, use a drill, and then pass the medial wire. So these are some of the tips when you have to pass a medial wire. So this I am okay with. I'm happy with the construct of the wires. So I'm going to cut my wires and then bend it. I will keep it outside and I will protect this in a slab. Slab remains for 3 weeks. I've checked that my pulsations are good. Clinically, many times before you take the C-arm, there are certain indications which can tell you that the fracture is reduced well. Once you give traction, you correct your mediolateral and then you give an olecranon tip and you flex it, you should be able to get a complete flexion if it is a perfectly reduced fracture in sagittal plane. If you are not able to get full flexion or if there is any rubbery feel, then there could be something entrapped within. Many times it happens that when you are flexing, your anterior neurovascular may get entrapped at the fracture site. So there you get a rubbery feel. And if your reduction is not achieved, you may not be able to get a full flexion. Otherwise, if you have got reduction, your fingers should be able to touch the shoulder and you should get a complete flexion. These are 2 of the clinical indications which tell you that your fracture is well reduced. Of course, you're going to confirm with your C-arm, but clinically also you know that you have achieved a good reduction if you have done this. Now I'm going to give a small dressing here. I'm going to give a slab, above elbow slab in 60-70 degrees flexion. I'll call the child again at 1 week, take a check X-ray. If at all the reduction and the fixation is not stable, if it's having some early failure. But at 1 week check X-ray, and then I'll call directly at 3 weeks. Usually they all unite by 3 weeks, and by 3 weeks we can take out the wire and then mobilize. Even if it's a transolecranon wire, being a child and being only for a temporary duration, it does not cause any elbow stiffness. So you should not get worried. Stability is more important as against, putting up unstable fixation and leading to complications. Okay, so that was just your intro of how, taking you to the theater and what happens every time, the direct relay. Yes.
That is wonderful, Binoti, very exactly how we would do. 2 questions. One is, in the good old days, I remember during my training days, it was always lateral position. And saying, why is that no longer? Is it because you can't correct the sagittal plane deformity very well in a lateral position and leaving behind residual extension?
Been doing in supine only, not in lateral position, because giving traction and you can always move,
So in unstable fracture, what happens is moment you in a lateral position, it will rotate and, you can lose reduction. But it's important to take a lateral view. And in good old days, when we both were residents, we used to turn the arm and take a lateral view. But now we turn the C-arm and take a lateral view because you don't want to change position of the arm. I think it will be very clear when Chintan is showing his arm bolt method.
Yeah, especially when you have a type 4 fracture, which is very unstable. So when you flex it, it goes in flexion. When you extend, it goes in extension. Never rotate, but rotate the C arm. Don't rotate the arm.
Some tips and tricks to correct rotation. The biggest problem intraoperatively is, yeah, you can correct the flexion extension, the varus valgus can be corrected, but correcting rotation is often extremely difficult.
That's why you
If you find it still malreduced and it's still rotated, what would you do?
So you take your column views. So don't just take AP and lateral. Take your internal and external oblique. If they are still rotated, then you can rotate to some extent. And because it's posteromedial and internally rotated, you can externally rotate. So your column views are very important in order to confirm that your rotation is corrected.
Gautam, so Binoti described very well. But if there is a rotation which is not budging, then you'll have to fix one part of the segment and then rotate the other part. Then only it will happen. Now, there are various ways to do it. One is by applying a sticking plaster on the proximal fragment, you're preventing rotation in the proximal fragment, and distal fragment can then be rotated. That's one way. The second way is to pass a K wire in the proximal fragment, and going from posterior to anterior so that you don't go across the radial now, and then rotate the distal fragment. Third way is to do joysticking. So pass a K wire into the distal fragment, and using that K wire, you correct your rotation and translation. And the last way is to do something known as intrafocal reduction. You actually put a K wire into the fracture and use that to correct translations and rotations which are refractory. So with these all methods, very rarely, Binoti, we need
open
an open
reduction
reduction.
or anything never needed.
So irreducible supracondylar really is very rare, and when it happens, the only thing you're worried about is neurovascular bundle, which is into the fracture site, and then those are the cases which may require open reduction.
How do you recognize intraoperatively that this might be the case? That when you have reduced it and it is irreducible, there may be a neurovascular bundle entrapped in the fracture site. How do you recognize that intraoperatively?
So once you have a good reduction, your fingers should be able to get complete flexion, and you should have a good bony feel. You get a rubbery feel, or if it's falling short of the complete flexion. And of course, you palpate always after reduction, always check your vascularity. So if that is diminishing or something, that's an indication.
Or is there a persistent gap which you would see?
On the C arm.
Red flags. Three red flags will be: one, if you have a pulse which is not palpable with a nerve injury, then you know that both nerve and vessels are hiding somewhere else. So that is one red flag. As Binoti said, and you also mentioned, anterior fracture clap after reduction is a second red flag. And third red flag is a rubbery feel. So if you have these three red flags, it can be a nerve and vessel which is entrapped at the fracture site.
Disappearing pulse.
Yeah.
Pulse it was palpable, but like
Absolutely.
disappearing.
So before reduction, the pulse was palpable. You reduce and pulse went away. So, that is something which is again a red flag.
So this was a very relatively undisplaced, but if you have a displaced, then a different technique by which you can do reduction is a new arm board technique, which Dr. Chintan is going to describe. Before that, I think do we have any questions? Because I think these are common fractures. Everyone, every place sees this. So any questions?
Sir, in Jalandhar, how do you assess the vaccine in a
Your voice is not audible, Dr. Zaveri.
Guys, yeah, in when you vascular you, the first thing you pulsation. The pulsation.
Your voice is not audible.
So think vascular these patients.
Gautam, that will rarely happen. In fact, the good vascularity and absent pulse is common. In presence of a pulse, a pale hand is very, very uncommon. It will not happen.
What do you do that way? In that way, it's a spine surgeon asking for fracture questions.
No. So we want to hear answer from Jalandhar, right?
Yeah.
So how do you assess? What are common ways? Do you use pulse oximeter? Do you use angiogram? Do you use CT angio or clinical assessment?
Rely on capillary refill. What do you do?
Somebody can answer.
Generally,
Or any.
if the pulses are not held, then we do the capillary assessment. And if that is not there, only then we go in for the angiography or something, CT angiography or something.
Okay, okay, great.
Gautam, a good way is to use a current pulse oximeter. I mean, the new pulse oximeters show a waveform, and many of the pulse oximeter you can also see it on a screen, record, take a printout, and things like that. So if pulse oximeter shows a waveform, then even if you can't feel a pulse, you're sure that the vascular perfusion is good. So pulse, the word pulse has to be erased off, and we have to look for perfusion now.
Any question? Yes, sir.
Ma'am, is there any indication while doing flexion and passing K where forearm should be supinated? Like you're telling it should be pronated, but is there? Yeah, yes.
The periosteal hinge, if you pronate, makes it more stable. So that is why if it's a posteromedial variety, you pronate. If it is a rare posterolateral, then you supinate. That is just for improving the in the stability of reduction before you pass. But your slab and everything is given in supination.
Sir, in pink pulseless hand, what is consensus?
What is the consensus for management of a pink pulseless hand, Binoti?
Yeah, so again, as Taral said, you observe all those things. So if you have a good waveform and if you have a good perfusion, then if it's a pink pulseless, you can wait and observe. Okay. But if it's a bad waveform, a poor capillary refill time, then, and plus you have a nerve palsy. Because many times if you have additional nerve palsy, then the child will not have the classical features of, impending compartment like anxiety, agitation, increased requirement of analgesia. So in presence of nerve palsy, you should have a low threshold for exploring. But otherwise, if you have a good waveform, you have a good capillary refill, pink perfused, you can observe and then again check. Anything?
So again, just 2 points here is that if you're pink pulseless and the treatment is same, close reduction and pinning, but with 2 additional modification, these are the patients I will not post next day. I will do in the middle of night, even if it's 2 a.m. I will do it as soon as it's possible to arrange for theater. The second thing is you have to really hold back the anesthetist from giving a block in these patients, because if the anesthetist gives a block, you've lost a very important sign of compartment syndrome in these patients. So don't let anesthetist give block for supracondylar reduction, especially when it's a pink pulseless hand and there is a lot of swelling.
Any more
So I
questions?
had a question.
Yeah.
If a patient comes with a AIN palsy and AIN with a pink pulseless hand, would you reduce the threshold for open reduction, or would you first still attempt a close reduction?
Only AIN, it will be close reduction. AIN and with pink pulseless hand, I will still attempt a reduction, but also keep it at back of my mind that if it's a rubbery reduction or if there is an anterior gap, so then I have to be ready for exploring. So in those patients, I will attach a tourniquet. If it's only AIN palsy, I will not even use a tourniquet in these patients while doing close reduction. So be prepared for an open reduction in case if there is a AIN palsy with a pulseless hand.
So
no, on post-op, which nerve? No, there are 3 nerves. So which nerve? And so if there was no palsy pre-op and you had palsy post-op, right? Binoti, you want to answer that? If there was no palsy pre-op, but patient had palsy post-op, palsy, what will you do?
Yeah, so if it's most of the nerve injuries in supracondylar and neuropraxia, but when they were not there and you have, created it, suppose you had put a medial wire and then done it, or if there was a rubbery feel anything, then you will be vigilant. If there was a medial wire, maybe then I'll remove that and revise it. But otherwise, majority are neuropraxia and they recover over a time. So, but you'll have to be vigilant. Anything
So
more?
if it's ulnar nerve palsy because of medial pin, many times if you diagnose immediately, removal of the pin and adding a lateral pin will work. Okay, but for median nerve or anterior interosseous nerve palsy, if it happens post-op, then I will take the child back to the OT and yeah. It's an anteromedial approach. You have to go on to the nerve. Okay, and if you get a radial nerve palsy, again, it's some pin which is irritating. So you'll have to remove that pin and, revise it.
So if there is a patient who has come with a vascular problem and you've reduced it, right? And the pulsations come back, the fracture has been reduced. In these patients, would you always fix, or is there a role for just a simple close reduction, or would you always do a percutaneous pinning?
Fixation and close reduction does not match with vascularity. Irrespective of vascular, no vascular, only type 1 or 2A are conservative. Rest all require fixation because they are quite unstable. If you get good reduction, very highly likely that they will again, displace and they will have complications. So fixation goes irrespective of the vascularity.
Saral sir, one question. As you said, most likely the last option will be putting the intrafocal for reduction. As reduction is not coming predominantly, a lot of swelling has occurred. So any tips and tricks on that, putting intrafocal wires, getting a reduction?
So there are two ways of doing it. One is to put a K wire, but nowadays we don't use a K wire. I use a mosquito forceps. And what I do is I will put a mosquito forceps, facing upwards first, and then turn it down, and then go anterior to the distal fragment and then pull it back. And as it is held in place, you keep a wire ready, pass one wire, remove the mosquito forceps, and then pass other wires.
That is with an intrafocal.
Yeah. So those of you who really want to see that video, during a very prominent Viron, 2000, what year was that? The Ram, Swapnil and Ram.
2015.
2015 Viroc. If you go to BOS website, there is an entire video of supracondylar fracture where I have demonstrated this. So those who are watching this, just go back to that video and you will be able to see this.
And mostly never open. And you are like hardly.
So if you
put some principle, there is never, and there is never always. So, there was one question was asked to me in IOCON at Jaipur that do you do open reduction ever? And I said no. And next week I had to do one. So you don't do that. So there are situations.
Mosquito that you put is through a lateral approach, right?
No, posterior approach.
Posterior approach.
Posterior midline approach.
Okay. All right. Lovely. We move to presentation. We were looking for lunch. Lunch is already served outside. So whenever you have time, don't be in a hurry to go there. One by one, you can go, come back. Then second person goes, come back. I'll be the first one to go.
So the same thing, but just a different technique, like how we are going to place the arm on this. So this is again a type 2B. Okay, we see that it's an extension. The capillary is lying behind the anterior humeral line, and there is a lateral combination and like a posterior lateral fragment. So we use this arm board. So arm board is placed under the torso of the child, and the distal fragment is kept free, and the proximal fragment, as Taral sir rightly said, can be immobilized by tying a adhesive tape around the proximal fragment onto the arm board. And what this does is this keeps our distal fragment totally in our control. Proximal fragment is immobilized, doesn't allow it to rotate or change its position. Now with the distal fragment, you can do the rotation maneuver, you can get it corrected, you can do the varus valgus correction. If there's a flexion type, you have the posterior part is totally free. You don't need to put a folded sheet or a gown, and you can just give a pull and push technique. For a flexion type, you can just flex. For extension type, you can just flex and get the reduction. Your olecranon is free to put your thumb and get the reduction done. So once the arm board is used and the arm is taped to the arm board, the distal fragment, as we know, is free, and we can see this in the image here. The distal fragment is completely under our control now. So, and then the reduction is done. Now, as sir was saying, nowadays, none of us are actually rotating the arm, because once you get the reduction, that is a golden moment. You don't want to lose it. So you want to keep the reduction stable and in position before you put the wire, but you still want to see on C-arm that you are right in the AP and the lateral and the oblique views. Here you can turn the C-arm around the elbow. You don't need to change any position of the elbow. The elbow is reduced and kept in position, and you just turn the C-arm in AP and lateral views. This is from another patient, but just to show how AP and lateral views can be taken. At the same time, if the C-arm is kept in 45 degrees in oblique views, anterior and medial and lateral obliques also you can get at the same position of the elbow. So you are not losing the reduction. You have your moment where you have got the reduction. You don't want to lose it, because what happens most of the times is you turn the elbow and then the next moment you see, array AP mein reduction aaya tha, now it's lost. We don't want that. We want both the reduction to be maintained. And once this is done, then the painting and draping is done as usual. We have the entire arm, which is, sterile with us. The unsterile part and the arm board, if it is unsterile, not autoclaved, that is kept under the drapes. It is not exposed to either of the sterile environment. And then, as I said, the distal fragment is under your control. You can do varus valgus maneuver. You can, as this was a type 2B, all you need to do just a flexion. And because the posterior cortex is also intact, the posterior hinge is intact, as you flexed and you got the reduction, then at this moment, then you will want to start passing the K wires. Now, the rest of the treatment is same what Binoti ma'am showed. So it's a very short video now. So you pass the first K wire laterally, get the hold. Now here is this fracture pattern was oblique, going posterior to anterior. Okay, so your wire will be from posterior to anterior. Okay, so it will be perpendicular to the fracture line. Now, arm board also is helpful, that if you want to pass a wire posteriorly, you have the entire area free. There is no arm table, there is nothing there that you have to lift the arm and then put a wire. So in the same position, you can pass the first wire and then the second wire. Once you have checked intraoperatively in both AP and lateral views, and also both the oblique views, the medial and the lateral oblique, that your columns are intact, then you can just go ahead, bend and cut the wires and apply above elbow plaster. The principle is the same. Whatever we have discussed in the last video and in between discussion, everything remains the same. It is just a different technique of how you make your life simpler and easier. You don't have to, change the position of the arm every now and then when you're taking a shoot. So arm board helps us to do that. So there's a post-op X-ray of the same patient, and the post-operative protocol remains the same as any other technique. 3 to 4 weeks of plaster, removal of wires after 3 to 4 weeks, and then active range of motion by the child.
Thanks, Chintan. Any more questions on supracondylar from the house here, or anyone from all of the other centers? If not, then we'll move to the next session. So we have Dr. Taral Nagra, who will be talking to us upon lateral condyle. Sir has been gracious enough to come back from his foreign trip in time and give this lecture. So I'll let sir take over from here and let us know all about treating lateral condyle right in the first attempt.
Yeah. Copy करना है. So lateral condyle fracture is a fracture of necessity, and there are a lot of confusions and myths about this fracture. So, we'll see two aspects in this video. One aspect which is more important is decision making, and second is the incision. So this is Jacob's staging of lateral condyle fracture. We divide into three. One which is crack, the second is split, and then third is flipped. But there are other classifications which you all may not know about, apart from Jacob's classification, and I'm going to show you this. This is Finn-Bagoson's classification, and it is a classification for so-called undisplaced lateral condyle fractures. So whatever are Jacob's 1 are divided into three types, and they are divided into stable, intermediate, and unstable. Stable are one which don't have to be fixed. Unstable will require fixation. Indeterminate, you'll have to decide. And Song, he remixed all these classification, and he classified lateral condyle fractures into 5 types. So stage 2, 1, 2, and 3 are necessarily a combination of Jacob 1, which are divided by Finn-Bagoson's classification. So Finn-Bagoson 1 becomes Song's 1, 2 becomes Song 2, and 3 becomes Song 3. And Jacob 2 becomes Song 4, and Jacob 3, which is completely flipped over, becomes 5. So what is of interest to us is that one which I have marked in green are indications for surgery. And there is not one surgery for lateral condyle fracture. There are 3 types of surgeries. You can either fix them in situ. Okay, this can be done with K-wire or screws. You can do a close reduction, arthrogram, and then fix. And the third surgery is open reduction and fixation, which you can do either through a lateral approach or a posterior approach. So I'm going to take you through all these things. This is an article by us on classification of lateral condyle fracture. So people can access it from IJPO. It's very well described. So this is a child. Let's learn how to do conservative treatment. You have to do AP, lateral and oblique views. And you can see here, this is Jacobs type 1 and Finbergerson 1, so which is a stable fracture. So this has to be treated in plaster. But it's important that the plaster is given with elbow in 90-degree flexion and with wrist in dorsiflexion. And why wrist in dorsiflexion? Because that makes the common extensor origin little inactive and will prevent displacement of the fracture. It's very important that we repeat the X-ray at 1 week, because those which are Jacob 1 or undisplaced lateral condyle fracture and which are going to displace will do so in 1 week. So if your fracture has not displaced at 1 week, it will not displace further. So what I do generally is give slab on day 1. I take repeat X-ray out of slab after 1 week. And if it's not displaced, I will give a plaster at 1 week, and that at 3 weeks I will check again. Sometimes I can check at 4 weeks, but maintain immobilization till the time you see solid radiological union for that patient. So this is at 3 weeks. बंद हो गया, आगे नहीं बढ़ रहा है. Okay, ठीक है. And you have to follow up these till union. So that's the crux of conservative treatment. The second procedure we have to learn is pinning in situ. So you have this fracture, which is Song 3 or Jacob 1 Finbergerson C, and you can easily recognize this if you do varus valgus views. So if it opens up, it is. And if the lateral gap is more than the medial gap, these are the cases where you know that these are unstable one. Okay, so this is unstable fracture and this needs to be done with pinning. Now, the diagnosis of lateral condyle fracture is in internal oblique view, and fixation in situ is also in internal oblique view. So what you will do, of course, on table, you will take AP and lateral, but the direction of pin is from posterior to anterior here. And because the fragment is posterior fragment. Okay, and this pin has to be, trajectory of the pin is an internal oblique view, then you are perpendicular to the fracture line. The supracondylar pins go from anterior to posterior because the lower end of humerus is tilted 45 degrees in front, but the lateral condyle pins most of the time will go from posterior to anterior. These are the cases where you actually don't need arthrogram because you are pinning in situ. As long as if you are not reducing, you don't need to do an arthrogram. And it's your choice. You can pass 2 or 3 wires. Here I am passing 2 wires which are divergent to each other, which means these wires meet outside, bahar aake mil. So, they meet outside and then diverge inside. So that is how these 2 wires will go. Many times I will purposely choose 2 different size wires so that I can recognize them on the lateral view. If you use same side wire, many times we get confused that which wire is going where, and if you have to revise, which one to revise. Give a plaster for these patients post-op, not a slab, and then they need to be followed up for a longer time. Now this is a 6-year-old child, and if you see this patient, lot of swelling. So moment there is a lot of swelling, anticipate instability. And if you see this patient, the AP and lateral look like Jacob 1. Okay, AP, but if you look, when you take X-ray in internal rotation, there is gross translation. So this is not Jacob 1. It is not a stable fracture. This is a really unstable fracture. This is split open, and this is Jacob 2 or Song 4. And this needs to be treated with close reduction. And because there is an intra-articular element, you need to confirm the reduction by doing an arthrogram and then fix it. And fixation with wire is not going to be very, very strong here. It's a avulsion fracture, so you need to take care of the shear forces, and a compression screw is a better option here. So how do we do this? So again, arm bolt like Chintan used in a different way, and we use a tourniquet here. because sometimes they may need open reduction. So again, in internal rotation, I'm reducing. You reduce it with a valgus force. Varus will open, valgus will reduce it, and then pass the first wire. Confirm it in AP and lateral, and then pass one more wire before putting a screw. Okay, so after passing these two wires, I'm doing an arthrogram. You can see that I'm putting a 16 number needle from the lateral aspect above the radial head. Okay, and then you have to go by the field because you don't want to go into the radial head. Go a little above that because the radial is otherwise not seen. Now this arthrogram beautifully delineates the joint surface, and you can see that you can see here now there is no step. What is the septum you see in between is the intercondylar notch, which is normal. Now some tips while doing arthrogram. First tip is that you can do it from a lateral approach, but nowadays we also do it from a posterior approach because there is injury laterally. Sometimes the dia extravasates into the common extensor origin and the capsule, and it will blur your vision. But if you put a needle through posterior approach, even if it blurs, it does not interfere with your fixation. So my choice today is to do arthrogram through a posterior approach. Second is keep the elbow not in extension, but in 30-degree flexion. Why do you do that? Because elbow was supposed to be in 30-degree flexion. The lower end of humerus is tilted in front, and then you will get actually AP of the elbow only when you bend the elbow to almost 30 degrees. So that's how you do an arthrogram. And once arthrogram is done and you confirm, you are ready for fixation. And for fixation, what you do here is you first will drill. Okay, you can just drill halfway through. You don't have to drill through and through, and then you pass a screw. Now, in older time, we used to pass partially threaded screws, but nowadays we pass fully threaded screw because compression is not really what we need. We give compression on table with help of a towel clip. But if you really give a strong compression, the screw will get buried inside because cartilage is soft. Sometimes it can even crush a soft cartilage or a soft bone of a child. So what we do is nowadays, use fully threaded screws, use intra-op compression with a towel clip because we don't want excessive compression. If you're using a partially threaded screws, don't over tighten it. Don't use washers. Okay. And you can use an additional wire. So this wire can be parallel to the screw or it can be parallel to the joint. It's your choice. Nowadays, I will pass a wire parallel to the joint and the screw along the column. So that's the construct which I prefer. When I did the case, that this is the construct which I used to prefer, but we evolve all the time from, iPhone 11 to iPhone 17 Pro, so the techniques also keep changing. But when I pass a screw and a wire, the wire I keep outside and the screw is inside. The reason is wire I will remove after 3 weeks. Screw I will remove after 6 months. So I don't want to do 2 surgeries for implant removal. And this is the way I can, mobilize the patient early. If you keep wire for too long, the problem is it will interfere with your movement. The screw does not interfere with the movements. So this is at 6 weeks, healing well. The child is happy, the parents are happy. 2 months, the range of movements in displaced fracture will take 3 to 6 months to come to normal. So don't be disheartened if the movements have not come that well. You will also see many times pseudo-varus because of a lateral condyle prominence. You can see the lateral condyle prominence. This will happen in many patients, almost 50% of a patient, whether you have treated them conservatively or operatively by close reduction or open reduction. This is inevitable and the time is the only solution. It will go away with time and that pseudo-varus will also disappear with time. So don't be in hurry to be judgmental. Now we come to open reduction and fixation through a lateral approach. So this is a 7-year-old child. The hazy X-ray and hazy decision-making was treated in plaster, should have been fixed on day 1. But this is how it was treated, kept on being observed. And this is like a ball being caught in final of the girls' match, where you are seeing the ball and it slips out of hand. Okay, so you can still catch it after 3 tries, and this is what happened in final. But in lateral condyle, at end of 3 weeks, if you catch it, it's not out. You lost the game. And here, what really you are going to do is an open reduction because this is an intra-articular fracture, restricted joint of movement, and there is a step. You cannot treat this by a closed percutaneous fixation, not possible. CT scan and MRI will show the articular step. Even on table under anesthesia, the range of movement of this child are restricted. This is the lateral approach. This video was shot in 2015. But still looks good. So a generous incision, at least 4 to 5 centimeters ahead of lateral epicondyle line, and then skin and subcutaneous tissue. And you can see in an acute fracture, you will see a lot of edema and fluid coming out there. The aim here is to not go on to the fragment. The first place you will go is the supracondylar area. So you go anteriorly from the lateral ridge so that the mobile VAD is all dissected in one piece along with the posterior interosseous nerve. So you are safe, subperiosteal, and you have exposed the lower end of the humerus, the coronoid notch here. The next step is to open the joint and don't fiddle around with the fragment. Go into the fracture site. So now we are going into the fracture site. Use your periosteum elevator and use gauze pieces, periosteal elevator, artery forceps. Go through the fracture site. Okay, so that there is minimum dissection of the fragment. And as you're opening and mobilizing this fracture, you can see that now you can see the physis, you can see both the fracture ends, and it gets mobilized good enough for this fragment to be put back into its anatomical position. And what are the instruments I'm using? I'm using, tooth forceps. I will use Alice forceps. Many times you will use K wires as joysticks, but I'm not going to use bone holding clamps here. Okay, because we need to maintain vascularity of this fragment, which is coming from posterolateral area. You can see this attachment of the common extensor origin very gently kept intact. I'm going very slowly, we are removing the tissues which are interposing inside, remove part of the joint capsule, which is hypertrophied and it's interfering. And this is the wire which I am passing parallel to the joint, which will act as a joystick. Now I prefer to pass two joysticks perpendicular to each other. You have to have a universal joy in life. So, you pass wires from at least two different directions. And then, again, valgus, Alice forceps, K-wire, everything playing their own roles. You reduce this and you have to see this reduction by seeing the joint line. And as you reduce it, then an intelligent assistant like Sushant will pass one more wire and then he will fix this fracture. So you don't fix this fracture. You ask someone else in your team to fix this fracture, and you'll pass multiple wires parallel to the joint and along the column. So that's your provisional fixation. And then since this is a non-union, just K wires are not enough. They are going to give way. You want to mobilize these patients early because they are also stiff. So at least some of the wires you will convert into screws. You will have some of the wires in place in addition to screw. You can't pass multiple screws. These are the days, 2015, I used to use a washer. But nowadays I don't use a washer. The quality of our cancellous screws also have improved. Their heads have improved and we don't need to use. The problem with washer is many times when you have to do implant removal, it is easy to remove the screw, but difficult to find the washer. Yeah. So that's how it looked on table. Again, two wires, one wire and a screw. That combination I have used. Some of the pictures here, intra-op, just to show you, how the joint looks like. Sometimes in a video the hands come in between. So these are some of the pictures to show you how the joint looks like. You have to do an anterior arthrotomy to see that. So you immobilize this patient for a month, then start mobilization, and generally I will remove these wires after a month, but screw I will keep for a longer time, and I can remove this whenever it's required. Normally, till the time screw is there, you will still have around 20-30 degree flexion deformity, and it goes away as soon as you remove the screw. I really don't know the reason for that, but this is what I have observed. So ultimately, this patient had excellent range of movement, full extension, full flexion, and united without any EVN. Now, this is new kid on the block, a posterior approach. And typically, I will use it for unstable lateral condyle. So this is lateral condyle with a distance. It is so unstable that it is not staying in place. And we did MRI because we were not really sure of the anatomy. But this is what the MRI showed. This was indeed a lateral condyle fracture with a dislocation of the elbow joint. And this approach from back also preserving the blood supply to the head. And it's a posterior incision. Either you can take a straight incision or curvilinear incision.
Not even required. Bakwas.
This is to show the instability.
Device.
If you didn't believe,
He needs
this is what was happening. Very simple approach, supine position, bend the elbow, and you take a posterior incision.
Time pass कर रहे हो
I have taken a curvilinear incision because you don't want your scar
Let's
over
talk
the
about
olecranon.
real orthopedics.
Curve it. And you remove, you
स्टेज पे क्या
split
fix
the
कर रहे हो
triceps
वो भी
here.
मतलब कोई indication कोई idea भी है कि there is no
And
guideline
as soon
नहीं
as you
मिल
do that,
this
immediately you will see the fracture site.
किसने किया कौन सर्जन था
It's very easy approach. Bang on. You don't have to do anything
इधर ही हॉस्पिटल
like an olecranon osteotomy here. Really
अरे वो
not
बात ही
required.
मत को आदर्श में जाएंगे
It's a posterolateral
अब उधर रहते हैं
incision. Again, you can see this fracture is completely flipped
मुखर्जी
over.
नगर रहते हैं उधर कहाँ से पहुंच गए
Very important again.
वैसे उधर तो लोग जाने से
that
डरता है आप उधर
preserve the blood supply. You can see those
उधर दिन में पास नहीं कर सकता
small
ना
muscle attachments which are getting blood supply here. Wash the fracture, remove all the clots. Be gentle, use gauze pieces, use curets. And again, the next step is to now derotate it. So how are you going to derotate it? Use the same tools, joysticks, tooth forceps, Alice forceps, gentle instruments.
नया you need extensive surgery अभी बड़ा सर्जरी करना पड़ेगा
And remember to hold the fragment as you're passing the wire. It should not rotate and kink around the blood supply.
वायर
Okay.
वायर फिक्सेशन को इंडिकेशन
You're moving, very important to hold it well.
यूनियन हो गया यार मोस्टली
So this is what I will do
अभी
myself
आल्ट्रा
and not,
एक्सरे है क्या
ask my assistant to do it.
ये जुड़ा ही नहीं है
You can see that fracture line is seen very well. So this is what I do now. 2 joysticks.
This is no
So that you can rotate the fragment as you want.
सर इसमें क्या किया जाएगा अरे प्लेटिंग करेंगे प्लेट करना पड़ेगा अरे वो पहला इंस्टेंस पे कुछ ही
So again, open up the fracture site. Give initially a varus force so that this fragment can be pushed inside, and then close it with a valgus force. So that's the maneuver you will use.
अभी यार देखो अभी
Can see the reduction beautifully. In anterior approach is a struggle to see the reduction. Posterior approach, you are bang on. You can see that why this was unstable. This is in the trochlea, bound to be unstable. It's going through that. And here you can see the famous forecortex wire going through the olecranon fossa. Okay. And many people will ask, is it okay to pass this? And I will say yes, because you're going to remove this wire before you start your mobilization. It does not come in way of the movement. Now this patient, the fragment was very small, metaphyseal fragment. Though we had kept the screws ready, but then we said, okay, will not work. Let's put wires. So we put 3 wires and kept them all bent inside. Now, because this will take a long time to heal, and I did not want to have wires outside and getting infected. So you can see 1 wire along parallel to the joint and 2 wires, divergent wires into the columns. So what we have learned are 5 techniques, not 4 but 5. Non-operative treatment, very important, because 50% of lateral condyle fractures are fractures in position. You need to learn them well. You don't have to operate every patient because the chance of displacement is 50%. If you operate every patient by pinning in situ, you would have operated 50%, which were actually possible to treat in plasters. So you use the judgment which I have told you. You use Finback-Osson's classification. Those fractures which are displaced less than 1 millimeter, where the lateral gap is more than the medial gap, or the fractures which stop short of metaphysis, where you don't have much swelling. Okay, these are the patients you can conserve. If in doubt, do an MRI. On MRI, if the articular hinge is intact, conserve. If it's broken, then you can still operate. Okay. Now, pinning in situ is for song 3. Okay, most of song 3 you will treat by pinning in situ, and no arthrogram is required. In older children, you can also replace pin with a screw, percutaneous screw fixation. For some of song 3, which have opened too much, and for song 4, we reserve closed reduction, arthrogram, and fixation. And I have shown you how to reduce it, how to do arthrogram, how to fix it with a pin and screw. And then for open reduction, we saw two approaches. One is a lateral approach for a stable lateral condyle fracture which has flipped over, or especially the old ones which have flipped over. And for unstable one with dislocation, I've shown you a posterior approach. So with this menu, lunchtime is closer, but the entire menu being served as an alternative to the lunch, we finished this. And I thank for those who chose this over the lunch. Thank you.
So thank you, Taral sir. And instead of having one video, you actually saw 5 videos and 5 ways how
Ek pitch are free.
So I think those who have seen this have really benefited well. Any questions from here on the technique or on any step that you didn't understand or you would do differently or
Arpit?
Yeah.
So, as far as I am aware, please correct me if I'm wrong, on X-rays after your reduction is closed or open, if your metaphyseal gap is there, that is unacceptable. My question is an articular gap acceptable on an X-ray?
Not acceptable. So you have to get articular reduction and fascial reduction, both. Now, in an acute fracture, you will get an articular reduction. Sometimes on the lateral side, because the fracture green sticks before it fractures. Sometimes, it may appear that it is not holding well. So you will go for first preference is articular reduction. Lateral side, there'll be some gap in acute fracture, which is okay. In older fractures, fracture which come to you 2 months, 3 months, and completely turned over, there you still have to go for an open reduction. It's not a very easy surgery, but in those patients, invariably there'll be a lateral column gap after you get articular reduction, and you'll have to fill that up with a bone graft, small bone graft. Now, in a child, where do you get bone graft from? You really don't have to go for iliac raise, just open olecranon, and you will get that small 2-3 mm bone graft from olecranon, and you can place it over there. That much is enough. Yeah, and it is through same operative area, and it can be done. Yeah. So articular preferred to the column continuity.
So those from Ajmer, Jalandhar and Gwalior, if you have any questions, you can definitely raise your hands.
Yeah. All right. Thank you.
Okay. Thank you, sir. I think you're ready. Spike again. So now we have next video of how we apply a hip spica cast. And we have Dr. Jaideep Damale for showing us the video presentation on this.
Good afternoon, everybody. So I will showing the hip spica and walking hip spica. So most important step for the treatment of the fracture sharp femur is one that to control the alignment, length, and is comfortable for the child. So 3 important things: length, stability, and deformity. These are the acceptable criteria. So ideal treatment for femoral sharp fracture 6 months to 6 years is double leg hip spica. These are the AOS guideline. Immediate close reduction application of well molded hip spica cast is safe treatment option for close fracture less than 6 years. Early spica casting or traction with delayed spica casting is also option. Some center are doing that. Indication: transfer fracture, spiral fracture. These are the steps because spica application is very difficult. We have to keep everything is ready on table. Requires 3-4 assistant. So these are the steps you can pre-operate, you can planning, obtain adequate sedation, assess the fracture stability with the help of telescopic test. So I will show you what is the telescopic test. Apply the cast liner, position on the spica table. Every center is not available the spica table, so you can use the wooden plank with the table. Cast padding apply the spica with well molded. You can apply the pillar at anterior side, trim and finish the cast and remove the patient from spica table. This is also important step. These are the checklist material: plaster, soft roll, stockinette, spica table. If not available, wooden plank. So these are what is the telescopic test? A gentle compression force is applied at distal end of the femur. If the overriding of the fragment is more than 25 mm, the patient should be spica failure. If the overriding is more than 25 mm, the spica will not work. So these are the position. These are the position we can give in 45-degree abduction, 30-degree abduction, 50 to 70-degree knee flexion. We don't want to give more than 70-degree knee flexion, otherwise the vascular compromise will be there. Always put the folded towel at the abdomen. Cast padding start below the nipple line to above the middle malleolus on ipsilateral side. We generally include the foot and ankle. So important step while applying the plaster, apply the anterior valgus mold to involve the thigh to recreate the anterior bow and address the tendency of the femoral fracture which shift into the varus. Always, if not applying the valgus pro, the shaft may trip into varus deformity. So this is the final position. So I will show you with this video. This is 2 years female child, history of fall from height, hemodynamic stable, presented with deformity and shortening. These are the X-ray, midshaft. These are the requirement we wanted. Wooden plank, stockinette, soft roll, narrow scale is ready. Plaster of Paris 4-inch, 6-inch, water tub, and sheet for counter traction. This is the important step you can see here. So we are given the patient position on wooden plank. One, we have applied the horizontal bed sheet. Just give the counter traction because the spica table is not available everywhere. How will you give the counter traction? The child will come down. So this will help as a counter traction and a molded padding for abdomen while applying the plaster. Position of the surgeon in center and side with enough padding, we just reduce the fracture. Applying the stockinette. So previous slide you see that we did the telescopic test, is not collapsing, getting good alignment. The important step in giving the spica, how will you assess the lateral view in giving this position? So you have to tilt, oblique the C-arm and just see the lateral view. Adequate cost padding and soft roll application. So we give extra padding at the posterior knee and heel to avoid the sore. Reduction manual. You can see here we giving the extra padding at knee because someone we cannot hold too long for the spica. They always lose the reduction. We want to give the extra padding there to prevent the sore. Opposite leg is influenced. Everything we kept ready. We always dip the plaster with the cover inside. We don't want to waste. Otherwise, after 2 plaster, your whole water will be. We take the plastic material with the cover in and then we remove the plaster. So now the water is clear. Start from proximal end, 3 layer. Then at the junction, we just roll the plaster in figure of 8 maneuver with maintaining the reduction. We don't want to give too much knee flexion and hip flexion here. So you can observe what position we have pre spica. We see the under the C-arm, what position reduction is achieved. In proximal fracture, we have to give maximum flexion, middle 40 to 50, lower third with decrease the flexion. I will show you in next case. Molding of here is very important. We don't want to too much force. Anterior push, valgus stress to prevent the varus collapse. Then complete the below knee part with maintaining the flexion. Otherwise, the below knee cast with hurt at popliteal fossa. Before completing below knee, we take the C-arm oblique and lateral view, whether the reduction is maintained or lost. So we apply the slab to reinforce this plaster. opposite half side, we just connecting with the main injured limb. Previously, we kept 1 centimeter stockinette and cord. Now we are just reflecting to protect skin. Check all the joint. If required, we can reinforce with the slab and plaster. Well mold edges. The most common complication of spica is the skin sore, redness, and rashes. Complete the foot part to avoid the rotation of the distal fragment. Fix with the abduction bar. The abduction bar scale is always held. Once the spica is completed, you can check supine and prone. If you want, we can use the fiberglass plaster to prevent breaking of the plaster. The spica bar is always help to carry the child, maintain the stability. The most important, after applying the spica, proper care to avoid the skin rash, skin complication. Always guide the parent to watch for pain, swelling. We use the double diaper because single diaper always wet the plaster. How to apply the double diaper is also important. One is inside and one is outside. Post-op protocol. So 3-year-old child fracture, we did a double leg spica. So option traction. So we did the spica, but the fracture is it acceptable? There's too much overlapping here. So spica has the advantage. We can do the as old technique. We did the wedging. You can see a plaster wedging. This is we accepted the angulation and overlapping is reduced. So proximal fracture, we give the more flexion, just like in infant, middle third 30 and distal less fracture. This is the same X-ray at 7 weeks, 4 months, 2.4 year, no limb length disparity. Close reduction and spica casting is a safe, effective method for the pediatric diaphyseal fracture of the sharp femur. Future research identifying the rate and pattern of remodeling as related to angulation shortening at various ages is not described in literature, particularly adolescent. These are the meta-analysis. 10 article they have review accepted fracture shortening 16 mm to 18 mm, accepted angulation 14 to 16 varus vulgus, accepted procuratum or recurrent deformity 18 to 22 up to 2 years, and spica is a safe. So this is another paper, spica casting for pediatric fracture, single leg versus double leg. Now we are using lot of single leg spica plaster. So whatever the study, there is no difference in radiological functional outcome between the single leg spica and double leg spica. Single leg casting is more comfortable during the sitting and greater easy to leaving the family home. Fewer care gear is required. Complication and acceptable radiological outcome appear similar in both the groups. Another case, fracture shop, long oblique, given the TT splint, and we apply the single leg spica here. So this is a 3-week single leg spica. Style is started with this spica, and this is a 6 weeks X-ray. 8 weeks, good range of movement. Another case, she's presented after the 10 days, someone has treated in TT splint. We are given the single leg spica. Immediately we started standing. These are the video available in Postna. This is 6 weeks. This is 2 months. And she is walking with 2 months, single leg spica. So walking is spica is a JPO 2006, 45 kids, 1 malunion, 62% kids walk, 5 cars broke at the hip. CHOP study is very good paper. All are the low energy trauma, no malunion in walking spica, regular spica care, ambulance transport is parents are very happy with the post care. Most important, place a small diaper inside the spica. Otherwise, all the spica in next follow-up, they will wait and develop with the rashes and so on. We put one diaper inside, anterior and posterior, and one more diaper to take care of outside. So following cast application as regular follow-up, we follow up 4 weeks, 6 weeks. Advantage, as I had told previously, the major determinant of treatment is age of the child and type of the fracture. Double leg spica is a treatment of choice, 2 to 6 years, and single leg spica with fewer parent days of the work, easier patient transport, increase easy for sitting. Thank you. So I just mentioned both the single leg and double leg advantage and disadvantage. Any question?
I have questions.
Yeah.
So I have two questions, sir. How do you prevent cast slippage in a hip spica for femur fracture? And my second question is 100% displacement is an acceptable criteria without angulation. How do you prevent slippage and bayoneting? Like if at 1 week follow-up you see more than 2 centimeters, 2.5 centimeters, do we revise it? Do we leave it as it is?
So it depends. First, if you see the video, I have put the bed sheet. Just give the counter traction. Okay. And main important step, anterior and valgus strip. That will prevent the collapse and varus collapse and overlapping, as you say. So as per criteria, 2 centimeter overlap up to 2.5 we can accept. It can remodel depending upon the age of the child. If the older child, then we have to revise. If angulation, varus valgus, you can do the wedging just like normal plaster and correct. As that's example also I have mentioned here.
So I was about to say wedging helps in correcting to say about 5 degrees or so, and especially if it's in one plane. If it's everything gone, like say angular deformity, sagittal plane, coronal plane, then you have to redo. But if it's just uniplanar and up to about 5 to 10 degrees, you can very well wedge it and keep the same plaster and then correct the alignment.
So that's why you have to mold the plaster.
Spike.
Otherwise,
Not.
whole cast will not come out.
So that is like a poorly applied spica.
Yeah.
Like how forearm also, if you do a distal end radius correction and you do a casting, and if it is not, you're not maintaining the cast index, it may still slip out. So in hip spica, it is also good that you mold it around the, trochanters, you mold it around. So it is important that it is well applied. A very loose fitting spica, if the child is slipping out, which means it's not applied properly.
So that very poorly nourished arthrocarpotic child, it happened actually. And we used something which is common sense. One of my fellows told me that if the pants are slipping off, what do? Use suspenders. So you put a spica and put suspenders over it so that it doesn't come down. Very simple, right? So you can use a polyc harness over a spica. So that prevents it from coming down. Try that. That will work.
Up. Flexions.
So Jaydeep, what is this single diaper, double diaper technique? वो बताओ तो सही.
So single diaper generally common sense the parent apply this diaper singly. So you generally of the female just drip the urine and the next day only they will wait the spica. So this is the spica. We apply this diaper inside the spica and another anteriorly inside the spica and next diaper over that to prevent the outside wetting.
So the first diaper is kept under the spica going into.
Both the diapers will have to be changed every time.
No, so the inner diaper you can change and the outside diaper you can, because that is still dry. It is just too, solid from the outside. So then
because
you can just
the parent will apply the diaper outside. The plaster will be soaked on the same day only.
So other thing was
any questions there from the audience?
Audience from Ajmer, Gwalior, Jalandhar. Do we have any questions from the relay stations?
I'm sure that from time to time you are all applying hip spicas for a variety of indications. I think Jaydeep here has shown us how to apply a hip spica very well. Okay, thank you very much, Jaideep.
So another thing, how while applying a hip spica, what will you prevent? You will not give excessive flexion. You will not. So the things, why is it important?
So I have mentioned we don't give the knee flexion more than 70 degree because the vascular compromise, compartment syndrome, and we have to see the fracture geometry is proximal. We have to give more flexion, middle less flexion, but not more than 70 degree. You have to on ankle after the because spica will take 20 minutes. So your assistant you have to tell. Sometimes they will tilt and everything. So important thing, no more flexion at the hip, no more flexion at the knee because that will give rise to compartment syndrome.
Point I wanted to ask whether you use that ruler for all the patients, because now earlier we used to give, but now we give synthetic.
So ma'am, previously whatever we use the POP gypsum, that time we give. But now we also give the
synthetic cast.
Synthetic cast not required because
Not
they
required.
maintain the stability. In Indian specifically, the spica is weight. Once it's collapsed and that's always help.
Yeah, because especially in smaller child, if they want to take them by the shoulder, then with that rod in between, the ruler in between, it becomes difficult.
Yes, ma'am. I agree.
Okay. Thank you so much, Jaideep.
Thank you, ma'am.
And so we move to another technique of treating femur shaft fractures in children, and that is little older kids where you cannot give spica, but you have to go for the nailing procedure. So we have Dr. Chintan Doshi is also the co-convener for this course. He's going to tell us about the exact principles of using TENS for femur shaft fracture. Over to you.
Yeah. So I'll be presenting the video first, and then we'll have discussion on this. So I'll just start. Yeah. Yeah, से start. I can pause it from here. Audio चाहिए. Yes. Okay. So audio will play, right? Yeah. Okay. Thank you. So I'll present the technique of TENS nailing in a femur shaft fracture. It's a audio. I'll pause it in between, or we'll have some discussion in between as well. Hello, everyone. Today we will be discussing about TENS nailing system for femur fractures. So to do the preoperative planning on this X-ray, we have measured the intramedullary diameter. That is, we have seen the canal diameter between the inner side of the cortices, and that is about 8 millimeters. So here it is 8 millimeter. So this measurement is possible if you take a true size X-ray. However, with the new DICOM images, you can do it on the computer itself where the images have been taken. Even if you don't have this, there is a technique which you can do it on the skin also, even before the incision is taken, to see how much of the canal diameter the nail is occupying. So that we'll see as we progress in the video. So as ma'am rightly said, so in an older child, so this is a 7-year-old kid with a femur shaft fracture, which is a long spiral oblique fracture. And for this, doing just a hip spica would mean, there'll be a shortening or there'll be residual deformity. So then we did TENS nailing for this kid. So we'll go ahead with the video. 40% of 8 millimeters, that is 0.4 into 8 millimeters is 3.2. And we'll be using a 3 millimeter nail in that case for this case. For femur shaft TENS nailing system, we place the patient supine, okay, on a radiolucent table, so that the C-arm can pass underneath and you can see the entire femur from knee to the hip joint. So regarding the positions, some of you would be doing it on a fracture table, but provided you have a pediatric fracture table which is available, and a small kid like 7 or 8-year-old can be kept on that fracture table. Actually, if you do it on a, like I've done here, I've shown in the video, if you just do it on a radiolucent table, that is enough. Okay, you can give traction, you can do the correction of the deformity of the reduction of the fragments, and it is very much possible. Older child, like if you're doing for a 11 or a 12-year-old and around 50 kg, where again a TENS nail could be indicated, and which is fitting on an adult fracture table, you can go ahead and do it. So there is no hard and fast rule that it's need to be done on a radiolucent table. Both are acceptable, provided you have the facilities for that. So this we have done it on a regular radiolucent table, and which is available in any third-tier city. So to determine our incision, what we are going to do is we are going to mark the physis here. So I'm going to keep my artery forces or the physis that I marked. Okay, can you show the C-arm? Should this is the marking that we do. So this is the part of the planning for the incision and where our incision will be. So now before taking any incision, we will start. So physeal marking we did because we want to stay away from the physis for the entry point. So about 1.5 to 2 centimeters proximal to the physis. We don't want to, endanger the physis, cause deformity because of physeal arrest. So our marking for the physis is very important even before we start preparing the nails or preparing the, the incision for this technique. Preparing the nails that we want to use. Then I have a 3 mm nail. Yeah, so that's the fracture side. I'll go as I said, if you don't have the measurement on the X-ray, this is how we'll measure on the clinically. The portion. Can I marker though? So I kept 2 3 mm nails on the skin. See how much of the canal at the isthmus or at the fracture side has been occupied. If it is occupying about 60 to 80%, then it is good enough. If it is less than that, then it is very thin nail, or if it is more than that, you'll have difficulty in passing the nail. But this is what you see, that it has to occupy the nail, occupy the intramedullary canal properly. So this is why we selected this. And then what I do is I keep it on the skin. You will see in the further video here. So this is the portion. So I mark the fracture site at the nail because we want to bend the nail at that side. Bring the bone. See, marking that and shoot how much of the nail is going to remain inside and where is the fracture site. Where the nails have to be bent maximally so as to get a spindle at the fracture site. So you want a spindle at the fracture site. Can be done with a simple plier and a T-handle. So you can use to hold both the edges. And then gently curve and bend. Okay, so the bend, the maximum height of the bend should be 3 times the canal diameter. Okay, so as to get a good elastic effect at the spindle. So the maximum bend is here. So this will be the spindle inside the bone and they are symmetrically bent. So this is the most important part of tense nailing. Okay, both the nails have to be of the same diameter. They have to be symmetrically bent. The maximum bend has to be at the fracture site because you want the spindle to be at the fracture site. The height of the bend is 3 times the intramedullary diameter. That is when that safety pin or the spindle effect will get at the fracture site, which will maintain the reduction till the time the fracture is healing. The diameter of the nail that we selected was 0.4 times, that is 40% of the canal diameter of one nail. So intramedullary canal diameter, if it was 10, then you will use a 4 mm nail, 8, then use a 3 mm nail. So that is how you will see same diameter nail, symmetrical bending and symmetrical spindle which is being formed once it's inside the bone. So that we will see. So till now we have not touched the patient. We have not taken blade in our hand. Everything is done, before all this is already ready. Now is when we'll start taking our incision. Same size nails, symmetrical bending. Okay. So we are just going to have a stab incision here. Okay. And just open it up a bit. Okay. So again, it's necessary you take a stab incision, but you open up a bit. Like you have to open a 1 to 1.5 centimeters. See, you have to retract the soft tissues. You just cannot enter with all, pressing all the muscles into the bone. So you have to give a good catch paw retractor, see the bare area of the bone and then enter with all. So this is also very important. We have seen nowadays, everyone wants to be very minimally invasive. Residents don't even take incision. They just take 11 number blade, just make a skin hole and then no soft tissue dissection is done directly. The nail all is passed in. You are passing IT band, the muscle lateral, vastus lateralis muscle, everything. You are pushing it through and going into the bone. That is not the right way to do. So it is better that you expose the soft tissue. So you'll pass a mosquito forceps. So we'll see the CM now. Okay, this is our entry for lateral nail. Okay, it is 2 centimeters away from the physis, exactly what we marked on the skin. Can I get a all? And entered into the shaft. Should I just slip there along the lateral cortex? But yeah, now I'm in. So all is entered first perpendicular to the perpendicular to the cortex. Once you are inside the cortex, then you will bend it away from the shaft so that you get that angle of 45 to 60 degrees at which the nail will pass into the canal. If you are going all the way perpendicular, you will hit the opposite cortex and then you will create a pseudo entry on the other side and it will cause you a problem. And then advancing the nail should. So when I put the nail in, my tip is first facing down and then we turn it around, and then it goes up into the canal. Should. Now this is the point where you have to be very careful because your nail has to bounce off the opposite cortex and go into the canal. So you see that little bend over there at the tip of the nail. That is the one which is allowing us not to perforate the opposite cortex and cause a problem. So that is where it will bounce off the opposite cortex and then enter into the canal straight up. If you use an absolutely straight tip, then it will not bounce off the opposite cortex and it will cause you a problem because it will always try to pierce that opposite cortex and go into the soft tissue. So this is, you will see advancing the nail into the canal and it will just bounce off the opposite cortex. Should. Right. We are there. Should. And then when you are at the fracture site, what you do is you enter the proximal fragment and then you turn the tip so that you are inside the canal, and at this time you have to see both AP and the lateral views. When you're seeing the AP and the lateral views and you are in the canal, that is when you will advance further. Otherwise, you'll have to use maneuvers to reduce this fracture. And I will show one of the maneuvers which is very commonly used and it's available in the set. I just see the lateral view. Then should. So this is another tool that will help us. This is the F tool. Okay. And this also helps us in getting reduction if it is difficult. This was easy in 2 attempts, we got it. But you are struggling a lot, then what you can do, if this fragment was going medial, this was coming lateral and you were not getting reduction at all, you could just use this F tool to get the reduction. Should. So this I'm showing just with a nail. So you can see F tool is radiolucent. You can see, you can get the reduction. And where the fragment is, it could be anterior posterior, it could be medial lateral. Here it was the proximal fragments are going lateral and distal fragments going medial. So to get the reduction, you use the F tool as a 3-point fixation and get the reduction so that, and then you can pass the nail inside. So this is a very good tool which is available in the set of tense nailing, and this is very helpful intraoperative in those, especially those unreducible or those that are giving you trouble in reducing on table. So that's the use of a F tool. It can be done even before the nail has been passed so as to get the reduction. And then while passing the second nail, there you can see the physis and the entry point. It will be almost similar to the opposite side, 2 centimeters above the physis. Now I'm entering with a gentle twisting movements. I'm just entering with my awl, straight awl. And there should, I've almost pierced the cortex. Yeah. I'll go a little further in and then go towards the shaft. Should. So there. Yeah, this is my entry point. Yeah. So while passing the second nail, it is very important that we just do gentle twisting movements. At any point in time, if you rotate more than 180 degrees, what it does is a snaking effect. The second nail will snake over or will roll over on the first nail, and then it is very difficult to get the spindle one. Second, at the time of even implant removal, both the nails are intertwined into each other and it doesn't come out because the first nail is preventing the second nail to come out and vice versa. So it is important that you don't snake the second nail onto the first nail. So your movement has to be within that 90-degree range. You don't twist it more than 180 degrees because that tip will twirl around the first nail and then you won't get the reduction and the fixation for that. So it's gentle twisting movements only. Now that's a spindle at the fracture side. We'll just turn it towards, right? So I'll show how we cut. So, and the nails are at the proximal metaphysis. So we want the nail, the medial nail will go almost into the into the neck, and the lateral nail will just end below the GT physis. So this will ensure that there is good 3-point fixation. Okay, at 3 points, the spindle is allowing at the fracture side, and the two ends, one is in the proximal metaphysis, one in the distal metaphysis, which is allowing the fracture to be kept in reduction till its healing. And this is how we will cut the nail. So what I do is I bend the nail a bit away from the skin. Nail stays flush to the cortex. We are not bending the nail at the cortex. You know, we don't want the 90-degree bend. Away from the skin. And there, so just cut flush the skin. We'll cut the nail. And about a centimeter also, you can drop it into the 1.5 centimeters, which is out of the soft tissue. We'll just hammer it in. We'll just we'll just punch it into the flush to the cortex. Good. Right. So that is a spindle at the fracture side. That's a reduction of that long spiral oblique fracture in both AP, and this is the lateral view now. There you can see the spindle at the fracture side, and the reduction is well maintained. Even on moving the hip, there is no displacement. So the spindle helps in maintaining the reduction. Fine. The spindle is at the fracture side. So after this, it is you need not always apply a plaster in those patients who are non-cooperative, and you could just give a slap for a while till the time the pain settles down and the wound heals. But otherwise, plasters are usually not required after tense nailing. In those that are comminuted, or those you think that they will plaster can be used as a supplementary, that they will collapse, then it can be used as a supplementary fixation. But usually tense nail itself takes care of the axial translation, the rotational translation, and the mediolateral translation. The other thing at how we are going to mobilize them, so they can walk almost at 3 weeks when the soft callus is seen, and over a period of time as the fracture heals, and the knee range of movements can be started almost immediately on post-op day 1, so that we don't lose out on movements and there is no stiffness.
So thank you, Chintan. That was a very good demonstration. Just for the benefit of the house, we need to have what is the ideal indication for doing a tense. Like this fracture geometry was little more oblique. The ideal place or the ideal indication is a middle third shaft transverse fracture in a 6 to 12-year-old child with weight less than 50 kg. If that is the thing and you use it in a perfect manner with all the principles followed, you can start immediately weight bearing, and it's a very, very stable fixation. Sometimes if you are beyond any of these indications, like you are doing it in a very proximal third or distal third or a very long oblique spiral, sometimes you supplement this with something else. So you do a hybrid fixation. So tense nail with a temporary external fixator or tense nail with a small plate. So still you can use tense, but you may have to give little additional stability for the initial period till it becomes little gummy or soft callus forms. Or you may give them a brace or a TT splint for a few weeks till it becomes gummy and then start weight bearing. So these are some of the things where you have an extended indication. Any?
Just so that you can tell, we see a lot of children who come to us for follow-up who have been implanted devices much younger than some of the indicated age. And even the principles of TENS, some people just put one wire and then put a spica and things like that. So I know the age for putting TENS nail is different in different parts of the world based on their considerations. So at large, can you give something like for India, what is the algorithm kind of?
So up to the age of 5 years, I think spica works well. You don't actually need to do a tense nailing. So this is usually kids more than 5 years. One. Second, those that are, as ma'am rightly said, those that are comminuted or multiple fragments, you can supplement them with hybrid fixation. But the upper limit is if the child is obese and is more than 50-55 kg, you will not do a TENS nailing. You would probably do a submuscular plating. In those cases, because TENS with the amount of muscle forces which are acting at the distal femur, it won't be able to hold it. And so about 50-55 kg, up to 55 kg is the extended indication, but up to 50 kg is what is recommended. So that is the upper limit. The lower limit is usually 5 years. Below 5 years, if a 4-year-old child will come with a femur shaft fracture, I would not put a TENS, I would put a spica.
In the little older, like we get lot in the above 10 and adolescent age group, still prefer TENS or anything else?
So there are two options in adolescent age group. When after 8 to 10 years, we don't expect GT physis to grow a lot. So that is when the lateral entry nail, okay, which is adolescent femur nail, also can be used at around 12 or 13 years of age. Also, as I said, if you get the child who is around, more than 50 kg, then you would prefer adolescent nail over a TENS nail. But yeah, so both are an open option if the child is 45 kg and is just 12 years old.
Any role of, okay, if you don't want to nail, I guess a lot of
submuscular plate.
They are better platers. So what is the role or indication of a plating, if at all, in pediatrics?
So submuscular plating is again if there is comminution, if there are multiple fragments, if you think that the TENS nail is going to back out, and if you need something more stable, then it is submuscular plating that can be done. Again, that is not, you don't have to open the fracture site. You just pass it like a MIPO from the distal to the proximal and just use the entry points for the screws at the on the plate.
Lovely.
Some of the original Synthes variety, they have these end caps. You have those end caps where at the entry point you make them so that prevent backing out, especially the ones which are long, oblique, spiral and not very stable. If you use end caps, then again the stability of the implant is improved and it doesn't back out. Couple of things on the finer points. If it's a transverse fracture just before cutting or doing, and especially if the child is on a normal table, you can flex the hip and knee and just thump it so you get additional compression. Or if the child is on a traction table, you lose the traction so that there is compression before doing the final sizing and cutting. Also, before you have to cut, maybe withdraw it to some extent, then you cut it, and then you have actually in the set a slotted one hammer sort of which can fit in there, the mallet, and over which you can hammer and then put it in. So withdraw a little bit, then cut it and then again put it in, and keep it always flush with the cortex. Don't bend it, and let the end be well above the physeal line. Otherwise, that also can cause little irritation of the perichondrium and can lead to growth arrest. So many times if your end of the nail is too close to the physis, that also can lead to growth arrest. So keep it away and don't bend it, because that bending will cause irritation again on the bursa and can lead to problems and pain. So these are a couple of small points which you have to use and follow in order to have an optimum outcome and prevent complications.
So we've heard now 4 fantastic videos. We started with the trauma session. We started with supracondylar humerus fixation. We moved on to lateral condyle fixation. Now we've had a hip spica application and a TENS nailing. We now move on to the last 2 presentations of the today. We've got Dr. Swapnil Keni, who is going to present, and followed by Dr. Taral, who's going to show us an extra, because there is so much of excitement about this, and the forearm nailing is something which people would love to see, and he is going to show us that. So we'll start with Dr. Swapnil. He'll present the first case and the second case, and then we'll call it a day. In the meanwhile, we are happy to take any questions from anywhere.
Sir, from Jalandhar. हेलो
हाँ प्लीज गो जलंधर से बोलिए. मैं सुनाई दे रहा है, आपका फोटो नहीं आ रहा है लेकिन आपका आवाज सुनाई दे रहा है.
Sir, the last question was that when do we recommend the removal of these TENS nails? Is it 6 weeks or 6 months, or when? Because we were told that we have to flush it with the cortex. Now, if the child grows and the nail goes inside, it falls short. So what is the recommendation? When do we take it out?
Right. So flushes the cortex is not the tip on the cortex. It is the last 1 centimeter of the nail is lying along the cortex. It is not bent at 90 degrees and cause irritation on the soft tissues. So that one so usually, as you asked about the timing of removal, it is usually once the fracture has healed and usually it is earliest would be 6 months, but still I would wait till 9 months to 2 years is any time that you can decide to remove, depending on how prominent the nail is and how easy it is going to be able to remove. We have seen that patients who are lost to follow up, they come after 5 years and then the nail is totally buried in the cortex and there is no tip which is outside the cortex. That is when we will just leave it and we will say that there is no indication to remove unless there is another similar fracture through which you can remove. But otherwise, no point in breaking the cortex and removing it.
Right. So there must be these are titanium. So there is a lot of ingrowth in the bone and it gets integrated very well. So is it very difficult to remove these nails?
Not quite. So if it is, as I said, 9 months to 2 years, it's not that difficult if the tip is visible. And if there's a tense removal plier which is available, which has a slot for hammering it back. So if you just get a grip, like a vice grip onto the tip of the nail and you hammer it, back hammer it, it is actually very easy. You can then the tip can be bent with a hollow mill or your suction tip. You can get a 90-degree bend again. So these are the tips for removal. Then you get a good grip on that edge of the nail and then you can back hammer it again. So these are just the ways in how you can remove it. Yes, removal sometimes can be in even in adult fractures, removal of implant can be more trickier than actually inserting the implant. So
Sir, regarding the material and the implants, whether it should be a titanium or a stainless steel can also be used instead of titanium.
Yeah, and anything can be used. I think you can use K-wires, long K-wires, stainless steel nails, ender nails, titanium nails. Titanium nails has ease of passage. It's easy to pass. Stainless steel nails are hard and it's very difficult to pass and get reduction. So that's the only difference, but really doesn't make any difference.
Thank you.
About removal, I've had maximum experience of difficult removals, and I can share as compared to Chintan, what would you do in difficult elastic nail removal? Because this plier, our experience is that most of the time it doesn't hold to the nail, especially when it's very short. And the instruments, 3 instruments I would use and which will be helpful are as follows. One is a hollow mill. So if you have difficulty in removing an elastic nail, use a hollow mill over the elastic nail. So you create a gap between the bone and loosen up the nail before removing it. Secondly, you can use, of course, this plier, with a vice grip. The third thing, if you really ask me, there is an instrument which is developed by Kshirsagar Surgical, and it's like a pen or a wire bender, but it has threads over it. So what happens is you can thread that instrument over the elastic nail, and it is available from 2 to 5 mm size. So if nothing works, this is my go-to instrument for removing it. And lastly, if nothing works, you try everything and it doesn't come out, then hammer the nail inside more and finish it, so that no one can remove it further.
Can I just add? Yeah, just addition to what everyone said. So what you can do is if you can identify the entry point and visualize the nail on the C-arm, use a 1.5 millimeter K-wire over a drill and make a very small window there. One thing which I always use is even if I'm using an Indian implant, when there is a removal, I always ask for the AO nail removal set, which has a vice grip to which you can attach a back hammer, right? So the vice grip holds the nail very well once you've kind of, dug into it. And a small periosteum elevator will also make some space inside. And once you do that and get a very good hold of the nail, then all you need to do is backhammer the nail. And most of the time it comes out.
Hi, sorry, I had a question. Thank
Yeah, please.
Yeah, thank you, Dr. Doshi, for sharing all the tips. Wonderful presentation. I had a question that if you have a sneaking effect, what do you do then? Intra-op, one during intra-op, and second, if that is during the removal. Two scenarios. Thank you.
Right. So, first of all, is not to have it, and that's why the video presentation and the principles of tense nailing. So, as we said, it has to be gentle rotation movements and never more than 180 degrees. That will actually lead to snaking. But God forbid you had it or someone else had it, and you are doing the removal. So never attempt to only remove one nail and then go on to the other one. There will be a time that one nail will come out partially because of the snaking effect. It will be stuck somewhere in between, won't budge and come out. That time you go to the other nail back, take it out further. That is when it will loosen out a bit, and then alternately try to back hammer both of them, and then usually you should be able to get it. So this does happen sometimes when it is the nail have twisted around itself. So if you are stuck and you are not able to take out the nail, let's say the lateral nail first, then go on to the medial nail, take it out a further, then the lateral nail will become easier to remove because it will make space in that area.
Thank you.
So any further questions on this? Then we move on to the distal radius fractures, and we have Dr. Swapnil Kenny who will be presenting on this.
Very good afternoon to all of you all present here and all the viewers all across India. First and foremost, I would like to thank Dr. Gautam Zaveri and the Bombay Orthopaedic Society for getting this outreach program. Sitting here in Mumbai, we can reach out everywhere and have a wonderful interaction. So kudos to sir. In the 60th year of the Bombay Orthopaedic Society, we are doing something very, very unique, and keep connected to the whole of India from Mumbai itself. I'm going to be speaking about the magic of cantilever reduction in distal radius fractures in children using something called as an intrafocal reduction technique. Now, this is a very common X-ray which comes up usually in the casualty or the next day when you take rounds, when your resident tells you that this is a fracture which is presented. So if there are, people here who would like to give their opinion as to what they would do, or people in the audience who would, like to tell me what they would do. Anybody here? Close reduction. Okay. Anyone else for close reduction? Close reduction pinning? Anybody? No? Very conservative. Open reduction pinning? Yes, Jaideep. Any other modality? So I think Tushar Agarwal is not here. He would have said yes. Having said that, so most of you probably believe that it is going to be close reduction. That's like very, very conservative, and I would agree to it. The only question is, how do you get a close reduction, right? And that is always a challenge in such fractures. Yeah.
It's been proven that children less than 10 years with a reduction like that, where there is no angulation, rotation, we just leave it in a slab and it will heal up and remodel very well.
Completely agree. So, on one side, there is literature which supports us. On the other side, we have apprehensive parents moving around this X-ray with 10 other orthopedic surgeons. And probably 9 out of 10 would have good things to say, but that one particular, very small, sly kind of a remark would make a...
Yeah, so I'll be the 10th one who will put a plaster.
Right. So if you look at the
Just if I have to add, go back to the X-ray. So as Taral rightly said, it's very well within the acceptable limit, but the only problem is maintenance of reduction. Once the swelling subsides, or if your plaster is not good, or if the child doesn't follow up, then many times it gets redisplaced. So this is an unstable variety. So that's one thing. If you're treating conservatively, have a good maintenance follow-up with a good cast, then it's okay. But you have to watch for redisplacement.
Absolutely. And getting X-rays.
Whatever, but so then no question.
Yeah, but despite that, putting a cast and putting it and maintaining this in this particular position with the cast loosening, with the kid moving around is going to be a challenge, right? So we are usually very conservative when it comes to conferences. and when we are in practice, we are a little different. That is very common. Yeah, no, maybe sir is an exception, but most of the people, general orthopedic surgeons, I would say. Right. So now, if you look at the acceptability criteria for distal and radius, especially the distal 1/3 fractures, there has been a wide variation right from 1979 till now, okay, where we went to a large degree of acceptability, then we came down, again we went beyond it. And there are a couple of factors why this happens, and I'll tell you, they basically come from foreign literature. One is most of the papers which come from England tend to conserve fractures because end of the day, the NHS needs to save money. So many a times, a lot of this Western literature is influenced by their decisions made by the NHS. That is one. Second, when a lot of papers come from the US, many a times when you put a pin, all right, then the coding and the billing is different vis-a-vis you do a close reduction. So there are both sides and you need to take each with a pinch of salt. So the treatment is somewhere in between. So this paper came out from the Sick Kids Hospital essentially, which we now follow, is where we accept anything less than 25 degrees of dorsovolar angulation in children less than 10 years and less than 20 degrees in children more than 10 years. As coming to radio-ulnar angulation, it's less than 15 degrees. Axial rotation, ideally you should not have. And in children less than 10 years, up to 1 centimeter of bayonet reduction is acceptable. So essentially what this paper says is that these fractures can be managed conservatively, right? But then why do we pin these fractures? Now there are two big randomized control trials, one coming from England and the second coming from the US. Now, what they did is they compared the outcomes of close reduction versus some sort of a reduction and pinning. So just cast, close reduction and cast versus some sort of a close reduction maneuver and pinning. And what they found is that the risk of loss of reduction was 0% in both the studies where pinning was done, but almost up to 40% in only the cast group. While pin-related complications were also high, but these were minor. So, very, very minor complications which could have easily been tackled. So the clinical outcomes were similar. And end of the day, even if you look at the cost of, taking the patient back in the OR, doing a re-reduction, getting multiple x-rays, vis-a-vis doing a single procedure once and getting the cast out and pulling the pins in the OP, they had similar costs. Now that may not be the same in India, but the way the billing and the coding happens in the US and the UK, it's a little different. So with 40% who are amenable to a redisplacement, it is safer that most centers now prefer a pinning and a cast just as an additional method of stabilizing these fractures. So don't consider it as a surgery, okay? It's one more way of stabilizing a fracture and seeing to it that it remains stable. There is no non-union, no malunion, no loss of reduction, and no functional outcome issues. So again, coming back to this 9.5-year-old patient with this sort of a fracture, this is what it looks like. The radius has gone completely dorsally, is sitting over the ulna, and there are various ways of reducing it. I am going to show you a very simple way. So there are essentially 6 steps to a transfocal reduction and intrafocal pinning. And if you follow these 6 steps, you will get a reduction in most cases. So all you need is a 2.5 to 3 millimeter K-wire, which depends on the size of the child, right? What you need to do is you need to have an assistant give you longitudinal traction so that there is no deviation in the transverse plane, right? Longitudinal traction, the distal part of the radius is aligned to the proximal part of the radius. You forget the overlap for the time being. Get the wire exactly at the fracture site in the middle of the distal radius fragment, which is usually a metaphyseal fragment, right? Slide this pin over the dorsal cortex of the distal fragment. This is your first step. The second step is once you pass this pin, you try and hit the volar cortex of the distal fragment. So you're going obliquely, right? Trying from the dorsal side, feel the dorsal side and try and get inside the volar cortex of the distal fragment. Once you do that, the third stage is called as capture, where you now swivel the wire more proximally and try to capture the spike of the dorsal cortex of the proximal fragment, right? Because they are lying like this. So try and capture this spike. Once you have some sort of a feeling, which is again something which is, you need to have a good amount of dexterity to feel these bones, because it may be easier seen here on the X-ray, but difficult to do it when there are so many soft tissues and so much of swelling. So the next step you do is you try and pass the tip of the pin into the medullary canal of the proximal fragment as much as possible. So what you're trying to do is you're trying to go beneath the dorsal cortex and try to get to the volar cortex of the proximal fragment. Once you do that, now you have a good lever on which you can use a cantilever principle and use this pin to reduce the proximal fragment over the distal fragment. Usually, most of the cases which we either do close reduction or operate, we always get the distal fragment to the proximal fragment. This is one rare instance where you are actually getting the proximal fragment to the distal fragment and do the reduction. Once you do that, you pass your pin through the fracture site into the proximal fragment for temporary stabilization of the fracture. Now this, believe me, is not a very strong fixation. It's like a little bit of a wobbly fixation, but it is a reduction tool which is used for a temporary reduction. You can keep this wire inside, you can remove it, nothing happens. Fracture healing is not a problem at all. So once that is done, then you can pass 2 cross K wires. You can also fix the ulna if you want, and then put this patient in a cast. So if I were to show this to you in an animated format, this is what it would look like. Essentially slide, then hit, then capture, then pass into the distal fragment of the prox, lever it like this, withdraw the pin and fix it. Right? Now, fixation. Now, it is very important that you need to understand the distal radius, right? There have been various studies which study the biomechanical effect of cross K wires versus one-sided K wires going from the lateral side to the medial side. And all these biomechanical studies have shown that cross K wires give a much strong fixation, even if they are the same diameter as 2 wires going from the lateral to the medial side. So you need to try and understand the 3-column concept of the wrist, which is used by the hand surgeons very regularly. So there is a radial column which is in the radius, there is an intermediate column, and there is an ulna column. Out of these 3 columns, if the radius is involved, you need to actually fix the 2 columns by getting hold on them to the proximal shaft. I'm talking about extra-articular fractures. Ideally, they use this concept in the intra-articular fractures. Now, why am I saying that? Because even if we feel that it's a small kid and a small fracture, right? There are 2 very strong muscles which are attached to the distal radius. One is the pronator quadratus and the second is the brachioradialis. The pronator quadratus actually causes volar flexion of this fragment, and the brachioradialis causes a dorsal and a radial displacement of this fragment. So there are a lot of forces which are acting on this fragment, and not everybody is as skilled in giving a cast as a seasoned pediatric orthopedic surgeon. Please remember, if you look at most of the casts which are put by general orthopedic surgeons, they are like banana casts, not very well fitting. So that's again a different day to discuss it out. But you need to understand that if your cast is not good, you're going to lose the reduction because there are these muscle forces which are acting on this fracture. So again, the reduction maneuver, the first step again is to counteract the volar flexion of the distal fragment by longitudinal traction, right? Like what I showed. The second step is to correct the dorsal displacement and radial deviation of the distal fragment by manipulation or cantilever mechanism, whichever you are comfortable with. So this is essentially a bone model. So you go down, be very, very careful, don't go through and through. Get your reduction in place. Once you get your reduction in place, it is time to temporarily stabilize the fracture by putting the transfocal pin across the fracture site like this. So drill it there, be in the center always, you will get a reasonably good reduction. Even after putting this pin, if you feel that there is a little bit of a radial and ulnar sort of a translation, that's okay. You can still correct it while putting the pins, because this is not a very strong fixation, but it keeps the bone there for you to have a very good hold on it when you're putting your pins. The next is rigid fixation of both pillars is extremely mandatory, right? So this is my radial wire, which goes from radial side, that is the lateral side, to the medial side. This is a center wire. What do I mean by center wire? Going from the center of the distal fragment into the center of the proximal fragment, right? Because the radius is nice and big and you have a lot of space here, you can go through this particular fragment center and put a cross wire. At the same time, you can hold a fracture with your wire and also ask somebody to hold the arm. My next wire is my ulna wire. Now there is hardly any space for you to go medial, right? So you have to go anteromedial, right? And come out posterolateral slightly, but don't go this way. So your trajectory is about 30 to 35 degrees. This is a little bit of a difficult wire to put, but with 2 wires stabilizing this fracture, you can take your own time and fix this fragment. So this is the wire which goes from the ulna side. Now with 3 wires, this fracture is very, very well fixed, right? So this is the wire going from the dorsomedial to the volar lateral, but it is not absolutely volar. It is lateral, but a little volar, right? So maybe about 35 degrees, get a good hold of your pin and then pass the pin across. So this is how it will look like eventually. That is the dorsal view where you see the pins, the lateral view where you can see the medial pin coming out, the medial view where you can see the lateral pin coming out, and the volar view where you can see the transfocal pin coming out. So coming to the surgery, actually, how we do the surgery is patient is draped, supine position, the arm is on a fracture table. Many a times if the kid is small, I tend to use the entire table and move the kid outwards if it is a radiolucent table. Again, following the same principles, putting my wire in, getting a cantilever force to reduce it completely. Once I do that, this is the live video which we did. Just withdraw your wire a little, right? Withdraw your wire a little. You've got a reduction. Withdraw your wire a little. And once you withdraw your wire, you can just angulate it a little more and then pass it into the proximal fragment. Now, you may feel that this is a little difficult, but if once you do 2 or 3, anybody and everybody can do it. Like my residents do it very, very well. So this pin goes inside. So this is fixed. Now you can see there is a little bit of a translation, right? So I can actually correct this translation with a little bit of maneuvering and also with my wire. So when my radial wire goes from the lateral side to the medial side, it will actually push the fragment a little more and get me a better reduction. I can also manipulate this fragment and get a better reduction. End of the day, you want a near anatomical reduction where both of the proximal and the distal fragments are well opposed against each other. There is no angulation, no rotation, and very minimal translation is also okay. Right, so this is my first wire, which is going from the radial lateral to the ulna medial side. So this is like what I call as a center wire going from the center of one cortex into the center of the other cortex. Confirm on the C-arm that you have got it perfectly in position, because this is the pillar wire is extremely important. The second wire is the medial wire. Now, one issue which many people have, especially in slightly distal fractures, is the physis, right? But if it is a reasonably metaphyseal fragment, you can still get a good entry. So that is why when you have a transfocal wire fixing, you have adequate amount of time to plan your third wire. Your radial wire will never be a problem. It will only be the medial wire which will be a problem. So this is how you do your fixation, and everything is closed. It doesn't take more than 10 to 15 minutes. Unless, of course, you're doing a live surgery, well, it may take a little more time, many a times. So this is how you get your fixation. And that is the final result. So very simple surgery. And what you need to do is once you put these pins, you need to put this patient in a cast. You can put this patient in a below elbow cast, unlike a distal and radius fracture where you have to use an above elbow cast when you're not putting a pin. And you can start mobilizing the elbow very, very early. right? So I'm again going to recapitulate, which is my last slide here, the steps of the surgery, right? Which are slide, hit, capture, pass, lever, and fix. So, my dear friends, a very simple fracture to reduce and fix, and also gave 100% result, not only on the first day, but eventually. Yes, people may disagree here that, we can wait for it to remodel, it will remodel, it will become fine. But trust me, as a pediatric orthopedic surgeon, you can counsel the parents, but they are still extremely stressed out when it comes to a fracture which has not been reduced. Even in fractures which have been reduced, say with a nail, even if they see the fracture line, they will say the fracture lining is being seen. They are so sensitive about these small issues, right? So again, I would say this is a procedure. It's not a surgery. It gives a 100% guaranteed result, and the outcomes are fantastic. Thank you.
Thank you, Swapnil. That was very, very nice. Any questions from the house over here?
From Jalandhar, sir, the
Slightly demanding technique, you think, Swapnil, or is it actually very simple when you actually go to do it?
I think initially 3-4 cases would be a little demanding, but eventually not that difficult. Once you get a hang of it, you're reasonably senior. It's about getting the feel. It's like putting a pedicle screw. Initially, you will struggle a little getting the anatomical landmarks, but once you're there, then it is a very, very simple technique and very safe, because even if your wire goes volarly, usually you do not get a neurological issue unless you do it multiple times and you have a threaded wire. So see to it that you use a smooth wire, smooth pin rather than a threaded pin.
Sir, in the process while you're doing this, the pass and the capture that you just mentioned. Hello?
Excellent demonstration of telling the cantilever technique. I want to know in which fractures, like you fix the ulna.
Right. So one is, of course, displaced fracture of the ulna. Second is an angulated fracture of the ulna, which is preventing the reduction of the radius. So unless you correct the ulna fracture and the radius is not falling into place. So these are the two indications where I would do it. If the ulna is kind of a buccal fracture or just a green stick, then I can just leave it like that. Many times what I do is, if I find that the ulna is stable, I can put a wire going from the ulna into the radius and just stabilize it. Right? That also gives a good fixation. So, and the ulna heals well. So you need not be anatomical, but you can maintain the length, because as you know, the ulna is very important to maintain the length of the forearm.
If at all you're using a wire in ulna, never never go across the physis, because very high chance of having growth arrest. And that will lead to your radioulnar variance alteration and then eventually a wrist pain. So little translation, everything, it heals well, but never pass a wire across the ulnar physis.
Sir, calling from
Not needed. Most of them, unless they present late, where obviously then you're going to leave them. You're not going to open them. You're going to leave them. But yes, presenting early,
So
definitely.
there is a series of cases presented by Premal with co-authors from other countries. If you open this fracture and fix with wires, that's the only reason this will go into non-union. Yeah. So if you open, then you have to rigidly fix. Opening and then fixing with wire is not good. Yeah. Something better.
Any questions from Gwalior, from Ajmer?
Yes, from Jalandhar.
All right. Thank you very much, Swapnil. As we move on to the last presentation of the day today, before we move on and I give the mic to Taral, I'm just going to take a minute to tell you about Bombay Orthopedic Society. Idhar gaya mera talk. Dr. Gautam. So I will not be going through the entire detailed presentations, but I do want to invite people seated in the audience over here and people from all across India to join us for WIROC 2025. Vyrock 2025 this year is going to be on December 26, 27, 28. It's at the Westin Hotel in Powai. We have a fantastic program lined up for you and some fantastic non-academic programs also lined up for you. In the academics, we've got pre-conference workshops on endoscopic spine, robotic hip and knee, complex elbow and soft tissue reconstruction. We've got some very nice master classes on how to do a CTEV correction casting, negative pressure wound therapy, spica, hand and foot splints, etc. We've got workshops on arthroplasty, orthopedic trauma, shoulder arthroplasty, and a day school in musculoskeletal radiology. Finally, we also have a fantastic thing called as the Robot Studio, the Virtual Reality and Mixed Reality Studio, and an AI lab. Things which are futuristic, which are going to shape orthopedics over the next 10 years. You want to get ahead of the battle? Join us for Vyrock 2025. Also, if this doesn't interest you, the last two things will. On the evening of the 26th December, we have a drone plus fireworks show as a part of our social event. And on the 27th December, we have got a Shankar Mahadevan concert. So for 15,000 bucks, you are getting all these academics, fantastic insight into the future of orthopedics, and of course, these fantastic shows, both the drone plus fireworks show and the Shankar Mahadevan show. Don't miss it. Thank you. Before we end and go for the last presentation, I would like to thank Dr. Binoti Sheth, our convener, our co-conveners, Dr. Chintan Doshi and Dr. Avi Shah, who have done a fantastic job of putting together close to 14 different live or real-life surgeries, plus 15 real-life surgeries. It's an amazing thing. For all of you, this will all be available on our YouTube video channel of the Bombay Spine Orthopedic Society, and it will be available on the Ortho TV network. So you all can always click and see these videos and learn from them at every time. It is our initiative from the Bombay Orthopedic Society to share knowledge, experience, and expertise of all our fantastic faculty with each and every delegate, every orthopedic surgeon across India. So it's a great opportunity. Keep seeing these videos. So I'd like to thank them. I would like to thank all the delegates who are seated here, and I hope that you all have enjoyed the program and learnt a lot. Finally, I would like to thank each and every one of our partnering cities, Jalandhar, Gwalior, Ajmer, Lucknow, Delhi, who have been here since morning. And I hope that you all have enjoyed this show. Thank you very much to the coordinators of the show. And finally, a big thank you to Intas Akila, the sponsor of this event, who have spared no efforts and spent a lot of money to put this program together. Thank you, Intas. You've done a wonderful job. Thank you very much.
And before people start moving after Taral's video, a big round of applause for our Gautam President, Dr. Gautam Zaveri. So this sort of activity has never happened in BOS, and he's trying his very best to reach out to people across India with his innovative ideas. And you see, he's been sitting throughout from morning to now and still sitting to encourage us and, guide us and make us more active. Thank you so much, sir. So next, last but not the least, we always keep the best one at the last so that people still get glued to the place and then carry forward good memories. So Taral, yeah.
So we'll have two short videos. So one thing which was not covered in the morning was close reduction for DDH and arthrogram and spike. Now, we did see an open surgery, but something which is easier to do is a close reduction. So this is a video made by me and Jaideep, short video, but has all the essentials for a successful treatment. So we have a 9-month-old child with right DDH. You can see all the clinical signs, shortening, restricted abduction, and no doubt that, clinically also this looks like DDH telescoping test was positive. It has to be done under general anesthesia in operation theater. Okay. And the first step is always a close reduction. And how do you do close reduction? Is by pulling it, traction, abduction, and what is important, you can see my other arm giving lateral push over the trochanter. And check this under image intensifier. Most of the time, the femoral head will be absent or very small, and that doesn't tell you about a concentric reduction. So we need to do an arthrogram. And this is how you'll do an arthrogram. To cover the private parts, this is how I do it, so that the plaster or the cleaning materials don't go. I make 3 syringes, one with air, one with water, and one with arthrogram. Arthrogram is done with 5 ml of iohexol diluted 50%. This is the entry point, medial side. You mark the adductor tendon and go from medial side. I use a 16 number needle, long one, 1.5 inch needle. Older children may require a spinal needle, especially if the child is chubby. First, I inject air, and when you inject air, you can see the shadow, and then you are sure that your needle is in the joint. You have to inform the anesthetist that injecting air. The second is injecting saline. Each one has different purpose. When you inject saline, it comes back with the force. Then you know it's in the joint. And second thing which happens is the hip flexes. So these are just confirmatory tests before you put your dye, and then finally you put dye, and then you take a check X-ray. You don't inject too much dye. Inject slowly. 2 to 3 cc. And as you're injecting, you take a live shoot, and then you get a visualization of the head. You realize suddenly the head is so large as compared to what you see on the X-ray. And then, you go on to close reduction. So here I'm giving traction, abduction, and pushing. And then I got a close reduction, and then I'm assessing, is my close reduction good enough? 2 ways to assess. One is seeing a static image. Static image, medial dye pulling was less than 2 mm. More important is dynamic assessment by Ramsay's zone. So here, maximum abduction you could give is 50, and at 15 degree abduction it dislocated. So safe zone was narrow. So I widened the safe zone by doing a adductor release using the same needle. So now the abduction possible was almost 70 to 80 degrees. So now you have a wide safe zone, and the position of the hip in spica will be the center point of this safe zone. So if you had a dislocation at 15 degree abduction and maximum abduction is 70, then around 50 is the position where you should give a spica. So this is how you see statically medial dye pulling of 2 mm. You see the rostron appearance of the labrum. You can also see the acetabulum, how deep it is. Now it's a time to give spica. After doing the reduction, you require again, 2 people to do it well. This is what we use: soft rolls, stockinette, and fiberglass plaster. I don't use POP plasters any longer. We use arm board, the same arm board which Chintan showed you, multi-purpose. You can use it for so many things. So first step is to, put stockinette. This is a wide stockinette, which is used for a fat person undergoing a THR. So this is the 20 size stockinette they will use. So you put it around the trunk, very useful. Stockinette makes the child's life easy. You put a towel here so that you don't get compression of the abdomen. So 2 towels which are folded. They will also protect the private parts and the perineum. Then 2 stockinettes. These are small ones, 7.5 mm for the lower limb. So over the affected hip, you will put full, and the other side you will put half. The right and the left stockinette you join in middle with help of a towel clip or you can use a paper tape, and then you put very generously you should put soft roll. You use at least 3 soft rolls for a 1.5-inch spica. And then you will roll the stockinette over that, because you want the edges of the spica to be very smooth. And child should be very comfortable. That's very important. The person, there are 2 people here, one applying the plaster and one holding the reduction. Naturally, one holding the reduction is more important than one who's applying the spica. Okay, so this is how you roll your stockinette. This is a master class Gautam in spica application. I think everyone should see this video again and again. It is available on Indian Orthopedic Association's journal, IOA journal. This has been submitted, accepted for publication. So this is the first plaster. You need 3 plaster. First plaster starts from the affected side, then goes on to the trunk. Okay, you're going as a figure of 8 around the hip joint, and then you go on the other side. So that's the first plaster. The number of plasters don't determine the strength of the spica. It is how you apply it will make it stronger. A plaster who is light plaster but applied properly can be stronger than a heavy plaster. Okay, so this, you will realize that these folds, over the groins, which I have folded them so that they become stronger. So this is the way you can, have a light plaster. You can cut these and, make them to be confirmatory. It's very important that the knee, the plaster should not be tight. I've been very gentle around the knee molding. Now it's a time to make slabs. This is how I make it. I will make at least 15-inch long slabs, 3 turns. Okay, and then I use them in a Y-shaped fashion around the hip. This is very important. So this will prevent breakage of spica. If this is applied well, you don't even need to connect the 2 sides of the spica with a wooden bar. So this is the second plaster. Though we are not gender biased, generally the parents do like pink for a girl and blue for a boy, but always we ask the parents, what color would you like? And they sometimes come with surprises. So if they want a change of color, it's very simple. You apply the color of choice on top. So if the reduction is stable, I don't include the ankle joint. If I'm not sure about the stability of reduction, if the child is too loose jointed, then I will also include foot in the spica. So whether to include or no is your choice. You can see that stockinette in the perineal area I have still kept intact. I have not rolled it over because I roll it after giving the spica. This is the area, which has to remain dry. And as Jaideep has explained, we put 2 diapers, one inside and one outside. It's very important that the spica is managed well, because if the child soaks the spica and if you have to remove it for any reason, it's going to cause a lot of issues and complications. So you check everywhere. You check top of the trunk part, the bottom of the trunk part. You even go behind and, like a car mechanic, look at the posterior part, because you don't want it poking into the skin behind. Many times we will put a sponge posteriorly between the stockinette and the skin to give luxury feeling. We call it as luxury spica because that will give a good cushioning effect. So this is the time you will take a final check X-ray again to make sure that your hip is well reduced. The dye, there are 2 choices. Urographin remains there for around 5 to 10 minutes, but if you put this iohexol, it remains for 2 hours. And even if you were to do a CT scan post-op, it would be seen. So I prefer iohexol. Many times we would do a post-reduction MRI the next day to confirm that the hip is inside and it is centric. I change plaster 2 more times at end of 1 month and 2 months. and then use brace for 3 months. So that's the protocol post-op. So that was about close reduction of hip. And then quickly we go on to the next video, which is about close reduction and elastic nail for radius ulnar fracture. I conserve most of my नहीं हे नहीं वो एक single slide होती है ना.
Just a question,
Radius
Taral.
ulnar, yeah.
How much abduction? Because that's in order to prevent
drive होता है ना.
AVN, how much abduction
One
maximum you
pen
can?
drive. Yeah. How much?
Abduction is safe to give.
Not more than 70. So 70 is maximum abduction you can give, but it doesn't mean that you give 70 abduction. If the 70 is maximum abduction beyond which you will get AVN, and 15 degree in this case was
Safe
minimum abduction beyond which you will get dislocation. So middle of this should be your position. Now what happens is we are all using this arm bolt. When you remove the arm bolt, the trunk sags. So if I want 50 degree abduction finally, when I'm giving the spica, I will give 70 abduction so that when the trunk sags, it becomes 50. If I give 50 to start with, then it will become 30 and then it may dislocate. So, these are small important points. Yeah. So I will show the next video, which is, this was again made in 1915 or 16, but when I was still working at SCFE hospital, it works well. 2007, yeah, way back. So forearm fracture, this was a puncture compound. Child had a lot of swelling, and we initially gave a slab. So this patient again could be treated with a close reduction, but an older child, 11-year-old child with this, we would do an elastic tape. Just showing the position, we are using this lateral support for counter traction. So that when you give traction, there is a counter traction. And you measure the length of the nails. So radius ulna is different than femur. Femur, you have just one bone. Radius ulna, there are two bones. So what you do is you take the fracture site and you should have maximum separation at fracture site. And how much separation? Double the interosseous space, not 3 times. So that is how it will work. For radius, I still prefer dorsal approach. There are a lot of people who do radial approach, but I do take a small dorsal approach. I will cut skin, subcutaneous tissue and the fascia, and then you actually see tendons and then retract those tendons and then use a drill sleeve to make this hole. If you don't do this, there are chances that the nail which you pass may go through the tendon and there can be incidence of EPL rupture. So now you select a nail, it will be around 2 or 2.5 mm nail, thin one, and then slowly you go till the fracture site. Don't hammer, use rocking motions. So no rotatory motions, no hammering, use rocking motions and go till the fracture site. And then use the bend of the nail to reduce. So here I will use 3 things: manual pressure. You can see my thumb is reducing the bone. You can use F tool. You can use towels, 2 towels in opposite direction and compress it to cause reduction. You can use K wires to cause reduction. Many ways you can do a K wiring for reduction. And then pass the nail. This is ulna. Ulna, I don't go proximal to distal. I go distal to proximal. You also have to be careful about the dorsal branch of the ulnar now. So you don't want to cause hypostasia there. Ulna nail, you have to make a generous opening because distal end of ulna is very thin. Sometimes you use a thinner nail, 2 mm for ulna and 2.5 for radius. So I am putting a distal nail into ulna, saving the physis. Once you pass your radius nail, ulna nail is generally easy, but sometimes it can be difficult. And the chances of opening ulna, according to me, are more than opening radius. When you open ulna, it takes a very long time to heal. It may take sometime 2-3 months to heal, but don't be in a hurry to do plating and bone grafting. It will eventually heal up. So this is how the nails have been passed. The final thing is cutting the nail. And Gautam, what we do is before cutting the nail, I will make the end of the nail serrated so that it's easier for anybody, whether I am removing the nail or this patient from UK. If some NHS doctor was to remove this nail in UK, we want to make life easy for him. So we use this thing which keeps the nail proud by around 1 centimeter. It's not flush with the bone. You cannot make it flush with the bone. It will stay out by 1 centimeter so that your removal is easier. So we put the patient in a slab or a brace. We don't give a plaster most of the time if it's stable. And then most of the time after 3 or 4 weeks, they don't even need plaster. They become stable enough. And then sports activities, this patient, he was a cricket player, and we allowed it after 3 months, not before that, because refractures can happen even with nails in place. Okay, just because the fracture is united and nail is in place, it's no guarantee that refractures won't happen. So till 3 months, we don't allow any sport activities. After that, 6 months, I ask them to use a brace if they want to play sports, either football or cricket. So this was about radius ulnar nail. I think we've ended with 2 brilliant pieces of desserts, mango ice cream and laddus, yeah. Should we end with this?
Any questions for the
last 2 talks, yeah.
Cast and the radius ulnar nailing?
While changing the
Yeah. I give half plaster. Most of the time, I will assess the stability and I give above knee spica. We keep the knee free that time.
Any change of
Angle, yes.
Yeah.
So I will assess the stability. By that time, it will not dislocate at 15-degree abduction. It will allow me that. So, I will give it at around 40,
So
90-degree flexion, around 45-degree abduction, so that child can be made to sit.
Yes.
Yeah.
Thank you.
Yeah, any questions? Ajmer, we are closing for today. Any last comments? Any comments? Any questions? Please ask them to unmute. And Ajmer, please unmute and say any questions for our eminent panelists. Lucknow. Yeah, again, ask your people to unmute Lucknow. Yeah, go on. Lucknow. No, I can't hear you.
Yeah, sir. Now
No,
can
we
you-
can't hear you.
Hello. Hello. Can you hear me?
Hello, Lucknow, please.
Yes. Hello, sir, from Ajmer. This is Dr. Nitin from Ajmer. Sir, it is a very.
इधर से बंद है.
Hello, you can hear me, sir?
Hello.
No, we can't hear you, Lucknow. We can't hear you.
Type in the chat box.
Hello.
Yeah, now we can hear you. Go on.
Yes, sir. It was a very nice presentation, a very nice conference, sir. I just like to ask 2 questions from the last presentation. One regarding the entry point for the distal ulna. Sir is showing the entry from the distal to proximal while fixing for the ulna. Is there preference? Because usually we used to practice from going from the proximal to distal. And if we are using the distal to ulna, then it is following to be in the every fracture pattern, or is there some specific indication?
Yeah, a good question. So I was, as a resident, we were taught always proximal nailing, and Gautam, we used to do Talwalkar's nail, even in adults, proximal to distal. The problem with proximal to distal nailing is that proximal part of the ulna is wide and the distal is narrow. So, you can get a wider nail proximally and distally it gets stuck. So with a elastic nail, what happens is for a 2 mm elastic nail, actually the working diameter is 2.5 because the tip is bent and you get stuck many times. Distally, it's easier because you're starting from a narrow zone and to go into a wide zone and have your tip, getting stabilized is easy. Second thing is if you're going proximal to distal, it's very difficult to take an X-ray because, your positions are awkward and you're passing a nail and you cannot straighten the elbow and take a true AP. So distal to proximal has worked for me. I saw this for the first time in 2020 when I went to San Antonio to observe Dr. K. Wilkins. And he used to put all the nails distal to proximal. And I asked him the same question you asked me today. And I'm sure when you demonstrate this to others, people will ask you the same question and you will be able to answer. It's easier. It is safer. You have to take a dorsal incision so that the nerve can be seen and be protected. Dorsal incision over lower end of ulna.
What is the exact point of entry he is asking? Lower end
entry is 1.5 centimeter above the physis because you're going to leave 1 centimeter of the nail outside. and you don't want the tip of the nail touching the physis. So the point of entry and which fracture, the mid shaft fractures are or upper fractures are good for this. If I have a montagia, then I will do proximal to distal nail. If I have very distal radius ulna, then nailing is very difficult. In that case, either wiring or external fixator, these are better ideas. So mid shaft radius ulna are the best indications for radius ulna nails.
Let's move to Ajmer. Ajmer, any last questions? Any comments?
No questions, sir, but the presentations were
Hello.
very, and it was a brush up of the previous knowledge and new techniques and acknowledgement from the very eminent faculty which have spared their time for presentations and the real life surgeries. We'll hope that BOS will continue with the spine and all that also, these real life surgeries or something like that.
Yeah, we will surely next year. Yeah.
Thank
Great. Thank you very much and have a great Sunday evening. Let me not rob you from your way, keep you away from your family. Gwalior, Rajneesh. Thank you very much, Rajneesh and team.
Thank you so much, sir. Thank you very much, sir. It was wonderful presentation, and our Gwalior Medical College team has also come as a chief guest today's session, and president of Gwalior Orthopaedic Society is also here. So almost 30 guests are there.
Oh, very nice. Thank you very much. Thank you. Very happy with all the arrangements everywhere. Thank you, Jalandhar. And thanks to each one of the faculty and the delegates in Bombay. See you soon. Let's have a photo. Photo निकालना यार हम लोग का सबका पहले फैकल्टी का आ जाओ और फैकल्टी और डेलीगेट सबका साथ Ashish
All delegates after this can also be very small. Excuse me, like off like you. Off
Everyone can come. Everybody join. अरे ये फोटो भेजते हैं
There are extra CME points for those who visit in there.
All of them. Yeah, numbers are more than the number of delegates. Second layer one. Thank you. Thank you. The dedication of a faculty. I have never seen any so much involved in this work. I hope it will continue. Difficult for next. Chalo, we'll see. I don't want to say that. If we have at least